as a organizing chairman, I would like to welcome you all to kick-start this spectacular week of academic extravaganza for 65th IOACON 2020 and scientific meeting of IOA going to be held at Jaipur from 5th to 7th March. Friend, it is a matter of great pleasure to me indeed to endorse the academic in spine surgery, an integral part of academic education in the field of orthopedic. We are pleased to serve as parent body and provide needful assistance to carry out series of education program in association with ASSI. The Supreme Spine Super Specialty Body of India, we as parent body of IOA in India are happy to endorse and give backup, mean to bring academic excellence to the member of IOA and one and everyone of the country who seek or desire to be trained under aegis of IOA in spine care. I must congratulate past President Dr. H.S. Chabra, Dr. Jhaveri, Dr. Vishal Kundanani, Samir Dalvi, who did a lot and started this program with the IOA as a joint venture, and I hope Dr. Shankaracharya and his cabinet will continue it for the benefit of future generation in the coming time. In the last, I shall not forget to thank those who are not on the screen and delegates and the viewers, those who are visiting this program, viewing this program from the country, out of country and abroad. And I thanks Dr. Vishal Kundanani and his team under the aegis of ASSI. Dr. Shankaracharya and his secretary did a lot of work to bring this program in this final stage, who will benefit definitely the members of the IOA and ASSI in their academic knowledge. This is the need of our in time of pandemic and shall be of use to all operating and treating surgeon of the India in the field of spine and orthopedics. All the best. Long live IOA and long live ASSI. Thank you very much, friend. In the last, I would like to invite you all, apart from this virtual workshop on 27-28 February, which is going to be 2 days after or today, I will request you all to join the IOACON 2020 from 5th to 7th March. I am sure you will definitely enlarge, you will definitely learn something more from this coming academic event. All the best. Thank you. Take care of your life and family.
Thank you, Dr. Meena. Now, Dr. Shankaracharya, the ASSI President, will give us the welcome address.
Good morning and welcome to this 2 days workshop in spine surgery. I, Dr. Shankaracharya, on behalf
Sir, picture is not clear, picture is not visible.
To this virtual live
Sanjay,
picture is not visible.
Yes, sir.
and welcome to this 2 days workshop in spine surgery.
Sanjay, set the picture.
On behalf
Yes, sir. Dr. Meena, this is Dr. Kamran. Morning.
Good morning, sir.
Morning, sir.
Good morning
Yes.
and welcome to this 2 days workshop in spine surgery. I, Dr. Shankaracharya, on behalf of the Association of Spine Surgeons of India, welcome you all to this virtual live workshop. It has always been our privilege and practice to participate in all the events that the Indian Orthopaedic Association conducts. I thank Dr. R.C. Meena, past President, Indian Orthopaedic Association, and the executive members of the association for inviting us to participate in this hybrid conference. In this 2 days workshop, we have basic and advanced courses, and I hope all the delegates will be able to take tips and tricks back home so that they are able to conduct safe spine surgery. Keeping patient care and doing excellent spine work has always been the motto of the Association of Spine Surgeons of India, including promoting education and research. And keeping this in mind, we are happy to participate in this mini 65th IOACON. I welcome you all, and I hope you have a great weekend of learning. Thank you very much.
Thank you, sir.
Thank you, sir. Our today's conveners for the course will be Dr. Appaji Krishnan and Dr. Gururaj. We will start our basic spine workshop. I would now like to hand over our proceedings to Dr. Gururaj Sangopinath to introduce us to the basic spine course.
Good morning, all. At the outset, I would like to thank Dr. R.C. Meena and his team and ASSI for giving us this opportunity. And for this weekend, we have a very well-packed scientific program. Today, we have a basic spine workshop, and tomorrow we are going to have an advanced spine workshop. So we have tried to cover almost everything, the format is mainly video lectures, and the lectures are going to be for 15 minutes and 5 minutes discussion is going to be there. And we have tried to make sure that the lectures are for 10 to 12 minutes, and then we get more time for discussion so that delegates can ask questions and clarify their doubts, and it remains more interactive, because what happens in this online programs that it becomes more didactic thing. So that's why we have tried to make it very interactive. So your faculties are there in this platform. So their videos will be played initially for 10 to 12 minutes. And then meanwhile, you can have questions in the Q&A box, and or you can have those questions asked. And then I will take those questions to the consult faculties. So all the best, everyone, and happy learning today. Thank you. So that I think we will start with the first presentation, that is Dr. Ravish Patel. Sanjay, can we have Dr. Ravish Patel's presentation? Yes. He is going to talk on spinal MRI, what every orthopedic surgeon must know. Sanjay?
Good morning, everybody. Let me start my today's talk with this clinical scenario. A 45-year-old female who had difficulty in walking and significant lower limb pain came to my clinic with this lumbar spine MRI, and she was awaiting a lumbar spine surgery. When I examined her, I realized that she had significant upper motor neuron signs. So I sent her back for a screening MRI, which showed she had significant compression in cervical spine also, and this also required surgery. This would have been missed without a proper clinical evaluation. And the first message that I would like to give you all is a proper clinical evaluation is must before you consider spine MRI. Another clinical scenario. 70-year male having back pain for a year, and he started developing lower limb weakness. So he got this MRI at some remote center in India, where the radiologist said that infection is more likely and neoplasm is less likely. So without taking any biopsy, the treating surgeon put him on anti-tuberculosis treatment. His condition kept on worsening, and when he came to us, he was having cauda equina syndrome, and we had to operate him on emergency basis, and the biopsy that we sent intraoperatively showed a synovial cell sarcoma. This would have been picked up earlier, provided he would have undergone a biopsy at appropriate time. So MRI is a tool that can help you to reach diagnosis, provided you use it properly along with other investigations and a thorough clinical evaluation. So with this, let me start my today's talk on spinal MRI, what every orthopedic surgeon must know. Decoding spine MRI doesn't mean reading an MRI report. It actually means trying to correlate your clinically significant finding with that of radiological findings. There are three main views of spine MRI. The first is the sagittal view, where we look at the spine from the side. Second is the axial view, which is basically a cut section view of the spine. And the third is the coronal view, where we visualize the spine from the front. There are two important sequences of spine MRI, T2 weighted sequence and T1 weighted sequence. And in special circumstances, we do use a fat suppressed sterile sequence, post contrast gadolinium enhanced sequence, or a diffusion weighted sequence. When we talk about the two main sequences, the striking difference is how the water containing tissues are visualized. So on T1 weighted image, higher the water content, the signal will be hypo-intense or dull in intensity, whereas in T2 weighted image, higher the water content, brighter will be the signal. So on the left hand side, you can see a T1 weighted image where the CSF is dull in color, whereas on the right hand side, you can see a T2 weighted image where CSF is white in color. The first MRI film that we should see is a screening MRI. And one should make a habit of ordering a screening MRI whenever they are ordering an MRI of a particular region. This will prevent missing any pathologies above or below the region of interest. So on screening MRI, which is a T2 weighted sagittal image, you can see the lower portion of brain, cervical spine, thoracic spine, lumbar spine, and sacrum. There are 2 points to note here. First, the counting is always done from the top in an MRI. And second, the spinal cord usually ends at the lower border of L. It is not necessary that everybody will have same number of lumbar vertebrae. Sometimes there can be a 4 lumbar vertebrae with the 5th vertebra being sacralized, or it has already become a part of sacrum. And sometimes the first sacral vertebrae may be lumbarized, giving rise to 6 lumbar vertebrae. Now it is important to note, because on X-ray or on an intraoperative fluoroscopy image, we do counting from the bottom, whereas in MRI, we start counting from the top. So the last mobile segment, which is usually alpha S1 for a fluoroscopy or an X-ray, may be actually L4-5 on MRI in case of sacralized L5, or S1, S2 in case of a lumbarized S1. And one should be aware of this variation, otherwise wrong surgeries can eventually happen. When we visualize the T2 weighted sagittal image, apart from the bright CSF, the other structures that we can see include the intermediate intensity of the vertebral body, the disc, which are bright in color when they are hydrated, and it becomes dull in color when they degenerate or when they are dehydrated. T2 weighted paracerebral cut can give a good information of the foraminal structures. And on T2 weighted axial image, you can see the dural sac and the spinal cord in case of cervical dorsal spine, whereas the nerve roots can be seen in the lumbar spine. The structure anterior to the dural sac is the disc, whereas the structure posterior to the dural sac are the facet joints. You can also see the traversing and the exiting nerve root at different cervical and the lumbar spinal levels, and any compression on this traversing or the exiting nerve root can be very well visualized on MRI T2 weighted axial image. So the common pathologies that we see on T2 weighted axial sequence include the degenerative pathologies. You can see a disc degeneration, which is characterized by a black disc. You can see an annular tear, which is a hyperintense zone in the posterior aspect of the intervertebral disc. You can identify a contained herniation, where the disc has not crossed or traverse the PLL, you can also identify a disc protrusion or an extruded or sequestrated disc on a T2 weighted sagittal image. On T2 weighted axial image, the posterior surface of the disc is usually concave, and when it loses its concavity and becomes convex, it is usually reported as disc bulge, which may or may not be of clinical significance. Clinically significant findings include a central disc herniation, a paracentral herniation, a foraminal herniation, or an extraforaminal herniation. Apart from disc pathologies, even the stenosis, one of the degenerative changes giving rise to a claudication, can also be identified on an MRI. So on the left hand side, you can see the dural sac and the nerve roots lying freely, whereas on the right hand side, because of the herniated disc, the flavum hypertrophy, there is a significant compression and clumping of the nerve roots, which can be visualized on a T2 weighted axial and sagittal image. You can also differentiate between the two common types of spondylolisthesis, that is the lytic and degenerative listhesis. So in lytic listhesis, there is usually a past defect, but there is no signs of degeneration. So the canal is wide, whereas in degenerative listhesis, you can see flavum hypertrophy, disc herniation giving rise to a significant canal stenosis. So the canal of lytic listhesis is wide, whereas in degenerative listhesis, it is narrow, or in some cases, it may be completely obliterated. If you look at the facet in case of degenerative listhesis, they are arthritic, they show osteophytes, whereas in lytic listhesis, the facet joints are usually spared, but on the paracentral cut, you can see a pars defect and a foraminal stenosis, which is characteristic of lytic listhesis. Similar to lumbar spine, you can also identify the causes of cervical stenosis, be it cervical disc osteophyte or an ossified ligament complex. MRI has a special role in spine trauma. If you look at this X-ray, you can definitely identify fracture dislocation. But what this X-ray would tell you is, why is this patient having neurological deficit? And that answer can only be provided by an MRI, where you can see a significant bony piece compressing on the spinal nerve roots. Apart from this, it is important to identify ligamentous injury for fracture classification and for subsequent treatment. And sometimes the herniation or an hematoma post-trauma may be the cause of neurological deficit, and that can only be identified on a spine MRI. In certain cases, the patient may have a pre-existing stenosis, which due to a whiplash injury, the patient may develop cord damage and cord edema. And these are the findings can only be shown on an MRI, because X-ray or CT scan of such patients will be absolutely normal. Moving forward, these are the T1 weighted images. You can see the majority of the structures are dull in color, except the vertebral body, which is of intermediate intensity. And another important use of T1 weighted paracellal image is visualization of the foraminal structures. Because of the hypointense structures, the foramen is very well demarcated, and any foraminal stenosis compression can be very well visualized on T1 weighted images. T1 weighted axial images, again, the majority of structures are dull in color, and so it is seldom of any benefit in routine practice for diagnostic purpose. T1 weighted sequences are important when we are looking at marrow invasion. So usually the bright or intermediate intensity signal of the vertebral body is because of fatty marrow. So when it is replaced by an infection, it becomes dull in color. When it is replaced by a tumor invasion, it becomes dull in color. And when it is replaced by an edema fluid, it becomes dull in color. So yes, many times the differentiation between these three can only best be done with the help of a biopsy, but the invasion of the marrow tissue is the first sign, and maybe the earliest sign in case of an infection, trauma, or a tumor. Sometimes we do utilize stir sequences, which are basically fat suppressed sequences, and you can see this is T2 weighted sagittal image, The stir basically is similar to intubated image, except the fat component is suppressed. And so this is a very good sequence for visualization of fluid, especially in case of an infection or any cystic collection in and around the spinal cord. It is also important for differentiating new and old osteoporotic fractures. So you can see this patient having multiple osteoporotic fractures, and on the right hand side you can see there is a hyperintense signal in the vertebral bodies marked with red arrow, which indicate that these are recent fractures, whereas the vertebral body marked with white is hypointense, indicating that it is a old fracture. Sometimes we do go for a post-contrast sequence. The contrast is injected intravenously, and it is very important for identifying vascular structures. So suppose if a patient is having post-operative pain and you want to differentiate a recurrent disc from an epidural scarring, contrast sequences are very important because epidural scarring, they won't show any hyperintense signal, whereas a recurrent disc herniation, because of the inflammation, will show peripheral enhancement around the reherniated portion of the disc. Similarly, abscess cavity will be hypointense, but the peripheral tissue around the abscess will be hyperintense in a post-contrast sequence, whereas in case of tumor, there will be uniform hyperintense signal. And similarly, granuloma also show a hyperintense signal on post-contrast sequences. There are certain drawbacks of spine MRI. Spine MRI may not always identify instability. There are certain predictors, which indicate that there might be an instability, but it cannot establish that this patient is having an instability or a listhesis. So I'll give you some examples. So sometimes a mild listhesis can give a clue that the patient may have some instability. A wet facet, fluid in the facet more than 3 millimeter, or arthritic or subluxated facet, this can definitely predict. But there are instances like in this, you can see the MRI shows normal degenerative changes without any lysis or listhesis. But when we did flexion extension view, you can see there is a significant forward and backward listhesis, which could have been easily missed on a spine MRI. Second is, not all things that you see on spine MRI is important. On the left hand side, you can see a patient with a large disc herniation, and on the right hand side, you can see a patient with small disc herniation. So in spite of having the large disc, the patient was asymptomatic, whereas on the right hand side, in spite of having a small disc, this patient was symptomatic because it was directly hitting on the normal. So the take home message that I would like to give you all is always correlate MRI with the clinical picture. Second, always ask for screening of whole spine whenever you are going for a detailed study of the affected region. Third, T2 weighted images are the key images for evaluation of most of the spine pathologies. And fourth, T1 weighted images are useful for infection, tumor, and trauma evaluation. Thank you.
Gururaj, you are muted. Gururaj, you are muted. Please unmute yourself.
Thank you, Dr. Ravish. Sanjay, meanwhile, you can load the next presenter's talk and just keep it ready so that I will ask you when to start it. So are there any questions for Dr. Ravish from the panelists? So Dr. Ravish, I would, Kamran, yeah, go ahead.
Ravish, when would you, get a CT scan as well done? If you have only the MRI picture, are there some cases in which you would like to get a CT scan done as well?
Good morning, everybody. That's a very good question. Yes, there are certain instances where we would like to do a CT scan along with an MRI. So I'll start with the common ones first. First is in case of a trauma, where we are considering fixation, where we are considering a surgery, or where we are planning for intervention. So in those cases, so CT scan can give a better idea of a bony architecture, bony morphology or fracture morphology than an MRI. So in that case, I'll get a CT scan. Second is in case of a hypertrophied posterior longitudinal ligament, where I want to differentiate whether it is ossified or whether it is not ossified. So that will also, especially in cervical spine, that will change my plan, whether should I go anterior, posterior, and how to deal with it. So that is the case. The third is in certain cases of tumor, for example, in case of an osteoid. So in those cases, I think additional CT scan will help.
Thank you.
Uh,
Very good. Thanks.
Dr. Ravish, can you just comment on a load-bearing MRI?
Yes, so I think load-bearing MRI is important for identification of any subtle instability or changes that are occurring in spine, along with load-bearing. For example, if you want to enhance listhesis or any instability that can be identified on load-bearing MRI. Sometimes we do flexion extension MRIs also in case of cervical spine, when we want to see what are the changes of the spinal cord that are occurring in different positions. But as I would like to say that there are only very few centers where these are performed. So I think one should be aware before ordering such MRI.
Thank you, Dr. Ravish. My co-convener, Dr. Appaji Krishnan, is here. Dr. Appaji, do you have any questions, please?
As such, no, not he has covered very well all the points during MRI. Major thing is if you cut corners doing MRI, like most of the times you will send for a cheaper MRI, you'll get a T1 or a T2 weighted picture, and you'll not have a comprehensive diagnosis in hand. You should get all the cuts. That's the point which we have to make. One more thing is in the contrast, I would like to ask the speaker, I mean, what type of contrast, and is there a flow sequence which is also necessary to differentiate infection and tumors?
Yeah, thank you very much for the question. So normally we go for a gadolinium enhancement, so that is injected intravenously, and it is very important to take the images at an appropriate time, where we get a sequence, the arterial sequence, and sometimes we do go for venous sequences also. So in case of an infection, especially when there is an abscess, the abscess cavity won't light up, whereas there will be peripheral enhancement. Whereas in case of tumors, there will be uniform enhancement because of the dye contrast material. And usually, in case of a tumor, usually in the arterial as well as the venous phase, the tumor will light up in both the phases, especially in tumors like hemangioma, cavernous hemangioma, or other kind of hemangioblastomas, where there will be a uniform enhancement in the arterial as well as the venous phase.
Yeah, thank you. That was a question. Differentiate between infection and tumors. I think the main point is to get all the sequences rather than rely on a single sequence to do, and also all the stir images if possible to differentiate between fatty infiltration and edema. I think you brought out all the points well. Yeah, Guru.
Yeah, thank you, Dr. Appaji. Thank you, Dr. Ravish. So we'll move on to the next speaker, Dr. Gurdeep Das. So he's going to talk on imaging in degenerative lumbar spine. Sanjay, can you?
Respected Chairperson, Senior Faculty, dear delegates, I have been asked to speak on imaging of the degenerated lumbar spine. And my sequence of presentation will be, I'll be talking about the various imaging modalities available to us, and then I will discuss about the common spinal pathologies that are diagnosed on plain X-rays, MRI, and then I will discuss about the indications and need for CT scan in special situations. The three imaging modalities that are available to us are plain radiographs, MRI, and rarely we use the CT scan. Plain radiographs are the workhorse investigation that we use in our day-to-day practice. This includes an AP view and the lateral view of the lumbosacral spine. The first question that comes to our mind is, in this age of MRI, is there a need for plain radiographs? I will illustrate this example. This was one of our patients who had L4-5 stenosis, and we had planned for L4-5 decompression plus minus instrumentation. And then when we got the X-rays, we realized that there was a lysis sitting just below our L4-5 level, and this changed the complete treatment plan. So it is essential that we give and we get an X-ray of the lumbosacral spine in spite of having an MRI. The various pathologies that are commonly seen in the plain radiographs include a spondylolysis with listhesis, or degenerative listhesis. I am not going to discuss about these common pathologies. Some of the uncommon pathologies that we see in our practice is what is called as a vacuum phenomenon. This is a dark shadow that is seen in the disc space. This is a hallmark of advanced disc degeneration, and it happens due to nitrogen accumulation within the disc space. This is usually associated with segmental instability, and often when you find this vacuum disc, the disc affected level needs to be stabilized or fused. Lumbosacral transitional vertebra is another commonly found pathology. The prevalence is around 4 to 8%, and it is a common cause of low back pain in young adults. It is actually not in pathology, but a variation in the morphology of L5 and sacral vertebra. Castelvi et al. Gave a classification from type 1 to type 4, describing the various types. In the type 1, there is a hypertrophic transverse process of L5, and in type 4, the L5 and S1 are fused to each other with the transverse processes. And this condition, in which there is back pain in addition to lumbosacral transitional vertebra, is called as Bertolotti syndrome. In addition to the routine radiographs that we advise in our day-to-day practice, sometimes we need dynamic X-rays. This is basically an flexion and extension X-ray, and this can be done in standing position, sitting position, or in lateral decubitus position. The problems that we see on this dynamic X-ray is called the insertal instability, and this may be in the form of sagittal translation or angular instability. In addition to the segmental instability, we also need to assess the spinopelvic parameters. The three common parameters that we assess in our routine practice is the pelvic incidence, the pelvic tilt, and the sacral slope. The basic question that comes to our mind is, why do we need to measure these complex angular parameters for our degenerative pathologies? Various studies have shown that patients who have altered or increased pelvic incidence and pelvic tilt have a higher incidence of low back pain, and patients who have higher level of pelvic incidence and pelvic tilt have a generally poor outcome in spite of any surgical intervention. Hence, these parameters need to be measured and assessed to predict the outcome of any surgical intervention. The next common finding that we often see in our day-to-day practice is a degenerative scoliosis. And once we see this degenerative scoliosis on the X-ray, we must get an whole spine X-ray. This is nothing but a 36-inch X-ray film, and this can be done in supine as well as standing position. And on these films, we need to look for any subtle listhesis, rotatory subluxation, the presence of osteoporosis, and the loss of lumbar lordosis, in addition to assessment of the spinopelvic parameters. In addition to the spinopelvic parameters like pelvic incidence and pelvic tilt, sagittal balance is a very essential parameter that is altered in patients with degenerative scoliosis. Sagittal balance essentially means when you draw a plumb line from the C7 cervical vertebra, this would fall within the pelvis. But patients who have sagittally imbalanced, this plumb line falls ahead. So the back muscles have to work that much harder to keep you straight. And so patients who are sagittally imbalanced have a very poor quality of life due to mechanical back pain, and this must be corrected. So we have various softwares available like Surgimap, where you can measure the parameters, spinopelvic parameters, as well as the sagittal vertical axis, and have a plan for your management. One common question that is often asked, how do we differentiate between the adult onset degenerative scoliosis from the idiopathic scoliosis that has progressed to adulthood? And it's very essential that we know the difference. The adult idiopathic scoliosis is a scoliosis that is present in childhood, and it is present now in adult. So these are usually thoracic with lumbar scoliosis. So this could be seen in even younger population. And these patients usually do not have spinal stenosis. Unlike the degenerative scoliosis, which is usually seen in older population, they have significant canal stenosis, and the curve is not usually that big, and there could be sagittal imbalance in addition to the coronal imbalance. The next investigation that we need to assess is our MRI. MRI has become an important armamentarium in our hands for evaluating lumbar pathologies. The first step is getting a proper prescription for an MRI. We have to order the MRI of the part that we need to be imaged in detail, but in addition, we have to get the whole spine screening. So always ask for a screening MRI of the whole spine. Why so? Because this beautiful study from Ganga Hospital has shown that there could be other pathologies which could be lurking silently in the cervical and the dorsal spine, which could have an impact on the overall outcome. So we must order a whole spine screening. The disc degeneration is the most common pathology that we will come across in the lumbar spine. Furman et al. Have given a beautiful grading system for the disc degeneration. Normally, a young adult will have a bright, hyperintense annulus surrounded by the nucleus pulposus, and this differentiation is gradually lost with aging. So when you have grade 4 or grade 5, the disc looks homogeneously dark and the disc height may be reduced. So these patients who have degenerated disc will have higher incidence of back pain. Then coming to the disc prolapse. This prolapse is perhaps the most common pathology that we will come across, and we need to have used the proper nomenclature for describing this disc herniation. This could be either a central disc herniation or a paracentral disc herniation or a foraminal or an extraforaminal disc herniation, depending upon the location of the disc herniation with respect to the thecal sac. Another classification that is used with respect to the pedicle. The disc herniated could be either at the level of the pedicle, superior to the level of the pedicle, or at a higher level to the pedicle. But the most commonly used classification is this one, where we divide them into content disc herniation and non-content disc herniation. Again, the content disc herniation could be either broad-based or focal, and the focal disc herniation could be either a protrusion or an extrusion. In protruded disc herniation, the base of the herniation disc is wider than the apex, whereas in an extruded disc herniation, the base is narrower. So, for example, this patient has an L4-5 disc herniation, but this is not the adequate description. So we should always tell that this is an L4-5 right paracentral broad base protruded disc. So this is how we should describe a disc herniation. Similarly, this is an L5S1 left-sided extraforaminal disc prolapse. Extraforaminal disc prolapse is far rarer to a canalicular disc herniation, but they are very painful and often a missed diagnosis. Patients who have recurrent disc prolapse, we can find it difficult to confirm the diagnosis on a routine MRI. In these patients, we need a contrast-enhanced MRI. Contrast-enhanced MRI, the presence of rim enhancement is classical of a recurrent disc herniation, because patients could be having fibrous scar over there. The fibrous scar will homogeneously become hyperintense and contrast, whereas a recurrent disc will have only rim enhancement. Other things that can be seen on the MRI is facetal effusion. The facetal effusion is a telltale sign of instability, and this can be confirmed with dynamic X-rays. Facetal arthropathy can also be visualized on the MRI, and the presence of discs, the facet space narrowing, the presence of osteophytes or irregularity is a sign of facetal arthropathy. Facetal cysts can also masquerade as lumbar disc herniation and present with radiculopathy, but they look as an hyperintense signal coming out of the facetal joint. Lumbar canal stenosis can also be diagnosed on the MRI, and the classical lumbar canal stenosis happens because of the ligamentum flavum hypertrophy. The ligamentum flavum appears as a thin layer on the undersurface of the lamina. If it thickens, that we know that this is lumbar canal stenosis. The lumbar canal stenosis again can be classified depending upon the location of the stenosis. It can be a central canal stenosis, or the far more common lateral recess stenosis, and the rarer foraminal stenosis. Again, this has to be described based on the axial images. There has been a qualitative grading that has been described by Sijas et al. To explain the severity of lumbar canal stenosis, divided broadly into A, B, C, and D. A and B are categories where you can identify the individual nerve roots, and when you can identify the individual nerve roots, the plan is usually conservative. Whereas in type C and type D, you cannot make a differentiation of the individual nerve roots, and these are severe canal stenosis. And these are the patients who often land up with a surgical management. In patients who have multiple level lumbar canal stenosis, this qualitative CJAS grading also helps you determine the levels which need intervention. Often a question is asked, if you have already diagnosed a spondylolisthesis at particular level, say at L4-5, do we need to get an MRI done? Yes, we also have to get an MRI done because there could be a concomitant stenosis at a higher level or at a lower level. And if you just address the listhetic level, the patient could still be symptomatic at the end of surgery. Then in degenerative scoliosis, MRI may be a little tricky because of the rotation involved, but we have to make an assessment of the foraminal stenosis, the presence of possible disc herniation, and the presence of facetal cyst. Modic changes are also a very important part that need to be assessed. Modic changes are nothing but vertebral body end plate signal changes. They are of three types: type 1, type 2, and type 3. Type 1 and type 2 are the most common. Type 1 is usually a T1 hypointense, T2 hyperintense signal, and this usually implicates marrow edema or marrow inflammation. And these patients who have type 1 modic changes usually need some kind of stabilization or fusion surgery for management. Type 2 modic change is an age-related degenerative change in which there is T1 hyperintensity and T2 hyperintensity, and this usually signifies fatty replacement of the bone marrow. Sometimes the type 1 modic change may be confused with spondylodiscitis. The key step there is to look at the disc space. If the disc space looks hypointense or normal, that means it is a modic change. Whereas if the disc space looks bright on the T2 weighted images, this looks that probably there is an infection like spondylodiscitis. The last part that we need to discuss is the need for CT scan. In this today's day, when we get X-ray and an MRI, we get most of the information that we need to plan our treatment. But CT scan does have a role. For example, for delineating the pathology like the presence of a calcified disc or an end plate eversion, or in certain cases when you are planning a surgery, we need to understand the pedicle morphology, or osteotomies, we need this CT scan. For example, in this case, we can see that there is a calcified disc. The presence of a calcified disc on the CT scan changes the whole treatment plan. We may not be able to do a simple discectomy, and we may have to do a fusion surgery because we have to curate the end plates that much. The presence of osteophytes also can be determined with the help of CT scan. These osteophytes could be in the form of traction osteophytes, they could be claw osteophyte, or they could be wraparound bumper osteophytes. These are better determined with the CT scan. The third and the most important role of CT scan is the evaluation of end plate failure. Earlier, we used to believe that majority of our disc herniation happened due to an annulus rupture, but now we know almost 65% of all lumbar disc herniation happen because of an end plate failure. And these end plate failures can be assessed, can be evaluated with a CT scan best. I think with this, we'll come to an end of our presentation. The take-home message from our presentation will be that multimodality approach will be the most helpful one. Clean radiographs still have a great role to play in the era of MRI. Dynamic radiographs help in evaluating subtle segmental instability. Qualitative MRI grading of lumbar canal stenosis helps plan treatment. Contrast enhanced MRI is useful for recurrent disc herniation, and CT scan helps identify disc calcification. Thank you.
Thank you, Gurdeep. So, anybody has any questions for Dr. Gurdeep? Okay, Gurdeep, I have one question for you. When it comes to imaging of degenerative lumbar spine, what are the pitfalls where we can go wrong?
I think one major pitfall is just if you have one MRI imaging and you feel that that is sufficient to plan the care for this particular patient. Even if you have an MRI, it is essential that you always insist on getting an X-ray, and because MRI is basically done in supine position, so you may miss out on instability, and so we need dynamic images and we need standing X-rays so that we can diagnose subtle instability. The other thing is if you are planning some major surgery, and if especially in degenerative scoliosis and you are planning to do an osteotomy, I think it is essential that you do not ignore the need for a CT scan. And I think, as my previous speaker told, if somebody has come to you with a lumbar spine MRI always insist on getting a whole spine MRI, because there are a lot of pathologies that you could miss out and that can have a bearing on the final outcome.
Okay, I think that was the very well brought out. The message is very well brought out. And I would also say that always just don't depend upon the imaging. You should always correlate it with clinical symptoms before you decide any management. Thank you, Gurdeep. If we do have any other questions? So if not, then we'll go to the next speaker. That is Professor Dr. Kamran Farooq. So he will be talking on radiology in spinal trauma.
Good morning. So we're going to talk about spine trauma imaging today. The reason why we need to image a patient with spine trauma is firstly to make the diagnosis of a vertebral fracture, to classify the fracture, to be able to define whether the injury is stable or unstable, to pick up any neurological compromise, and finally, based on imaging, to plan the appropriate treatment for the patient. The risk of missing a spinal injury could be a major permanent disability and a catastrophe for the patient. There is no controversy that the imaging should be emergent and appropriate for a patient of spine trauma. In the cervical spine, on the AP and lateral views X-rays, on the AP view, what we should look for is that the tips of spinous processes of the vertebra should be in the midline and on a straight line. The lateral margin of vertebral bodies should again form a straight line, and the lateral margin of vertebral body should be equidistant from the midline or the spinous processes. On the lateral view, there are 4 lines which you should look at in the cervical spine: the line along the anterior margin of vertebral bodies, the line along the posterior margin of vertebral bodies, the spinolaminar line, and the line joining the tips of spinous processes. They should all form a smooth curve and should be continuous. If they are broken, then you should suspect some kind of spine fracture. The ideal modality of imaging for a patient with spine trauma is the multi-detector CT, which is a modality of choice. The best part is that even CT done for chest, abdominal, pelvic injuries, we can reconstruct the images of spine, and the patient need not go a separate CT scan of the spinal column for picking up the spine injury. So MDCT has become now the standard protocol in assessing patients of trauma. If any neurological deficit is suspected, then further MRI can be done in these patients to look for cord injuries, for other soft tissue injuries, and the posterior ligamentous complex injury. The best thing is to look at all the cuts of the MDCT, which is the axial cut, the sagittal cut, and the coronal cut, to be able to define and get the best diagnosis and the inference of the spine fracture. If you look at only one cut, it is likely that you might miss certain nuances. It should be picked up when you assess all the cuts of the CTs. If you suspect that vertebral arteries are also involved, then a CT angiography can be done at the same time. A common injury in the cervical spine is a hyperflexion type of injuries, which can be picked up on the CT scan by obvious either compression fracture or subluxation or dislocation of the vertebra, superior vertebra on the inferior vertebra. And the thing to look for on the CT scan is either on the parisagittal cuts, there would be either a perching of the facets, or there could be a break in the facets along with dislocation. They could be uncovering, as well as they could be a jumped facet, which could be either unilateral or bilateral. Normally on the axial cut of a cervical spine subaxial vertebra, you will find that the facets look like a burger, which is called the hamburger sign. If there's a dislocation, the burger is reversed, and it is called reversed hamburger sign. In case of bilateral facial dislocation, you will have reversed hamburger sign on both the sides. You should possibly get an MRI done to look for any kind of any kind of cord lesion, and you can see a contusion along with the edema here. Or you could pick up subtle signs like the tearing of facet capsules, clearly seen here, along with covering of the facet joint, and obviously to look for any kind of cord injury in such cases. A fracture which is peculiar to the cervical subaxial spine is a flexion teardrop fracture, again caused by a flexion hyperflexion type of injury, in which there is a fracture of the anterior inferior portion of the cervical vertebra, along with the retropulsion of the vertebral body. The same can be picked up on the MRI, and it's a highly unstable fracture and can cause severe cervical cord damage. Another fracture which is common is the, along with the hyperflexion, you have axial loading of the vertebra, which can cause a burst fracture. It is like a commonly seen burst fractures in the thoracic and lumbar spine. The shattering of the vertebral bodies, and it's broken, and it could be a retropulsion along with damage to the cervical cord. A peculiar injury which is seen especially in the fused spines like ankylosing spondylitis and dish is the hyperextension injury. The spine acts like a carrot and breaks into two parts, more akin to the femoral shaft fracture with two columns, and there's a hyperextension kind of injury breaking. You know, these two act like the shaft of femur, and there's a break in the shaft of femur, sort of a fracture akin to a shaft of femur fracture with two long columns, highly unstable injuries which should be surgically treated. Another fracture which is seen in the upper cervical spine is the extension teardrop of fracture, normally seen by and large in the upper cervical spine. Again, there's an avulsion fracture of the anterior end of the vertebra, the annulus teres, ALL, and the annulus teres, the anteroinferior part of the fracture. It's stable in flexion, and there's no retropulsion seen in this case. We could have a hyperflexion sort of injury with rotation, which can be picked up either on coronal CTs or on axial CTs, in which two contiguous vertebra will be seen in rotation. MRI is very important to look at the injury to the disc, which is seen here as a bright signal, or the PLC, which is again seen here on a stud image. There's a bright signal and the PLC is torn, or to look at the ligament, the transverse ligament in case of a dense injury. The transverse ligament is torn here, or to look at the PLC and the fracture edema. The different kind of imaging which you can see on the MRI, the cord injuries, is edema, which will be seen as a bright signal on T2. It's like a flame-shaped sort of appearance which you get, or there could be contusion, which again is a bright signal, but it's confined to the site of maximum injury. Contusions could be hemorrhagic, which is seen here, which will be seen as a dark signal on T2 due to the hemorrhaging, or non-hemorrhagic. And then obviously transaction of cord is easily picked up on an MRI, and later on this could result into a myelomalacia, again seen as a very bright signal on T2 and a hyper signal on T1. And again on a T1 image you can see a hematoma. In the thoracolumbar spine, it is easy to think of injuries as either a compression fracture due to flexion, or flexion distraction injuries in which there's distraction of the posterior elements and compression of anterior elements, or it could be a fracture dislocation or a translation as in type C injuries. The important thing is to look at the PLC on an MRI, and the best views to look at the PLC on the MRI is either the stir image to suppress the fat, or a T2 fat saturated image, in which you can see the supraspinous ligament as a dark band. You can see the ligamentum flavum again as a dark band. You can see the interspinous ligaments, and on the transverse cuts you can see the ligamentum flavum, you can see the supraspinous ligament, and then you can see the facet capsules also. These should be looked at on a T2's either a T2 fat suppressed image or a stir image. The typical impaction type of fractures caused by flexion, the hallmark of this injury is that only the anterior part of vertebral body is involved, and the posterior vertebral body wall or the margin will be intact in these cases. Seen beautifully on the MRI, only the anterior part of the vertebra is compressed here, and the posterior part of the vertebral body is intact. And you can see the dark band of PLC is intact. The supraspinous ligament, the flavum, the ligamentum flavum, the interspinous ligament, they are all intact. So it's important to see similar things seen on the STIR image, the same picture. This is a T2 vertebral image and the STIR. So the same thing can be seen that PLC is intact. The compression injury could involve both the superior and inferior end plate and the classic split fracture which we get on the CT. Again, the important thing is that the posterior margin of vertebral body will be intact. However, if there's an axial loading along with the flexion injury, then it could result in the classic burst fracture in which there is shattering of the vertebral body. But the most important thing to look at is whether the posterior part of vertebral body is injured. The posterior margin would definitely be injured in a burst fracture, and you could get a retropulsion along with neurological deficit, or even without a deficit, and the role of MRI and PLC injury comes therein. We could have a flexion distraction type of injury which could run through the bone. You can see here the fracture line is running through the mid part of the vertebral body and exiting through the spinous process. This is a classic flexion distraction type of injury, or a chance fracture running through the bone. You could have a flexion distraction type of injury which could be purely ligamentous. In this case, it's running through the disc and through the PLC. You can see the classic sign of increase in the interspinous distance on CT scan in a case of flexion distraction injury, and avulsion fracture of the posterior part of annulus here. So this again is a sign of flexion distraction injury. Again, here you can see the fracture is exiting through the bone here, but going into the soft tissue. So this is a soft tissue injury in a case of flexion distraction fracture. Or you could have the hyperextension type, anterior distraction type of injury, B3, classically seen in fused spines like ankylosing spine and dish type of a picture. So they act like two long segments and they're highly unstable injury. And then finally, you could have the fracture dislocation or translation type of injuries along with the rotation. Seen here, you have sort of a flexion injury along with the dislocation. Then you could have a flexion distraction injury. Again, here, these are all translation and type C injuries in which all the three columns of the vertebral body, the spine as such, are involved. They are highly unstable injuries. Or you could have the same in which there is a shear fracture both in the coronal plane and in the sagittal plane. The important thing is to look at the PLC injury on the MRI, especially in case of burst fractures, to decide whether the injury is stable or unstable. And injury to the PLC would look like a discontinuation of the supraspinous dark band on a T2 fat suppressed image, or on a STIR image you can see the PLC injured and you can have a bright signal edema running through the PLC complex. So it's important to pick up the PLC injury, then that's why MRI is very important, especially if you have to decide the stability of the fracture. So finally, the checklist we should look at on the CT scan is look at the injury pattern, the mechanism of injury, try to decipher whether it's a compression injury, it's a burst fracture. Look at the basic morphology of the lesion. Look if there's any vertebral body height loss, if there's any retropulsion of the fragment into the canal. Try to assess the degree of kyphosis, and on the CT scan try to infer if there's any PLC injury which could have happened by looking at the facet joint widening, look at the interspinous distance widening, look if there's any spinous process avulsion fracture and any obvious vertebral body subluxation or dislocation. On the MRI, look at the status of the PLC by looking at the supraspinous, interspinous, ligamentum flavum, facet capsules. They'll all be edema on T2 STIR images. Look at the status of disc, look at the anterior and posterior longitudinal ligaments, and finally look at the neurologic injuries of the patient in the spinal cord, chordae equina, any nerve root injury, or if there's epidural hematoma. So to conclude, from the imaging, we should try to decipher the mechanism of injury, whether for the flexion injury, hyperextension injury, does it involve any axial loading, or if it's a flexion distraction injury. Look at the morphology of the injury. If it's a compression, burst, or dislocation kind of an injury, level of injury would be obvious. Look at the status of the disc, PLC, if there's any epidural hematoma. Look at the status of the cord if it is injured, and finally all this imaging should help to formulate a treatment plan. Thanks very much for patient hearing.
Uh, uh, thank you, Dr. Kamran. So it was a very nice presentation. We all know that imaging is very, very important when it comes to spinal trauma. So you are at the Apex Trauma Center of the nation, actually. When a suspected spinal trauma comes to your center, what all are the must imagings which you do?
The must imaging which we do is a CT scan. Because most of these patients are either RTA or blunt trauma. So anyways, they would go in for a whole body CT scan to assess other injuries in the chest, abdomen, and pelvis. And most of the times what we do is we try to reconstruct the spine imaging from the CT which has been done for, scouting for other injuries, right? So we don't get a CT scan done separately for spine. In fact, we reformat the images from CT which is already been done for the chest and pelvis and abdominal injuries. So that is one thing. And then if there's any neurological deficit, then we would go on for a MRI, which is not emergent. Once the patient has been admitted, then we get the MRI done. But yes, once the patient comes, we go for a whole body CT scan.
Do you follow any criteria at your institute?
You mean the nexus criteria? Yeah, we do. I mean, because obviously all the patients who are coming in, we can't subject them to cervical spine CT. So we do follow the criteria, the nexus criteria or the Canadian C-spine rule by and large.
Okay. Dr. Appaji, do you have any questions?
Not really. Hi, Kamran. How are you?
Nice to see you long time. Because of the COVID, we are not able to meet.
Meet in any of the conferences.
Yeah.
So, Dr. Kamran, what is your advice when it comes to imaging of junctional areas like cervicothoracic junction and basically occipito-cervical junction? It's a tricky. So, what's your advice?
The thing is that on plain X-rays, I mean, some people, if they are not taking CT scan as a routine, on plain X-rays, I mean, the rate of missing these junctional injuries and even C-spine injuries is very, very high. It's almost to the tune of 50 to 60%. So it is advised that if possible, we must get a CT scan. And the ideal thing for a spine injury is to get at least a screening of the whole spine. I mean, in a CT scan, whole spine CT scan can be done very fast, especially with the recent machines. It hardly takes about 10 minutes, not even that. So always get a CT spine of the whole spine done and not lie just on X-rays because the rate of missing fracture, especially in the junctional areas as C0, C1 areas and in C-spine is very, very high just on the basis of X-rays. So the older school of thought was that just take a lateral view, open mouth and AP view, and you pick up most of the injuries. Well, that's not really true. Then you do miss a lot of injuries if you don't take a CT spine.
And Dr. Kamran, can you comment about Sciurra?
Sciurra, yes. I mean, if on clinical examination and on CT scan, you don't find any injury, then you have to go on for an MRI. Actually, Sciurra term was coined when we didn't have MRIs. So especially in children, because of the physiological laxity, they can undergo some kind of a neurological injury, even without, because the hyperlaxity, even picking it up without picking it up on the CT scan, and in degenerative spines in elderly, especially central cord syndrome. I mean, you might have a perfectly normal CT, only with osteophytes, all alignment, there would be no fracture, no problem with alignment. It's only when you get the MRI done. So it's imperative that these cases, you must rely on your clinical examination. I mean, that's mandatory. I mean, it should not be that you don't see the patient, you just go to the radiology room and see the CT scan and you clear the patient. That should not be. You have to see the patient first and then see the investigations. And that holds true for all spine pathologies. I mean, you have to correlate your radiology with your clinical science. You can have anything on the radiology and you might not have a concordant clinical symptoms. So it's imperative. In fact, what I would say is if your imaging is not concordant with your clinical examination, then you must go back and rethink. You can't take the patient up for surgery then.
Yeah, you're right. Actually, the scura, there is another term called as real scura after the invent of MRI. When you don't find anything in MRI also, then it's called as real scura. So thank you, Dr. Kamran. Thank you.
SI and Dr. Meena and Team IOACON for giving me this opportunity. Thank you.
Yeah. So can we go for next talk by Dr. Shyam Sundar Bhatt?
Good morning, everyone. This is thank you for Dr. Chal and of the team for giving me the opportunity to give a talk here. It's a good basic talk for spine surgeons. It's titled Radiology for Spinal Tumors, and I welcome you all to this talk. Basically, when you talk about spinal tumors, it's very important to get good imaging done, which I'm going to speak about. And CAT scan and MRI are the basic requirements of any center or wherever you want to diagnose these tumors. CT is very good for evaluating the amount of osseous involvement and the degree of cancellous and cortical bone loss. It also evaluates the risk for vertebral for body collapse or the further collapse. MRI is probably the benchmark, the gold standard which we use to evaluate the epidural space as well as the soft tissue involvement of the neural structures. You can do radionuclear scans as well as PET scans, which you can use for surveillance and also picking up to small metastasis up to 2 millimeters or so. If you look at this chart, basically these are the various types of tumors which are and where they present and what is the common age of presentation. Osteoporosity is very common, which you see, it's usually seen in the posterior elements, seen in second, third decade. Then you have something like an osteochondroma, could be any pair, but mostly in the spinous process. You can see a chondrosarcoma, which is in the vertebral body, usually in the third or decade afterwards. You may see a patient like of a giant cell tumor. It happens mostly in the vertebral body in the third to fifth decade. So what I'm trying to say that all these tumors which are up in the spine, they occur at different sites in the spine, in the posterior elements or anterior elements of the body or in the neural arc, and they come in very different ages. So keeping in mind this, then only you can go and see and diagnose on the radiology. So if you see the tumors I just spoke about, if you see the location that, if they're in the anterior part of the body, if you just divide the body into two parts, and the anterior is the vertebral body, you most commonly see a malignant tumor. And that could be metastasis, it could be a myeloma, plasmacytoma, lymphoma, chordoma. Exceptions which are most common is the hemangioma, or maybe a giant cell tumor. If you see the posterior elements, which includes the neural arc as well as the posterior elements, the most common is the osteoporosity. Here is also where you get the osteoblastomas and the chondromas. Exceptions which most commonly you might see is the chondrosarcoma. If you look at the sites, if it's a lot of sites involved, multiple sites in the thing, the first thing which will come to your mind is metastasis. Other is the myeloma or lymphoma, which are the other common ones. If it involves of adjacent vertebral levels, so you have one spine wall and another one on top, one on down, basically. Those are seen in osteosarcoma, chondrosarcoma, as well as myeloma and other tumors. If you see the classification, which is basically based on what type of tumor it is. If you have osteogenic, chondrogenic, vascular, hematopoietic, and other causes. Osteogenic most common is the osteoblastoma and the osteoblastoma, which becomes a sarcoma later on. Chondrogenic is the osteochondroma, which becomes the chondrosarcoma later on. Vascular, you have the hemangioma and the lymph involvements. Hematopoietic are the ones which are usually malignant. They are the plasmacytomas and the multiple myelomas. The notochord ones are the ones which are malignant, usually which are the chordros or chordomas, which you see in the sacrum. Then you have a giant cell tumor, which is like a benign giant cell tumor, but could be also locally malignant. Ewing sarcomas are the penial tumors. Coming down to benign tumors, you can see that osteoblastoma, you probably commonly see patient complains of pain in the night, and most Commonly, it happens in the posterior elements is most involved. You'll see a nidus formation like this, and CT is a very good modality to pick it up. On an MRI, you can see the nidus is hypo-intense on T1 weighted images and variable signal on T2 weighted images. And if you do contrast, there is enhancement in this. Coming to osteoblastoma, they account about 30 to 40% of all osteoblastomas are in the spine. They originate in the neural arc and often extend to the vertebral body. You can see these two images, one is the CT scan and the MRI. On the CT scan, you can see a well-lit lesion in the posterior elements and around the transverse process, and there is a surrounding sclerosis. On the MRI, you can see the lesion is hypo-intense and has mixed signal on T2 weighted due to variable matrix mineralization. So this is bottom to mode. Coming to an osteochondroma, this is mostly seen in the spinous process, and if you get an MRI done, which is on the right side here, you can see that the T2 hyperintensity beyond cortex is the part where represents the cartilage's cap. Coming to a chondroblastoma and a chondromyxide fibroma, these are very rare, very few you see, but you can see them. You can appreciate on the CT scan that it's an aggressive tumor and expansile lesion, but it also has a sclerotic border. On an MRI, you can see that it's hyperintensity within the matrix, and which represents the immature chondroid. Is hypercellularity, hemosiderin, and calcification on histological analysis. So you can see that it involves the lumbar spine as well as the cervical spine. Hemangiomas may be benign, which is the most common one, but also can be aggressive, which are very vascular. So on a CT scan, you will see a polka dot and chordroid appearance. And MRI demonstrates T1 and T2 hyperintensity, which is interspersed with thick low signal intensity vertical bone struts. You can see this one image of a CT scan, an X-ray, an MRI, as well as a DSA. What a DSA shows, that's a very vascular tumor. Giant cell tumor is also very, very common, and primary site is the vertebral body. Upper sacrum will be the most common. These lesions are well defined lytic, but without any matrix calcification or sclerotic rim. So you can appreciate here that there's areas of hypertensity inside the sacral tumor, and has lots of dense collagen and hemosiderin. On the right side, you can see that the total collapse of the C7 has happened, and even right to that is you can see that the C7 vertebral body has collapsed, and that has gone into the compressing the thecal sag. Osteosarcomas, these basically are very aggressive tumors. They usually happen in the posterior elements, but can happen anywhere in the body, anywhere in the vertebral body as well as behind. The telangiectatic osteosarcoma presents lytic lesion, and on MRI, fluid levels can be appreciated. Coming to a chondrosarcoma, this is basically also aggressive, and imaging in this shows a lytic destruction with chondroid matrix. It may look like a ring and arc in some cases. It usually arises from the posterior element, and on MRI, you can see that it's contrasted on MRI on top, which shows that there's lobal enhancing mark, which may be arising from the right of the lamina. It compresses and displaces the cord. It's an aggressive tumor. There's another photograph. This is the CCT of an axial view of sacrum with the chondrosarcoma, and this is the chondrosarcoma of the left transverse process of L4. Another one is the hemangioendothelia and hemangiopericytoma. To show you that these are also aggressive tumors, and you can see that this imaging reveals lytic lesion with honeycomb experience. So just to go through these four images, the one on the left is an X-ray which shows involvement of the pedicle, and then you have a contrast on CT scan which shows involvement of the vertebral body. Then you have another image which shows the MRIs. This shows intense enhancements of lesion, and it is a multiple curvilinear flow which are characteristics of hemangiopericytoma. Lymphomas, they account for about 1 to 3% of lymphomas, usually happen in the older generation. These lesions are lytic, mixed, and rarely sclerotic. So basically you see them lytic, which is the most common. And in this MRI, you will see a focus of marrow replacement and a large surrounding soft tissue without a large area of cortical destruction. These are highly suggestive of lymphomas. Leukemia cases also seen. Commonly you can see them, but mostly occur in children and mostly male children. So you can see that it involves the vertebral body as well as the neural arc area, and the diffuse enhancement seen on the contrast administration. These lesions appear hyperintense on T1 and hyperintense on T2. Chordomas is the second most common tumor. It happens in the sacral coccygeal area Probably everyone's already seen these. So this typical appearance is of a mushroom collar button. You can see this is what it looks like. Okay. Ewing sarcoma is also seen, mostly seen in the sacrum, and it's an aggressive lytic lesion, like as it happens in the femur anywhere. So here also is aggressive lytic lesion destruction, and there's collapse of the vertebral body. PNET is very rarely seen, but it can be seen mostly in the lumbar area. And I mean, you can see them, and if you follow them up to a month or 2 months, you can see that it eats up the whole body as well as the vertebral arch. Leiomyoma or leiomyosoma and the spindle tumor, these have to be kept in mind. These are permeative lesions with the indistinct in outline, and they are better demonstrated in CT more than MRI. Intramedullary tumor is also very important because these also we see a lot. Most common one is ependymoma, then is the astrocytoma. The general characteristics of these are they cause spinal cord expansion. They produce high single intensity on T2 weighted images, and the majority show at least some contrast enhancement. So just spend a minute on this, that you can see that like an example of ependoma, it is usually seen in the cervical cord. On T1, it's iso-intense to hypo-intense. On T2, it's hyper-intense. Strong enhancement on contrast, and it shows in the cervical area. Second most commonest is the astrocytoma. Usually see in the thoracic cord, it's again iso-intense to hypo-intense. And on T2, it's hyper-intense. It may be variable, patchy, or enhancement. So if you just see on this, everything is same here, except that on enhancement, the astrocytomas are variable and patchy. Other tumors like you might see a schwannoma, also seen in cervical cord. Similar appearance, iso-intense to hypointense on T1 and hyperintense on T2. It may be heterogeneous on enhancement, but you see here like a dumbbell shape, I will show you. Ependymoma, this is what a characteristic looks like, and the T2 weighted images demonstrate a heterogeneous mass located centrally, displacing the normal cord laterally. Astrocytoma is the second most common tumor, and it happens in the thoracic cord, not in the cervical cord. And they also cause long masses which are seen. And if you contrast it with the chondromium, it demonstrates an indefined heterogeneous enhancing mass, which is the white arrows. Other rare ones which you see are hemangioblastoma, one of the A on top. The second is the ganglioma, intramedullary metastasis you can see in the C part, and the D is the primary intramedullary lymphoma. So these are different tumors which you can see intramedullary type also. Schwannoma is characteristic, and you can see that it shows a dumbbell-shaped mass. You can see the black arrows coming out of the root area and passes out the neural arc. So this is a characteristic of a schwannoma. Meningioma, these are basically iso-intense to the spinal cord. So you can see a big one here on the T1 image and hypertense on the T2 image. So the basic take-home message which you have to understand is that the plasmacytomas and multiple myelomas are the most common malignant primary spine tumors. Hemangioma is the most common benign tumor. Imaging is very important. You have to get an X-ray, at least a CT scan, an MRI, and if possible, a PET scan. Bone scans are also invaluable. All these will have involvement of the body, the soft tissue. It can cause infiltration of the marrow as well as an intraspinal extension. But you have to remember that all these tumors you have to correlate with the age, when it appears, the sex of the patient, location, if it's happening anteriorly or in the posterior elements, it's happening in the cervical spine and the thoracic spine, wherever it's happening. And keeping all these in mind will give you maybe not a definite, but a close diagnosis of what kind of tumor it is. Thank you so much for it.
Thank you. Does anybody has any question for sir? So any?
Saravjit, hi, good morning. Kamran here. Do you involve your radiologists when you're, any special imaging to discuss with them, or do they advise And what about intervention like?
So like you're sitting in a tertiary hospital, I'm also in tertiary hospital. So most of our patients who come, about 80%, already have a CT scan, MRI, PET scan, everything possible. And from outside, they have it. So basically what we do is we keep that, and we get a CD, and we have a very good musculoskeletal radiology team. And there are 2 consultants who are attached with us. So it's like an MDT here. So all our MRIs are discussed with them, and then we, the CT scan, and then we do another 3 Tesla MRI. We usually go for a 3 Tesla MRI. It's not possible from outside. And then we plan all our biopsies and DSAs, interventions, even the approach has to be done. Even the radiotherapy people come and join us to discuss how are you going to treat it and when patient comes to us. So I think so multidisciplinary is very important.
Very, very important in this. Thank you.
Okay, so now we move on to our next speaker. It's Dr. Yogesh Pitwa. It's about the radiological evaluation in spinal infections. Sanjay, can you please play the next video?
Hello, very good morning to everyone. I thank the organizers for this opportunity. Well begun is half done, but as surgeons, we would believe that well diagnosed is half treated. So in this background, let's look at some radiological evaluation in spinal infections from the perspective of a spine surgeon. There's lots and lots written in the textbook by radiologists, but let's see as what we as spine surgeons would be interested to look out for whenever we are evaluating spinal infections. X-rays, of course, is the mainstay of investigations in these kind of situations. And the only drawback is that most of the times the changes in X-rays would happen only after a lag period. And hence, they may not be among the foremost modalities to pick up early infection, but in a later stage, we would see changes like end plate erosions as is seen over here. There are also certain other features which we can see on the X-rays. There is this bird's nest appearance as we can see on the anteroposterior X-ray over here, and which would be indicative of a paraspinal abscess and which may probably require a surgical intervention as is seen over here. Beyond that, we are more keenly interested in looking, not just, we are orthopedic surgeons and we tend to look more at the bones, but beyond the bones, we also need to look at the soft tissue. Now here is a illustrative case wherein the soft tissue shadow has increased in the anterior aspect of the cervical spine, and when we do an MRI, we realize that there is a prevertebral abscess which is causing a mass effect and had to be drained. And that was because of a small lesion in the C2, an exudative Cox type of lesion, and which was drained and which led to a satisfactory outcome at the end of treatment. One can see the normalization of the soft tissue shadow at that level. We are also interested in looking at features of instability in the spine, and this is something which I believe most of us are aware about, and that is the presence of spine at risk signs in pediatric spinal tuberculosis. There are 4 signs, and of the 4, 3 are seen on the lateral X-ray and are seen in this particular illustrative case: the toppling over, posterior translation, and the facetal disruption. The 4th sign, that is the lateral translation, is seen on the anteroposterior X-ray. So this is the MRI of this particular patient and had to be operated upon with a hybrid fixation as is seen over here. Sometimes we also see anterior tuberculosis with anterior abscess, and that may present with scalloping of the anterior cortex. Just zooming out the lateral view, and we can see that there is scalloping of the anterior cortex over here, which is because of the erosion due to the anterior abscess. We, as mentioned before, we also use X-rays as primarily, since we are surgeons, we would want to evaluate instability. And here is a patient who had features of postoperative infection at the L5-S1 level, and there was significant osteolysis before the start of the treatment. At the end of the treatment, the CT scan did show good amount of resolution of the bone defect, but still, not adequate enough for us to make a decision whether the spine is stable or not. And in these situations, we often resort to flexion extension X-rays to actually clarify whether the patient's spine is stable or not. Beyond de novo infections, we would also want to look out for infections, signs of infections in post-operative cases of ours. And in these situations, we may have to look out for subtle indicators of infection, such as lucencies around the screws, as is seen over here. To summarize, X-rays are used as one of the most basic investigations. One can look out for end plate erosions, and it's not just the bones. We also need to look at the soft tissue shadows. We also look out for features of instability, and it's a very important investigation for follow-up of treatment. We also look for features of post-operative infection whenever necessary. Coming to the next modality, that is MRI. This is something which is very popular, commonplace, and universally available now in practically all parts of India. There are various features that you would want to look out for in the MRI: abscess, extent of lesion, as well as the status of the cord, as is seen over here. We would also want to go beyond just looking at the lesion, the main lesion. We would also want to look out for skip lesions, and for this, stir imaging of the whole spine is very useful. Here is an illustrative case, a patient with skip lesions at 3 levels, and of these 3 levels, the thoracic and the lumbar spine levels were showing instability and hence had to be operated upon, as is seen over here. We would also want to look out for spinal cord changes or presence of intramedullary tuberculoma. We are more focused on discussing tuberculosis because that is the most common spinal infection that we would be visualizing. Of course, there are other infections also, but a major part of our discussion is going to focus on tuberculosis. So this is a patient who had intramedullary tuberculoma, and before treatment and after treatment with steroids and anti-tuberculous treatment, we had a satisfactory outcome for this particular patient. There are also certain telltale signs which will tell us which will differentiate the tuberculosis from pyogenic infection on MRI. Here is a wonderful literature for that, and just a synopsis of this literature. Whenever we do a contrast MRI in TV, there will be heterogeneous enhancement of the vertebral body. Vertebral intraosseous abscess will be there, and there will be paraspinal abscess. As against that, in pyogenic, we would see homogeneous enhancement of the vertebral body, disc abscess, and that is how we will be able to differentiate between the tuberculosis and the pyogenic infection. The other indications of MRI is to identify the healing response. Now, this is a MRI which was present before the treatment was started, and one can see the cold abscess there, and where there is resolution of the cold abscess following non-operative treatment, as is seen over here. One would also want to look out for signal intensity changes before treatment and after treatment. And one of the foremost indicators of healed infection is the presence of hyperintensities on T1 weighted images, which indicates that the infected marrow is now replaced by fatty marrow, and hence it's a sign of healing. There are, of course, other indications for MRI to evaluate post-operative spine infections, and these would be better evaluated on T2 weighted images. Now, here's an illustrative case: a patient operated upon for L4-5 discectomy, presented with pain thereafter, and we had when we did the MRI, there was evidence of hyperintensity on T2 weighted images at the level of the disc space, indicative of infection. And the patient had to be taken up for appropriate surgery accordingly. There are additional utilities of MRI, as is seen over here in this particular illustrative case. We can see that there is infectious lesion in the subaxial spine, and here is the axial section, and we can see that there is a large abscess which is slightly asymmetrical, and it's also engulfing the vertebral artery. So in these kind of situations, one may utilize the MRI to do MR angiogram to evaluate the vertebral artery status, and once confirmed that it's all okay, we can go ahead with our operative intervention as is seen over here. However, there's a word of caution that we need to have on MRI. Though MRI is diagnostic in most cases, there are some TB cases which may mimic neoplasms as is seen over here, and vice versa. Some neoplasms may mimic tuberculosis as is seen over here. This may otherwise look like a tuberculous lesion, but it's actually a metastasis from the lung carcinoma. So sometimes there is an overestimation of the problem on MRI. Now here is an illustrative case. The presentation X-ray, we should see no case, but we see the MRI, it looks quite ghastly. And however, we were aware about this phenomenon of overestimation of problem on the MRI. The patient was given non-operative treatment, and following simple conservative treatment, we had a satisfactory outcome without the need for any kind of major surgical intervention. So to summarize, MRI is useful for confirming diagnosis, for evaluating the cord status, to identify skip lesions, and to differentiate between pyogenic versus tuberculous lesions, to evaluate the healing response as well. It may also give us ancillary information in the form of status of vertebral artery and other details which may be useful in planning the treatment. Coming to CT scan, it's used primarily to assess stability. As spine surgeons, this is what we are interested in looking out for. Here is an illustrative case. A patient with a mid-lumbar lesion, there is some amount of collapse of the disc space. MRI looks okay, but when we do a CT scan, here is what we see. There is a significant osteolysis, one side facet is totally destroyed, and definitely this qualifies to be an unstable lesion and hence was operated upon. The patient was also severely symptomatic, not able to move around even in the bed, could not turn around in the bed, and hence had to be taken up for intervention. So this kind of decision making is possible only if we judiciously utilize CT scans in the evaluation of these kind of lesions. It allows us, as mentioned, it allows us to define the extent of osteolysis. Again, a subaxial lesion, we can see that there is some involvement in the MRI, but a CT scan obviously shows a large defect anteriorly, which cannot be managed with non-operative treatment, and hence a surgical intervention was essential. It can also obviously help us. A CT-guided biopsy can also be useful modality in investigating for in a setting of spinal infection. So this is an illustrative case with hyperintensity seen in the SI joint, taken up for CT-guided biopsy, and accordingly appropriate treatment was carried out. CT is also obviously useful for evaluation of junctional areas. Here is a cervicothoracic tuberculosis patient who was operated upon with an anterior plus posterior fixation. So to summarize, CT scan is useful for diagnosing instability, for percutaneous biopsy, and to assess junctional areas. There are a lot of other tests which have also been listed out, which I'm just listing out for the sake of completion. The use of bone scan. Some of these scans can give us the information related to infection even within 48 hours. PET-CT, though it is documented to be a useful investigation modality, but it's not very frequently used because of the cost constraints and the availability constraints. But yes, it can be used for diagnosis, but more so for follow-up of these kind of problems. There are other newer modalities on the horizon, such as diffusion tensor imaging. However, there have not been many promising results out of this thing, and hence it's not really very useful. So the take-home message is that radiological investigations in the management of spinal infections are directed towards diagnosis, evaluation of instability, planning the management, and monitoring response to treatment. Thank you very much for your attention.
Thank you, Dr. Yogesh. Do you have any questions for Dr. Yogesh, please? Anybody? So, Dr. Yogesh, Dr. Yogesh, can you hear me?
I think he's not logged in.
He is not logged in. Okay. So then we'll move to the next talk by Dr. Shyam Sundar Bhatt.
At the outset, I would like to thank Association of Spine Surgeons of India for giving me an opportunity to talk in the basic spine workshop of Mini-IOACON 2021. The topic given to me is evaluation of a patient with a solitary vertebral collapse. I am from Manipal Academy of Higher Education, which is a deemed university situated in the district of Udupi in Karnataka state. The objectives of my presentations are introduction, the causes of solitary vertebral collapse, the pathological causes, variables to be considered in a solitary vertebral collapse, why we need to investigate, how do we investigate, and pathophysiology in a case of osteoporosis, which is one of the causes of solitary vertebral collapse. The incidence of solitary vertebral collapse is about 1.5 million per year in the United States. It is common in elderly population, and 25% of postmenopausal women may be affected. It can cause significant disability and morbidity in this population. There can be benign causes and malignant causes. Among the benign causes, we have osteoporosis and infective causes. Osteoporosis can be primary or secondary. The primary osteoporosis may be postmenopausal or senile osteoporosis. Secondary osteoporosis usually occurs on prolonged steroid use, in Cushing's syndrome, and some inflammatory diseases like rheumatoid arthritis or ankylosing spondylitis. The infective causes, the commonest one is a central type of tuberculosis. Among the malignant causes, we have primary malignancies like multiple myeloma, when initially a single vertebra can be involved. Secondary causes like malignancies from thyroid, lungs, kidneys, or adrenals, which can cause secondaries in the skeletal system. The other causes are traumatic causes. An axial compression can result in a solitary vertebral collapse. Histiocytosis X or Langerhans cell histiocytosis is another cause. Osteogenesis imperfecta, leukemia, lymphoma, and the most common vertebral hemangioma can also cause a solitary vertebral collapse. The variables to be considered are age of the patient, sex of the patient, the anatomical site where the lesion is, the displacement of the fracture, and there is any secondary complications like neurological deficit, root involvement, or cord involvement causing neurological deficits. The purpose of investigation in a case of solitary vertebral collapse is to confirm the diagnosis of vertebral collapse, look for the causes, exclude possible complications, allow prognostication, and aid in selection of treatment, and provide a baseline assessment of response to the treatment if it is due to osteoporosis. How do we diagnose a case of solitary vertebral collapse? We have to take a detailed history to look for any risk factors if the patients have. A thorough physical examination, including ruling out causes of fall. For example, a poor eyesight, cataract, can result in a fall. So that has to be ruled out. X-ray of lumbar and thoracic spine to be done, especially where there is tenderness, that has to be centered in the radiograph. More than 30% bone loss is required to be visible on radiograph. There may be some asymptomatic wedge fractures too in a radiograph. And bone mineral density measurement is another investigation which can be done with the help of an ultrasound of the wrist or calcaneum, or with the help of a DEXA scan, that is dual emission X-ray absorptiometry. We have a clinical scenario. A 67-year-old lady complains of history of slip and fall at home, following which she had backache and she could not walk immediately after the fall. On examination, she had tenderness over L1 vertebra and there was no neurological involvement. What would you like as a next step in the management of this patient? Okay, first of all, we will take the radiographs, the injured level radiograph, AP and lateral views. In this case, we are seeing that in the anteroposterior view, there is reduced height of L1 vertebra, and in the lateral view as well, you can see that the vertebral height is reduced. Both anterior and posterior heights are reduced. When such a reduction in the vertebral height occurs due to a vertebral collapse occurring both anteriorly and posteriorly, it is called as vertebra plana, also called as pancake vertebra, silver dollar vertebra, coin on edge vertebra, or wafer vertebra. There are several synonyms like this. So it represents a very advanced compression fracture. The next in diagnosis are full blood count, erythrocyte sedimentation rate, albumin globulin ratio, bone profile, that is calcium, phosphorus, and alkaline phosphatase, thyroid function tests, and protein electrophoresis. If the protein electrophoresis does not show any M band, we can even do a serum light chain assay to know for other myeloproliferative disorders. Technetium-99m radioisotope scanning helps to know the hot spots in the entire skeleton. We may need to do ultrasonography of abdomen and thyroid to rule out any primary which can cause secondaries in the bone. Radiograph of the chest to know any bronchogenic carcinoma causing coin lesions, also called as cannonball lesions. And then skeletal survey including skull X-ray, pelvis X-ray, and bilateral shoulder X-rays to know if there are any secondaries in the axial or paraxial skeleton. Tumor markers may be done to know like carcinoembryonic antigen can be done to rule out if there are any primary causing lesions in the bone. There are some tests which can be done if you are suspecting osteoporosis, testosterone and gonadotropin levels in men, serum parathormone, vitamin D3 levels may help in assessing the bone quality. Bone marrow biopsy can be done after tetracycline labeling. It will help to rule out osteomalacia. Otherwise, it is usually done in the case of diagnosis of myeloma. Urinary free cortisol can be useful, and Benz-Jones proteins are usually done in the case of multiple myeloma. However, rarely we find that it is positive. This is the DEXA scan. This is the DEXA machine where the arm moves along the patient body and it detects the bone mineral density, especially of the spine, hips, and forearm bones. The bone density is measured relative to the population mean in young adults. There are two scores, T-score and Z-score. The number of standard deviation away from the mean for a sex and race matched young healthy population is the T-score, and Z-score is defined as the number of standard deviation from the mean for an age, sex, and race matched population. Normally, the bone mineral density is more or equal to -1 standard deviation. In osteopenia, BMD can be -1 to -2.5 CS standard deviation, and osteoporosis is defined as less than -2.5 standard deviation, and severe osteoporosis is in the presence of one or more fragility factors. So essentially, a single vertebral collapse is seen only in severe osteoporosis. Sometimes we may need to do serum and urine markers of bone absorption and formation, especially in metabolic disorders. The markers of bone formation are bone-specific alkaline phosphatase and osteocalcin. And bone resorption markers are collagen breakdown products in the urine, that is N and C telopeptides. There are some imaging which need to be done. Computerized tomography is useful to know the bone structure and if there is any retropulsion in the canal which can differentiate from a burst fracture. Magnetic resonance imaging is helpful to detect the signal changes, also to know the compression on the spinal cord or nerve roots. PET-CT or positron emission tomography CT scan is a useful technique in secondaries. This is a magnetic resonance imaging, T2 weighted image showing a vertebra plana. Can see that there is fluid in the vertebral body suggestive of hematoma. So this is a case of solitary vertebral collapse. How do you differentiate malignant vertebral collapse and benign single vertebral collapse? There is an article in Journal of Magnetic Resonance Imaging in 1999, and there are several differences have been mentioned in the article. Ill-defined margin of abnormal signal change of a pedicle with an expansile lesion, marked and heterogeneous pattern of contrast enhancement, and irregular nodular paravertebral soft tissue lesion. These are all suggestive of malignant lesions. Whereas benign lesions are suggested by well-defined margin of abnormal signal, mild and or homogeneous enhancement, then paravertebral soft tissue lesion with a rim shape. In such a situation, we may need to avoid biopsy and regular follow-up is indicated. This is a useful article by Panda. This is imaging of vertebral fractures, which is given in Indian Journal of Endocrinology Metabolism in 2014. There are several articles which compare benign and malignant vertebral compression fractures in using MRI. These are very useful articles. on this topic. There is a Gennard's semi-quantitative method of assessment of vertebral fractures. This is the normal vertebral imaging. There is a wedge fracture, biconcave fracture, or crush fracture. Mild fracture is grade 1, 20 to 25%. Moderate fracture is graded as grade 2, 25 to 40%. And severe fracture is grade 3, more than 40% collapse. This is a semi-quantitative method of assessment. This graph represents pathophysiology of osteoporosis, which is one of the causes for a solitary vertebral collapse. There's a peak bone mass occurs in about third decade, and after that, there is a severe decline in the bone density. You can see that in women at about 50 years, there is a sudden drop after menopause, and in men somewhere around 70 years, we can see that there is a drop in the bone density. In summary, solitary vertebral collapse affects elderly populations, especially postmenopausal women. Often, it can cause incapacitating back pain and morbidity. And the most important step is prevention and treating the cause for the solitary vertebral collapse. Thank you very much for listening.
Thank you, Dr. Shyam Sundar. Do you have any questions for Dr. Shyam Sundar, please? Dr. Shyam Sundar, can you hear me?
Yes, Dr. Gururaj, I can hear.
So, in practical, when you see a solitary lesion in a spine, do you follow any sequence of imaging, or how do you go about it?
Yeah, we in our hospital we routinely just do a T1 and T2 weighted images, and I rely more upon a T2 weighted images because that is more clear, which shows the fluid hematoma and any neural compression is more evident in the T2 weighted image than other images.
Okay. But then you just rely on like MRI, or you further do investigate, and you have some certain sequence, like you do MRI first, then CT, or maybe a PET CT or a bone scan. Like, how do you go about it?
Yes. We will if we are suspecting a secondary lesion, we will usually go for a bone scan or a PET CT depending on the affordability of the patient, and also. We will rule out myeloma by sending the investigations, and also by doing a ruling out primary in other areas like ultrasound of the abdomen and pelvis, ultrasound thyroid, chest X-ray, all these things.
I have a question.
Guru.
Yeah. Dr. Shyam Sundar,
yes.
I wanted to ask you, when would you utilize a PET scan if it is a suspected case of collapse, like to differentiate from tuberculosis? Would you do a PET scan? When would you do a rather PET scan in case of a TB with collapse?
Usually, it is done in consultation with our medical oncologist. We usually do it when there is a suspicion of malignancy.
No, because many times people nowadays, there's a fashion of doing PET scan, especially obviously if there's a suspicion of malignancy to differentiate. So what's your practice?
Yeah, we usually do it once we confirm the diagnosis of malignancy by some tissue diagnosis. When we obtain, we ask our oncologist, and they ask as a first step from then on for a PET CT scan, especially FTG PET CT scan. In this, they try to locate, they usually find out an unknown primary. It can be easily detected in this PET scan.
Okay. So we have one question from Dr. Ravish. what are the signs on T1 and T2 images that differentiate between osteoporotic and pathological fracture? This is the first question. So if you can answer this, and then I'll ask a second one.
Okay, I think mainly, as I said, I rely more upon T2 weighted images. In T2 weighted image, we can see that the fluid will appear as dark. So if there is a hematoma, it will appear as, sorry, not dark, white lesion. And that's how it is. And in the T1 image, the hematoma will appear dark. If there is a fracture, you can make out that way. And if it's a pathology, you may have multiple vertebral involvement, which might not have fractured, but there is involvement of the multiple vertebrae.
Yeah, and another differential maybe in a pathological fractures, most of the times you have something soft tissue shadows. You might have
correct.
shadows.
You are right. Yeah.
And in canal, you can see a pathological fracture. Usually, you can see that classically described as a W sign. Whenever you have a maybe a tubercular or maybe secondaries, so the epidural soft tissue looks like basically a W sign, and in osteoporotic fractures it's like a U. So that is again another differential thing. And the second question is, how do you differentiate tuberculosis from other types of spondylodiscitis?
Okay, well, most often the tubercular spondylodiscitis, there will be destruction of the body in a paradiscal area. Whereas in the pyogenic spondylodiscitis, usually there will be fluid within the disc and less involvement, less destruction of the vertebral body. That is how we usually differentiate. And usually in pyogenic spondylodiscitis, there is no kyphosis. Whereas tuberculosis, usually there is a gibbous deformity when there is involvement of two vertebrae.
Okay.
Also, similarly, in case of brucella, also we get destruction of the bone, resulting in gibbous deformity. Okay. Radiologically, we cannot differentiate brucella from tuberculosis. It's often based on detection of brucella in the latex agglutination test.
Okay, I think I can see Dr. Yogesh here. Dr. Yogesh, can you take up that question again? What are your comments on that?
I think more or less most of the points have been covered. There's only one additional point in that as to differentiating the in the pyogenic versus the tuberculous, which I already mentioned in the talk, and that is in terms of contrast enhancement. If there is homogeneous enhancement, it is more indicative of tuberculosis, whereas if it's a heterogeneous enhancement, it's more in favor of pyogenic. Also, in tuberculosis, there is we see the possibility of intraosseous abscess, whereas as Dr. Shamsundar said, in pyogenic, it would be more of abscess which is restricted to the disc space. The extent of paraspinal abscess is also higher in tuberculosis as compared to pyogenic. So these are the broad differentiating features. Hello.
Yeah, thank you, Dr. Yogesh.
So we have one more question here. What percentage of suspected osteoporotic vertebral fractures usually show malignancy or infection?
Well, I'm not sure about the percentage, but the most common is osteoporotic compression fracture. The pathological variety are less. What is your view, Dr. Yogesh?
Dr. Yogesh?
Yeah, I'm sorry, I missed the question. Apologies.
No, percentage of malignancy.
Suspected osteoporotic vertebral fractures can show malignancy or infection?
I think if you know, as a
as a part of the normal protocol, whenever we examine a patient, it's never just an X-ray or the MRI. Invariably, almost all the times, there is an associated blood biochemistry that we do. So in my practice, that's the protocol that I follow, and it's never been that I have missed out on identifying a osteoporotic or a non-osteoporotic fracture which mimics an osteoporotic fracture, because invariably I do the entire workup for practically all the patients. Have I made myself clear? Did I answer the question?
Yeah.
Have I? Yeah. Okay.
Yes, yes.
Fine.
So is it necessary to biopsy all cases of osteoporotic vertebral compression fractures before doing any intervention?
Well, I'll say that if you are doing an intervention, always take a biopsy. Rather, the reverse, I'll say.
Okay. So any more?
Can I add to that?
Yes, yes, Dr. Yogesh. Yeah.
So as I said, invariably, most of the times we do a proper blood biochemistry and everything prior to initiating any kind of anti-osteoporosis treatment. So in my practice, ever since the beginning, I have not been, very fond of vertebroplasty, kyphoplasty, and I have hardly done any intervention in these kind of patients. Only in a rare patient in whom there is a deficit due to osteoporotic fracture have I intervened, in which case, of course, we do a biopsy. But otherwise, most of the times, I mean, osteoporotic fracture per se does not qualify to be, biopsied. Of course, there can be various ways of looking at this, but this is just my perspective.
Okay. Okay. So Appaji, any more questions?
Nothing much. Last so many years, I will say we have missed two patients who had myeloma. Hello, can you hear
Yes,
me?
yes, Appaji. Yeah.
Yeah, please.
So, who had myeloma, we have been treating them as osteoporotic fractures, but since the pain was persistent and progressive, a repeat MRI after 6 months showed some soft tissue, wherein we had to do a CT-guided biopsy, and we got it as myeloma. Otherwise, I have not seen a huge. I mean, if you do, like Yogesh says, if you do proper blood workup and all the imaging modalities, you may not get confused with osteoporotic fractures and the other pathological.
So how many of us do the routine serum electrophoresis in osteoporotic compression fractures?
Yeah, I do.
Not me. Yeah.
I do, Gururaj.
Yeah. I also do in all osteoporotic fractures.
Yeah, I mean,
serum
electrophoresis even we do. I mean, it hardly takes anything. I mean, just a blood sample. We would routinely do a serum electrophoresis.
Yeah.
And there are two things I would like to highlight more here. In especially in myeloma, there can be a solitary myeloma where only one vertebra is involved initially at the time of presentation, and also sometimes there are non-secretory myelomas which do not secrete the kappa and lambda chains.
Definitely. Yeah. So
in those situations, good, thanks for bringing out that wonderful point, Dr. Shamsundar. But in those situations, the MRI will be quite distinctive. It will certainly show some amount of ballooning of the posterior cortex. There will be a homogeneous change in the signal intensities in the MRI, particularly in the T1 weighted images. There will be other telltale signs which will, let us know. There will be, at least when you do all the tests together, if all don't fit into the picture of a osteoporotic fracture, then you certainly would want to investigate. And I agree that in those situations, in a solitary plasmacytoma, the blood biochemistry may still be normal, but the MRI will definitely tell you that this is not looking osteoporotic. This is something else. So in those situations, we of course go ahead and do a biopsy or whatever else that is necessary.
And Dr. Shamsundar.
Yes, Gururaj.
Like for the sake of scoring a solitary lesion or for the sake of having the scores for management, Like, do you do further investigations, or you don't tend to do scoring?
No, I don't do the scoring.
Okay. So, Dr. Yogesh?
Yeah, I'm not too sure. Was that question specific only to osteoporosis or for general thing? If it is for a
not
general thing,
for
I
a solitary
score,
lesion. For a
I do.
solitary lesion, yeah.
Yeah. I mean, this is something routine which I do a routine CT scan for these patients, and I do a SIN score because a SIN score requires a CT scan. So many a times, yes, if I am contemplating surgical intervention, or either ways, I am deciding whether the patient warrants a surgical intervention or otherwise, I certainly add in CT scan to the investigations so that I can see the extent of osteolysis, I can see the involvement of posterior elements. So that would allow me to do some decision making.
Sarvadeep, are you there? Yeah. So, you spoke on imaging on spinal tumors. So what is your take on that? Like, we routinely need to do scoring, or we can manage these patients without scoring. So, what do you do, and what literature says about it?
Yeah, so scoring is excellent way to do. I mean, I work in a teaching hospital, yeah. So everything's, even like a basic tibia fracture is classified and we write it in the files, yeah. But if you are picking up a specialized branch like spine, it is very important to follow scoring. And if you follow these classification and scoring, and you correlate with your radiologist, then you can really actually guide the children, your residents, how to go about it. It just gives better than anything, just to use your own key, my way of doing it. I mean, in spine, I think so. It's not like trauma. Yeah. You can't say my way of doing it. It's just better to follow these standards which are published everywhere in the world.
Okay. So, do we have any more comments or questions, or anybody wants to say anything more? So, in that case, we will start the next session exactly at 11 o'clock. So we have 20 minutes break now. So we'll start exactly at 11 next session. Thank you.
Thank you, Gururaj.
Gururaj, this login would be the same?
Login would be same, Kamran. Same.
Thanks a lot. Bye.
Thank you, Gururaj.
Thank you. Sai? Sai, can you hear me?
हाँ बोलो. Yes sir, बोलिए ना sir. Yes sir, I'm there. Tell me.
Oh, okay. So can we start, Sai?
Yeah, we can.
Okay.
Sanjay is there. Sanjay.
Yes, sir.
Yes, Sanjay is also there. We can start, sir.
Okay. So again, I welcome all of you for this basic spine workshop of IOACON in association with Association of Spine Surgeons of India. So we are going to morning session. We had lectures on basic radiology of spinal pathologies. So now we are going to start with our video sessions on spinal surgery techniques. So the first video is going to be by Dr. Manish Kothari. So can we have the video of Dr. Manish Kothari?
Hello everyone, this is Dr. Manish Kothari. I'm a spine surgeon at Jaslok Hospital, Mumbai. Today we are going to discuss about patient positioning in spine surgery. Mostly it will be about prone positioning. Now a good position will make your job easy and perfect, just like a perfect cover drive. But an improper position can land you in soup. You can have unexpected complications. Now just looking at the literature, you look at the number of studies published with regard to the number of complications. Just have a look at the complications. So there are so many studies regarding visual loss, conjunctival swelling, corneal abrasions, compartment syndromes of the eye, angle closure glaucoma, even double vision diplopia. There are many others regarding vascular complications like cerebral infarction, embolism, bowel ischemia, and so on. Then there are others which are common to other positions also, including which include nerve palsies, compartment syndromes, and this one particular position called the knee chest position has had the maximum number of complications. Now, to understand why these complications happen, we need to understand that prone positioning in general anesthesia changes the physiology of the patient. It causes a decrease in cardiac index. It increases the airway pressure, it increases the abdominal pressure, and causes unnatural pressure points. When the patient is positioned prone, there is the abdominal pressure causes increase in the inferior vena cava pressure, and through the Batchen's plexus, this causes increase in your epidural pressure. These epidural veins are valveless, muscleless, thin-walled, very easy to rupture and difficult to coagulate, and cause a nightmare to the surgeons. It causes increased bleeding, poor operative field. You may not be able to complete your job. It causes the surgical duration will increase, and of course all your pressure points will start becoming important as the time increases. Now, to avoid these, we need to be very clear regarding how to achieve a safe positioning. So the goals are that there should be adequate padding of all pressure points head to toe. The abdomen should be free. You should freely be able to pass your hand under the abdomen and make sure it is nice and hanging. And you can even use the position to enhance or rather help you during the surgery. We'll see to it later. Now, when we talk about the position, the care starts right from the supine position when the anesthetist is starting the induction. For example, in this patient with ankylosing spondylitis, the trolley is straight, but the patient is given a contoured position as per the shape of his spine. Another example is patients with severe cervical stenosis. You want to avoid hyperextension during the laryngoscopy and the passage of the endotracheal tube. This can cause catastrophic quadriplegia. From Now, turning the patient from supine to prone is a delicate process. It has to be a slow, smooth event with everybody on the same page, and the lead is taken by the anesthetist who is holding the head. The head, neck, torso should move as one unit. It should be maintained in neutral position. The head should not twist while the body is being turned on one side. This is especially true in cervical stenosis or trauma patients with unstable injuries. Of course, all pipes have to be free, Foley's, your IV lines, your arterial lines, and so on. Now, once the patient has been positioned prone, you want to look at all the pressure points. The most important, I would say, is your eyes. They have to be very carefully positioned. The eyelids have to be shut and taped, or you can add some ointment. There should be absolutely no pressure on the orbits around the eyes. Some people use Mayfield and cervical tongs, which is perfectly fine. Make sure that the head is not dangling in any position. Use supports to keep the head and neck in neutral position. The head should be above the heart level so that there is no venous engorgement in the area through the superior vena cava and in the face. And when you are scrubbing the patient, make sure that none of the scrubbing agents trickle down into the eyes. This happens very commonly during posterior cervical surgery. This one position I would highly not recommend, should be avoided, is turning the head on one side, especially the anesthetist does that during lumbar surgeries. In the young flexible cervical spine, it may be okay, but for older and arthritic patients, this may be disastrous. There are better positioning systems available now very commonly. These are various ways you can for the headrest. I personally like to use this one with a mirror, where you can see the eyes of the patient through the mirror. Next, you want to look at the neck position. It should be in neutral position as much as possible. You should avoid hyperflexion or hyperextension. Then we come to the shoulder. The shoulder should be in 90-90 position with about 20 to 30 degrees of forward flexion of the shoulder, not in complete, not in abduction. The problems in bad positioning can cause brachial plexus injuries, shoulder pain, and rarely thrombosis of the vessels. Next, we come to checking all the bony prominences. You want to look at the elbow for your ulnar nerve. Make sure there is an axillary pad under the axilla. Similar, a good Gamgee pad or a gel pad to protect the lateral cutaneous nerve of thigh. Protect the knees, protect the ankles, and the hip and knee should be in relative flexion for most of the cases. So pressure points should be avoided. This will become very important as the duration of the surgery increases. Now, other thing that I always like to talk about is to check the airway pressure. So always ask the anesthetist, what is the change in airway pressure from supine to prone? A very large change in airway pressure and a longer duration of surgery can lead to disastrous events. The change in pressure can be because of bad positioning of the bolsters. If they are too close, then it will cause pressure on the abdomen. If they are too far away, then the patient will sink in between the bolsters and cause abdominal pressure. The ideal position is the anterior superior iliac spine is well rested in the center of the bolsters. You can also keep bolsters horizontally if you may wish. The patient should be relatively thin, or rather not too obese. The next thing that I always also look at is the tidal volume. So a normal accepted values of tidal volume in anesthesia is roughly around 6 to 7 ml per kg. So if you see this, my patient I was doing a few days ago, he was a 60 kilos patient, but his tidal volume given was 50 and his airway pressure was 29. So I asked the anesthetist, can we reduce the tidal volume? He was very happy to do so. And once we've done the tidal volume to 450, there is a drop in airway pressure by 3, which is going to make very significant difference in my epidural pressures. This becomes very common, or rather problematic, in especially patients with large bellies. So a way to avoid or rather keep the abdomen free is use a knee chest position, but make sure that there is not too much pressure at the popliteal angle and there is support for the buttocks so that the weight of the body is not on the legs. Other way of doing this is you can stack up a few pillows, tie them up, and then keep your bolsters on top of the pillows to raise the height. Other way, with especially with large, short patients, I personally like to use these contoured bolsters, which are contoured for the thighs as well as the abdomen. Now we look at how to use the position to our advantage. So we can use something called as Wilson's frame for a microdiscectomy, where you can jack up the patient, but you should not do it too much. It should be very mild jacking up, just enough to open up the space. Otherwise, it will cause your increase in abdominal pressure significantly. Next, you can do the same thing by breaking the table a bit, about 20 degrees or so. That will give you good opening up of the thing. But it is reverse in a spondylolisthesis, where you want to give thigh extension so that helps in your reduction during the surgery, and you can achieve good reduction. If you're doing large tumors, then you want access in between the legs, which will give you a complete complete turnaround of the mass. For posterior cervical, horseshoe is what many people use. But I always recommend that it should be used with some form of traction to stabilize the head. Otherwise, the head becomes too wobbly and it can cause complications. For example, this is my own patient. This was before the surgery where the patient was positioned and I had given traction as well. But you can see at the end of the surgery, the patient had slided down from where he was supposed to be to where he is now. Because he had traction, there was no major event and the patient got away with this. I personally now like to use radiolucent Mayfield clamps, which allows complete access to your C-arm as well, and you can do all sorts of instrumentations. In an anterior cervical surgery, you want the patient to be raised above the table so that the C-arm, the images can be seen properly. So you add a head ring under the head, bolsters in between the scapulae. You strap the shoulders down so that they don't obstruct your C-arm images, and you want to give slight extension at the chin so that the skin is stretched out and your access becomes easier. Other important point is that your C-arm management should be precise and well thought of before you start draping. Sometimes you get these extreme angles with the C-arm, if your positioning is correct, it should not be a problem. You have to have enough distance to look at both AP and lateral and whatever views you want. Especially during an S1 screw, you need those extreme lordotic angles, and the base of the table causes a problem. For example, in this patient, I would absolutely not be able to take an AP view or whatever I try. So this should be planned well in advance. So to summarize, padding at all important points is necessary as we discussed. Make sure the eyes and the abdomen are free. For obese patient, you have to plan well in advance. Make sure your bolsters are of the right size and of the right density. Sometimes the bolsters are very soft and they will just sink down. Make sure your C-arm management is also taken care of. You should be able to see all that you want to see with the C-arm. And you can always make sure that the position that you give will aid your surgery. Thank you very much.
Thank you, Dr. Manish. Do you have any questions for Dr. Manish, please? Yeah, Manish?
Yeah, hello.
Can you hear me? Yeah, Manish.
Yeah.
Can you just elaborate on how do you position the patients when there is instability?
Right. So instability, say you're talking about, probably I'm talking about trauma here with say a fracture
dislocation. Trauma, maybe a extension distraction type of injury in ankylosing spondylitis, where
exactly.
they have a lot of instability. Yeah.
So there are specialized tables available. Unfortunately, we don't have here in India, but you have to maintain an inline position of the patient. It has to be, as I said, the head, neck, torso has to move as exactly one unit, and I make sure there are at least 6 people to transfer, to turn the patient. It should not be done with one on the other side, one on the other side, and one at the head, one at the toe. That's a disaster waiting to happen. There should be 2 on each side, one at head and toe, and everybody has to move. So I turn them around by 30 degrees, and each point we make sure that there is no twisting of the spine, and then you can make sure that the head is stable. This is particularly important in cervical spine, where the chances of things going wrong is very easy. Other part is you look at the shape of the spine. What is the shape of the spine that is likely you are going to get? If it is a distracted spine, you make sure that your bolsters are also going to assume a roughly the same shape. You don't want to give a straight bolster in something which is which is very kyphotic. You want to contour your bolsters or the shape of the bolsters according to the shape of the spine, and which will help your positioning in a neutral position. So always avoid horizontal bolsters in such patients. I always use vertical bolsters along the length of the spine, especially in thoracolumbar kind of injuries. Hello.
Thank you.
Dr. Gururaj?
Yes, for fusion surgery.
Yeah.
Hello. Yeah, for fusion surgery is to maintain the lumbar lordosis other than hip extension.
Yeah.
Do you do anything else for that, or how do you position them?
I keep them in neutral. I keep them upside. I said I had shown one of my bolsters which are used for fusion surgeries. The abdomen is free, and I make sure that I've regained some part of the lumbar lordosis. So that does part of the job, and part of the job, of course, is with the cage and the rods. So I make sure I don't flex the spine as you would do in a micro discectomy. You keep it in neutral and make sure there is lordosis. You can see the lordosis as you see the as you position the patient.
Okay. How do you have you had any complications because of positioning, and how have you managed them?
So common ones are lateral is the myalgia paresthetica. You see them quite frequently, but now I make sure you pad that area very well. But even despite that, in obese patients, you sometimes still get the myalgia part. You off and on, I have done very long cases. You can have some pressure sores, some skin peeling off on the skin. These are the common ones that I will see off and on once in a couple of months. And one that I've had was like a kind of saved me, as I showed in this picture, where the neck was almost dangling. It's got saved because of the traction. So I've stopped using horseshoe completely. I don't recommend anyone to use horseshoe as long as possible. Not many centers have Mayfield clamp. So wherever you can, if you're using a horseshoe, always use traction.
Okay, and when you position for lumbar surgeries, do you take a note of your cervical spine, how it is positioned?
So as I said, whatever is a surgery in the lumbar or thoracic spine, my head and neck is always neutral on that prone view.
Yes.
That prone view is very important because it allows you to adjust the height of the face mask, the sponge. You can increase and decrease. You can also stack up some bed sheets, folded bed sheets under it. The main important part is that you can see the eyes. So I think you cannot afford to have any form of eye complication in today's day and age. It's very difficult to explain to the patient. Touchwood I've never had, but also because I use all these precautions. I never turn the head to one side, so I didn't have a picture to show. And the eye, one thing I think is you should never have an eye complication.
Okay. So thank you, Dr. Manish. So can we move to the next presentation by Dr. Rupinder Chahal? It's on minimally invasive fenestration discectomy. Video on minimally invasive fenestration discectomy.
Good morning. I will be now speaking on minimal incision fenestration discectomy, one of the most common surgeries as a spine surgeon that we do. Let me take you through a representative case. This is a 41-year-old gentleman, a teacher by profession, has a right buttock and a leg pain for 3 months. On examination, his SLR is 30 degree, motor functions are normal. There's a decreased S1 dermatomal sensation on the right side and a diminished ankle reflex. Bladder bubble is intact. We position the patient prone on a bolster. I usually like to have my bolsters in a vertical direction. I don't want to recreate more lordosis because then the disc interlaminar space decreases and it becomes difficult and you have to cut more bone. Make sure your eyes and the nose and all are free and your arms are not stretched and the bony prominences around the elbow, the wrist, the knees are well padded. And your knees are a little flexed, so your toes do not fold in. That causes a little post-operative pain in such patients. And the genitalia are free. All your wires, the quadri, the Foley's catheter and all are fixed well. So, and a radiolucent part of the table is visible. So, so when you're marking the level, you have a free movement of your C-arm. That is very, very important. Once preoperatively, you mark the level with a needle. Needle should not be long, should be in the paraspinal regions that you don't go into the dura. We are just marking it for the video's sake. It is important that you mark the midline. This is important in a very obese person where you can't feel the midline spinous processes and you may tend to give incision little paraspinal and in that case, to reach the level, you may have to extend the incision, which becomes an issue because microdiscectomy is one surgery, you sell the patient as a minimum incision. So we go little paraspinal. We don't give the incision paraspinal, but retract the skin literally on the lateral aspect, give around a 2 centimeter incision. And once that incision is given, then you, with the COPS elevator, and leaving a small cuff of muscle along with the fascia on the medial aspect, you go into the interlaminar space. Once you are in the interlaminar space, you do apply this Taylor's retractor. Let me tell you about this retractor. This is an L-shaped malleable retractor that hinges into the pars or the facet on the lateral aspect and pushes the skin down. So good part is, unlike the conventional hemilaminectomy retractors, it doesn't have the medial prong which can fracture the spinous process. And if you are doing an over-the-top decompression, it does not hinder your vision on the medial aspect. And once this retractor is in place, it is important that you check your levels again because level is an important, wrong level is a big issue. And we're using a Carrison to check the levels. Once you are in the right interlaminar space, it is important that you take out all the soft tissues from that area before you reach the ligamentum flavum and mark your superior and inferior lamina with the cautery. It is important because it becomes easier to use a bar on an osteotome to do a laminotomy. But make sure you do not damage your facet joints with the cautery. So you have a superior lamina of L5 on the superior right aspect and S1 on the down. Using a Carrison, you remove all the soft tissue, fascia and the fat over the space. You can see a yellow shining ligamentum flavum. We are just holding the cuff of that medial muscle to have a good vision. People use normally to detach the superior ligamentum flavum, you can use a sharp curette. You can do a partial laminotomy with a bar or with an osteotome. And in L5S1, even you can make a space in the ligamentum flavum, a window, and work from there because it's a wider space. To remove this ligamentum flavum, people tend to use a 90-degree Carrison because then the ligamentum doesn't slip. But most of people don't prefer that, using it's a large footprint and you have to go deep into the canal. Other tip to remove this ligamentum flavum is that you work at the edges. So you work it around the bone. So once you are taking a cuff of the bone with the ligament, it becomes very, very easy to remove it, like we're doing here from the inferior lamina. It is also important that you clear the lateral aspect, because then it is very easy. If you can identify the traversing route, then you know you are safe on one side, and you can use the bigger instruments to remove the disc. So that from the lateral gutter, we are removing all the ligamentum flavum. It is good that you remove every free fragment of the ligamentum flavum, because it can roll back and cause stenosis at a later aspect. Using a blunt dissector, we are retracting the neural structures on the lateral aspect, on the medial aspect, sorry, and identifying the disc. Using a cottonoid helps you clear the field. It gives you a tamponade effect. It pushes the neural structures away from your operating site. So once the disc space is identified, and using a cottonoid, you retract the neural structures medially and clear the space. It is important that you identify the superior and the inferior end plate, because then you can give your incision in the middle of the disc. It helps you in healing. Otherwise, if there is a rent or an end plate fracture in most of the cases in the superior and inferior, then probably you have to give another incision and connect both of them to do a complete job. And healing may become an issue in those cases. And nowadays we do not give a cruciate incision. So here it is, the annulus you see is already torn. This is just the PLL we have incised and the disc is popping out. At this point, you are tempted to just pull this out, but ideally you should tease this whole fragment out. And the best instrument to do is a blunt hook, not a sharp hook. The sharp hook will cut through the disc, and you may even catch your root or the dura with it. So once you have a sufficiently free fragments clearly teased out, then depending upon your size of the fragment and these, you can use a number 1, 2, or 3 pituitary rongers to pull these fragments out. As I already told you, your suction is an important dissector. So make sure your suction is not sharp. It is not over the root, but it's just pushing the root away. And under vision, this is an important step. So whenever you're pulling, make sure your root is far away from your instruments. This is the major thing that happens, is that people do catch up the root and damage it. So, and these cottonoids soak blood and swell up and need to be replaced a few times during the surgery. Otherwise, they impede your vision. So once you have cleared all the space, it is important that if you take out these large fragments and then compare it with your MRI findings, another step we do is we use a suction tip and flush a lot of saline into the disc space to flush out the free disc fragments. And once those are done, your disectomy is complete. Remove all the cottonoids, look for all bleeders, and look for small fragments of discs which may have gone under the root, may cause irritation, and your soft tissue falls back and you close in layers. Another technical note on an axillary disc. This is a 39-year-old female with the cauda equina syndrome, decreased power in right limb, and large posterior central disc at L5S1 level. And we mark the level, and as in the previous case, intraoperatively level is confirmed. And this is we are now in the axilla between the S1 and the S2 roots. This is a very large piece. The issue with this is now you're working under between the two discs and you're using large instruments. There's always a chance that you will catch up one of the roots or give a traction to the roots. And you have to be very, very, very careful. And in young patients, sometimes these pieces are very, very sticky, and you have to just keep pulling it and they refuse to come out. So another trick is to convert this axillary disc into a shoulder disc. So you just retract the S1 root medially, identify the annulus, give an incision there, connecting it with the rent which is previously seen. And now you can use much bigger instruments, because one side of your approach is relatively safe and you have to only watch out for one of the roots. The other part is this part of which is just coming out through the axilla, refuses to go in. So you can do is take a cottonoid and keep pushing this piece of disc material back into the disc space, and then go back into the shoulder approach again and try taking out this piece. This is important that you just push it back in the disc space, and now coming back, you just pull it, the cottonoid is out, and you have the S1, S2 and the thecal sac, but it's nothing on the lateral aspect, so you can freely use a large size instruments. And it is important to just catch hold of the root and pull it, and make sure that your root is free when you are just holding this disc fragment, and this large piece has just come out. Thank you.
Thank you, Dr. Rupinder. Rupinder. Hello? Dr. Rupinder, can you hear me? Rupinder?
Dr. Guru is not online.
He's not online. He was.
Yeah.
Actually,
I didn't see him also. Yeah.
Connected.
He was there. Okay. So if he's not there, Partha, I can see you. So can you just tell the delegates that how to avoid doing a wrong level disc? What precautions do we take?
All right. So commonly when you're doing a minimal invasive discectomy, in whatever shape or form, your ability to go to a wrong level is very easy, because the distance between the skin and the lamina is anywhere between 7 to even 10 to 12 centimeters, depending on how obese your patient is. So even if you slightly deviate in angle, you're likely to go to the higher or the lower level. So rule number one, what I do is before I mark the level, I make sure that there is a needle that is entirely perpendicular to the ground, and I see that on C-arm to know what level I marked at. Before we do any kind of fenestration or removal of bone or flavum, it's important to check the level again, right? And when I finish the discectomy and the root is free, again, I make sure that I'm at the level that is checked on. The common fallacies are, of course, that if you have a sacralized L5 and you have an L4-5 disc, sometimes you may go wrong. There are issues whenever you have a very obese patient, because your imaging may not be great. So it's important to check and check again, because this is the most common mistake that we can make in a minimal invasive discectomy.
Okay. So do you have any like tips to identify a level when it is sacralized or lumbarized? Do you come from like you do a whole spine MRI, or how do you really mark your levels?
The easiest way to do this would be still to count the number of open discs you have on the MRI from the lower level, rather than to count from the top, because you're using a C-arm to localize in theater. And so it's like impossible to count from the top. You would be much better off counting from the bottom. You need the MRI level by counting from the top, because it correlates with the involvement of the root. So clinically, when you want to correlate it, it's important to know whether it's a sacralized L5 or it is an L5-S1 disc that is open, because you can correlate the neurological deficit with the level of the disc. But intraoperatively, if you want to correlate the level, you need to count from the last open disc that you see on the MRI and you can see that open disc. Whether or not it's mobile doesn't matter. For example, if you have an L5S1 where the L5 is sacralized, the L5S1 disc will be pristine, but it will still be open most of the time. So you can count that as the last disc and then count from that.
Okay. Do you have any tips for a large central disc? So we all have experienced this problem. There will be a huge central disc, and it's really difficult to sometimes find also when you go inside. So how to go about this large central disc when we do this minimally invasive fenestration discectomy?
So the important thing, Guru, over here is that if you have a large central disc, there are two types of large central discs that you can get. One is the acute large central disc, which is essentially an extruded kind of disc, and that's a large free fragment kind of disc. And the other is the chronic central disc, which has been there for a very long time, which may be calcified. So these two require entirely different approaches in the way you do them. The acute kind of extruded disc is a little bit easier to work with, but the trick remains that it doesn't mean that because your incision is small, it is necessary to do less bone work. If you need to remove more bone, especially when you go higher up, L4, 5, L3, 4, if you need to remove more lamina, remove more lamina, because you don't want to traumatize the dura during your retraction. You will be retracting a lot more, but you also have to factor in whether this disc is large central inferiorly migrated, large central at the level of the disc, large central superiorly migrated. If it is large central superiorly migrated at almost all levels, you will have to remove some portion of the lamina. The second thing is, it's all right to do a central decompression in these cases. It's not necessary to stay entirely on one side, especially if the disc is hard. If it is an extruded disc, it tends to slip out from underneath the dura. But if it's a hard disc, that may not really be possible. So you may have to actually go on both sides. If it's a large extruded disc, I would stay on the side of maximum symptoms and remove it from that side. But if it's a large central disc, in that case, then I would look at both ends, both sides.
Okay. You touched upon the higher disc. So how do you take care of your parts, not to cause a iatrogenic pars lysis, or you take out the whole facets? So what are the tips to preserve the pars or the facet?
So if you're going up more than L3-4, either an L3-4 or an L2-3 disc, this is a slightly more difficult disc to handle because the disc is almost at the level of the mid of the lamina, right? So your expectation will be that you have to remove quite a bit of lamina. In that case, it's all right to extend your incision just a little bit more. We shouldn't be fighting for conserving a skin incision of a centimeter more, which will give us a much better exposure of what is happening. For fear, it's more dangerous to damage the pars or the facet or the nerve root than it is to have an incision which is a half centimeter more, especially when you're starting off. As you get more experienced with it, maybe yes, you can stay entirely within a small incision even at the higher level. But more importantly, you can feel your way to the lateral part of the pars if you just slide any probe or anything along the lamina going superiorly and laterally. It will dip down where the pars is, and there will be a soft spot there. So that is the lateral extent of where you are. The other part of it is you don't need to remove so much bone to see the lateral border of the dura. The minute you see the lateral border of the dura, there's no necessity to remove any more bone. If you just follow these two things, you'll probably stay adequately medial so as to not get the facet loose or damage the pars. You're on mute, Guru. Can you unmute?
Appaji, are you there? Dr. Appaji Krishna?
Yeah, Guru.
Yeah. Dr. Appaji, in this fenestration discectomy, especially it's a small incision and we tend to do it smaller and smaller these days. So if you have an incidental durotomy in these cases, how do you manage them?
Yeah. So in microdiscectomy, so it depends on where the durotomy has happened. If it is anterior, you can just pack it with fat graft and put sealant. If it is posterior and if you have skills to repair, I will suggest a bite or two. If it is a very small puncture wound, these are the dangerous ones which keep on leaking. So make it a slightly larger wound and try to take 2 bites, or pack it with fat. You can even insert fat into the dural sleeve and then seal it with a sealant, either a T-seal or a Duragel foam with T-seal. This is how you'll make, if you are, the main aim should be to avoid such a mishap, because these are the ones which will keep irritating. These are small puncture wounds which you'll make in microdiscectomies, which will keep, the longer incisions are actually easier to repair and easier to manage than these puncture wounds in dura during microdiscectomy.
So, no, what I mean is,
if I made a, yeah, that's what. So if I've made a puncture, it depends on where I made it. If it's in the shoulder of the root, that's a worst part where you can have, because that can be recurring quite often. It's very difficult to manage. So you can actually make an incision posteriorly, pack it with the fat graft, put T-seal, and then repair the dura. If it is posterior, it's very easy. Dorsal dura, it's very easy. You can still take a bite. If it is a longer wound, you take a bite, or you pack it with fat and put T-seal. The worst part is at the shoulder of the, like child was showing, if you are doing an axillary disc and you are just pulling at it, you can actually tear the root away from the dura. So that's another place where you can have a dural puncture, and these are very, very difficult to repair. Most often it is not repairable. You just have to pack with fat and fascia graft and then repair it with T-seal. You cannot take bites in these areas.
Which is the step which is most, which is the step where the most likely that we can have incidental durotomy? Which is that one step or two step?
Yeah, the most important step is, like Partha was telling, identifying the lateral border and then dissecting the lateral border of dura out from the disc. Most often, if there is an extruded disc or a sequestered fragment, these are slightly adherent. They are not fully adherent, mind you. If you are very careful, you can, you should avoid injuring. That is where you can injure the shoulder of the root, where you will just try to mobilize. The root will be more taut than the dura, so the root can still be adherent and you can make puncture wounds. Second step is when you will insert your pituitary forceps or the disc ronger to pull out the disc. You have to make sure that you are not anywhere near the neural elements, and you have to make sure that, that's where the illumination and microscope or the magnification matters. So you have to make sure you're not somewhere. These are the two common areas where you can injure. One is while dissecting out the dura away from the disc. Second one is the disc punch.
Thank you, Dr. Appaji. So for the want of time, we'll move for the next presentation. That is by Dr. Priyank Patel. He is going to show a video on decompression for lumbar canal stenosis.
Good morning, everyone. I'm Dr. Priyank Patel, and I'll be speaking to you on laminectomy. Laminectomy is a procedure which every spine surgeon should master. In fact, it's the first surgery which every surgeon is taught during their fellowship. So let's get to it. Pre-operatively, make sure that you use all the imaging modalities that you have at hand to plan the exact extent of decompression. This will make your surgery very specific, quick, and atraumatic, thereby avoiding the treasure hunt syndrome. In positioning, remember that you have a good head support along with the Ryle's tube which is passed. You can use a foam head support, or you can use attachments to tables with tongs, or some newer jelly head supports. Make sure that whatever you use, you have adequate and good eye padding. Keep the abdomen free from the table with the help of bolsters. These bolsters can be arranged either horizontally or vertically. You have newer generation tables that are available, like the Jackson frame, which has got multi-point fixation and the abdomen is completely free. Remember, when you're positioning the patient, The arm should not be abducted. This causes traction to the ulnar nerve, and sometimes you can land up with ulnar nerve palsy. Once you have positioned the patient, you mark the area which you want to decompress with the help of a needle. Confirm this under a C-arm. Some people prefer to infiltrate with the help of some vasopressor diluted in saline, and it can be done pre-surgery. Some people post-surgery before closure infiltrate in order to give a good analgesia. The advantages are it decreases the bleeding during exposure, and it also helps delineate the tissue planes. But some disadvantages are that if your surgery is prolonged, eventually the bleeders open up later, and in some cases it could cause some skin problems. Once you are ready with all this, you can take your incision. The approach to laminectomy is the posterior approach to the lumbar spine, where a central midline incision is taken. Once incised, you start taking off the paraspinal muscles from the spinous process. Try to remain subperiosteal and not enter the muscular planes in order to avoid unnecessary bleeding. So here you can see that the patient has been positioned and the incision has been taken. You see how we are using a periosteum and slowly, with the help of a cautery, separating out the muscles very close to the bone. So we are trying not to get into the intramuscular plane and cause unnecessary bleeding. The ideal amount of dissection is till you can identify the bars on either side. You can use a simple rubber catheter to prevent any damage to the skin by covering the cautery tips. So dissect laterally, keeping the pars as the outer limit and not damaging the capsule. This is a very important point. Once it's done, you start removing the spinous process and then thin down the lamina to make decompression more gentle. So after an adequate exposure, here what we are trying to do is identify the last mobile segment. So whenever you are doing a decompression right up to the sacrum, you know that L5S1 should be your last mobile segment, and this helps you confirm your level. In a smaller incision or where you're not going up to the sacrum, you can use a C-arm to confirm your level at this stage. Once your level is confirmed, you start removing the interspinous ligament with the help of a knife and nibbler. The next is you take a spine cutting and start removing the spinous process. You can use a nibbler to clear out the remaining part of the base of the spinous process and any soft tissue which is around. Once that is done, use a cautery to clear out all the soft tissue and delineate the bony landmarks. Try not to burn the facet capsule, and after that you can start thinning off the lamina with the help of a nibbler or the help of a burr. This makes decompression easy later on as the efforts with the forward reduces. Use ample amount of bone wax to seal off all the bleeding edges. Then you can start taking a ronger. Usually you start off with a number 3 or a number 4 ronger. In tight stenosis, try sticking to number 3, whereas in moderate stenosis, you can take a number 4. Start taking off the lamina bit by bit, making sure that you don't end up biting the dural sac, which is just underneath that. When using the kerrison, it is very important that you have a good grip and good control over your instrument. So your left hand should be holding the kerrison and should be placed on the patient so that you have a good control over your instrument. As you move further with your decompression, you can start packing cottonoids under your lamina to safeguard the dura underneath that and to start slowly separating off the ligamentum flavum from the lamina. So the cottonoids or patties help create a smooth plane under which you can start passing your forwards. Slowly and steadily progress along and start removing the remaining part of the lamina. The suction is one another tool that can sometimes cause dural injuries, especially if the end is rough. So you can cover it with the help of an Indian rubber catheter and prevent dural injuries because of that. A Penfield or a dura retractor also helps creating plane in between the lamina and the dura. Make sure that the surgical site is free of any blood so that you can visualize what you are taking. Watch out for innocuous looking fibrous strands between the dura and the ligamentum flavum. Don't be in a rush to identify the flavum and pull it out, because sometimes there are strands which can take a chunk of dural sleeve along with it and causing unnecessary dural injuries. So you can see here how we are slowly teasing out the ligamentum flavum. You can use cottonoids or Penfields at this stage to help create a plane between the ligamentum flavum and the dura. You can also use a disc forceps or a nibbler to separate out all the ligamentum flavum from the dura. Make sure that there are no adhesions, and if there are any, use stilies to separate it out before you pull them out. So laminectomy is not the surgery, it's just the approach. What you want to do here is you want to decompress the spine. So in order to decompress the spine, you have to remove the central compressing element, and also you have to remove the elements which are compressing the lateral recesses. So in case of laminectomy, what you do is you just remove the central lamina, but the lateral recesses are not decompressed. If you want a good decompression, you have to remove a part of your medial facet which is hypertrophied and is pressing on the exiting nerve roots. So this will complete your decompression. So here you can see a good central laminectomy is done, and I'm using a dura retractor to make planes between the dura and the hypertrophied ligamentum flavum and the hypertrophied medial facets. Once I make a good plane, I'll use a forward and clear out soft tissues that is overhanging on the dura. By doing this, I can get a clear visualization of the hypertrophied medial facet. And then with the help of a Penfield retractor, we are separating off the dura and making sure there are no adhesions. Patties are put underneath the facet joints so that there is no injury to the nerve roots when we are doing the facetectomy. Now, there are different ways by which you can do facetectomy. We use osteotomes to take off that hypertrophied facet, but you could very well use a ronger in this place. Make sure that the patties are well underneath the facet joint so that if your osteotome slips, it does not cause a root injury. Once that's done, the loose fragments of the hypertrophied facets are taken off with the help of kerrison. There could be sudden increase in bleeding as the epidural space starts getting decompressed, or you catch or you tear a epidural bleeder. So make sure that you have a good assistant with a suction in his hand, and don't put a forward in the epidural in the lateral recess without a good visualization of the root. Otherwise, you might catch the root while trying to remove the hypertrophied facets. You do this till you have a good visualization of the root. So if you have done a good facetectomy, you will be able to identify the root underneath the parts exiting to the foramen. Once adequacy of decompression is checked, the area is then packed with the help of patties, and the facetectomy of the other side is done to get a good bilateral thorough lumbar decompression. Once the adequacy of decompression is checked, the lateral recess is then packed with the help of strips of cut gel foams, which help control the epidural bleeders. And then the skin is closed over a drain in multiple layers. So that's all about laminectomy. Thank you and have a nice day.
Thank you, Priyank. Priyank, can you hear me?
Yes, I can hear you.
Okay. So it looks like you're traveling.
Yeah, I just reached my hospital, and this is the best place to talk.
Oh, okay. So Priyank,
Yes.
we were already discussing about this par slices, iatrogenic par slices.
Correct. I was hearing that.
Yeah. So if you inadvertently, when you are doing lumbar canal stenosis surgery and you take out the part.
Correct.
So what do you do usually? You just leave it alone, or you go ahead and fuse it, or what do you do?
No, so
almost always just leave it alone, because these patients have been counseled preoperatively for a laminectomy procedure. A pars, an injury to the pars, essentially is something that we have caused. We don't know that it is eventually going to absolutely turn into an unstable spine. And since we have never consented the patient and they are not aware about the fusion pit, we don't change the plan on table. Some patients where you have very few patients where you have that thing where you intraop are going to decide and fuse, and if you have that option available, then you could fuse. But in our case, I never do that, because it's either a decompression or a fusion. So if it's only decompression, I just let it be and hope for the best, and tackle it some other day if it turns into unstable spine.
Okay. And when do you do discectomy, add on a discectomy when you are doing a decompression surgery for lumbar canal stenosis?
Correct. So, typically, if it's a pure lumbar canal stenosis, you are kind of thinking only about laminectomy and medial fascectomy. There are some of these cases where they have bumps and they clinically have pain in that same direction. So, such cases, intraop, we try to explore the disc and see if one particular disc bulge is causing, that symptom. If clinically, radiologically, and intraop findings match, and when you're trying to retract the root just around the shoulder, and if you see that it is difficult to retract or the root is getting tented over the bump, then we tend to do a discectomy. If there is any doubt, if you are not sure if the root is tented or not, you can always compare the root on the opposite side at the same level. And if you realize the retractability is less on one side, then you go ahead and do the discectomy at that. Of course, and the other things, like if you find an extruded fragment or a significant disc bulge, then you anyways have to go and do it.
So is any clinical findings does influence your decision?
Absolutely. If a patient is a case of LCS with claudication, but clinically he says that he specifically has right leg pain much more than the left leg pain, then I am constantly watchful for the cause of that extra large right leg pain. Could be because of a facet cyst, could be because of a hypertrophic facet, or it could be because of a disc bulge, which eventually needs to get out.
So,
what are your
Priyank, sorry, Guru,
yes.
can I? Yeah. So Priyank, I'm Partha here.
Hi, Partha.
Yeah, so I just wanted to ask you, obviously you showed us a very nice video on doing a complete laminectomy, which was at, I think, 2 or 3 levels on that video. How often do you find it necessary to do extensive laminectomies like this? And, considering we may need to go in again, in most degenerative cases, are you now okay with doing a more minimal
yes.
laminectomy?
So
can you explain?
So I absolutely agree with you. So in our practice, what I've kind of realized that patients who come into our government setup, who are into our peripheries, who come from not metropolitan cities, these patients tend to have lived with degeneration for years together. And when they present to us, eventually we see that they are almost always multi-segment compressions. But however, in metro cities, patients are much more aware and they don't wait for the problem to go in so much. So these patients tend to present with 1 or 2 level compressions. So when the compression is less, we tend to go minimal. Whereas those patients with either primary stenosis or multi-level compressions, we tend to go long segment.
So Priyank,
yes.
What are your end points for decompression in terms of central canal and the lateral recess and the foramen? What are your end points for decompression?
So for central canal, in the first step, we go right from the level to level. So if we have planned a 3 to S1 laminectomy or 3 to 5 laminectomy, so 3, 4, 5 lamina we remove. That's the end of the central canal decompression. Lateral recess decompression we do till we are able to visualize the root, till basically the roof of the root is well visualized and we are able to retract the root. I tend to take that angled ball tip probe and pass it across the foramen and see if the foramen is cleared. Till we get that satisfaction, we keep decompressing. So essentially the hypertrophied part of the medial facet along with the phlegm in that area should be removed, and you should be able to visualize and retract the root well. That would be the endpoint of the lateral recess.
So, which is the most important step in avoiding complications when it comes to lumbar canal stenosis decompression?
So I would say there are 3 times when you really want to watch for the complications. The first time is when you're doing a central laminectomy. The phlegm is attached midway between the lamina. So where the phlegm is attached, so up till the phlegm, you have a cushion of the phlegm when you're putting the forward in. But just at the junction where the phlegm and the lamina are attached together, there you have to be careful, because sometimes the tip of your forward tends to take a bite of your dura and you can get a leak there. The second time when I've noticed is if a patient has got severe lumbar canal stenosis for years together, the phlegm tries to be adhered to the dural sac. So when you're in a rush and you try to remove it, a dural sleeve just comes out and you have a long linear tear, which then becomes a problem to manage. And the third part is when you're doing the lateral recess decompression, especially when it's very tight. At that time, differentiating between the root and the phlegm becomes sometimes difficult, especially if you're trying to do a lateral recess decompression with sharp instruments like an osteotome. And now some people also use ultrasound scalpels. So at that time, you should be careful that you don't end up injuring the roots or the sleeve of the root.
Thank you, Priya. So
Thanks,
for
Guru.
the want of the time, we'll move ahead to the next presentation by Dr. Arvind Kulkarni. So he's going to show a video on sacropelvic fixation techniques.
Thank you, Guru.
Dear friends, this is an extremely interesting topic. The sacrum forms the posterior segment of the pelvic ring through the sacroiliac joints. Forces transmitted through the lumbosacral articulation into the upper sacrum propagate laterally across the SI joints to the pelvis. Hence, the sacrum has been described as the keystone of the pelvic ring because of these load transferring and load sharing properties. It is a transitional zone between the mobile lumbar spine and the stiff pelvis. The LS junction is a very challenging area because of high rates of failure of fixation in this area because of poor bone quality in the cancellous sacrum. Patients have osteoporosis who need this kind of surgery here. Because of the complex regional anatomy, high level of transitional stress in this area. So that's why there is high rate of pseudoarthrosis, high rates of implant breakage and failure. So there are 3 zones of opportunities to put your screws here. The first is the S1 body, the second is the S2 to the tip of the coccyx, and the third is the ilium. So these are the various opportunities here. Now, the commonest spinopelvic fixation is in zone 1, that is the S1 screw that we use day in and day out. Usually we use the bicortical screw. This is good as long as the sacral bone quality is good, the bone density is good. Otherwise, it is a day 1 failure. So either you put a bicortical screw or a Euler screw in the divergent direction. But the best, in my experience, is the tricortical screw, which has never failed me. This is a useless zone of fixation because the purchase in S2 and S3 is of no importance. When we talk of spinopelvic fixation, we are basically talking about fixation in the ilium, because this provides a big platform, big area of big canvas to put your screws in. You can put screws which are close to 10 centimeter in length. It is mainly cortical in nature and it can take big diameter screws and it generally never fails you. The advantage is that you can put the screws beyond the pivot point. The pivot point is what is a very important strategic point, that the concept of which you need to understand. This is basically located at the annulus posterior at the L5S1, exactly in the center, and this was highlighted by McCord long back. Any fixation which can neutralize the forces of flexion and extension at the lumbosacral junction should be beyond this particular point. So that is where the iliac screws, the S2 iliac screws, that is where they succeed. So this is very important to neutralize the flexion extension forces in the lumbosacral junction. So this was, the seeds were sown long back by Galveston, In place of screws, Galveston rods were basically cylindrical rods. These were devised by Allen and Ferguson, but the concept was the same. Though these Galveston screws paved the path for these iliac screws, they were very weak because of the nature of the rods, which were cylindrical and smooth. So they are not very strong in flexion, extension, and rotation. So they failed. That is when these screws were devised by Vidal. You basically knock off the PSIS and aim your screws towards the greater trochanter or the ASIS to gain purchase in the acetabular roof, which has a strong zone of purchase. It is highly cortical in that particular area. So the screws are usually could usually range from 7.5 to 10 centimeters, and the diameter could be somewhere between 6.5 to 10 millimeters. And you pass the screw through this teardrop, which you can achieve by organizing your siam in an oblique fashion. So this teardrop is called the iliac pedicle. So there are various advantages of these long iliac screws. It helps in correcting pelvic deformity. It's invaluable in revision surgery. Does not violate the SI joint. Most importantly, the difficulties would be, exposure may be difficult in an obese patient. Prominence of hardware can be avoided by burying the screw lower down. That's why you knock off the PSIS. There is a certain percentage of neurological injury, but I've never seen that happening in my experience. And we definitely need well-developed iliac wings, which may be a problem in kids with neuromuscular scoliosis. It's recommended that the patient's spine, hip, and pelvis is in extension, so that the fixation is such that the patient can stand properly. The revolution has been the S2 iliac screws, which have the advantage of being in line with the S1 screws, so you don't have a need to use an additional connector. They're not prominent because they're buried down, and they're not very offset from the main rod. And they're as good as the iliac screws. These are the landmarks. So the midpoint of the line connecting the lateral edge of the S1 and S2 foramen is the point where you start making your trajectory, which is 20 to 30 degrees caudal and 40 degrees to the horizontal plane. Now let's go through some indications. The foremost and most common indication in my experience is limitation or absence of anchorage of points of fixation across the lumbosacral junction. This is usually seen in lumbosacral infection, where the upper half of S1 is eaten away. So this is one of our case reports which we published. So this patient had S1 tuberculosis, where the S1 vertebral body had totally vanished, and we are looking for point of fixation. That's when we put these iliac screws and connected them to the L5 screw and filled with this vacuum with allograft, and you beautifully filled up in the next 1 year and give a solid fusion. Second would be pelvic obliquity. This is very common in neuromuscular scoliosis, who suffer from loss of sitting balance. So the goal here is to achieve a stable pelvis, like in this particular patient. Again, in long deformities, especially adult spinal deformities, this is basically to minimize the rate of pseudoarthrosis, implant breakage, to enhance the chance of fusion. And this was a very well done adult degenerative kyphoscoliosis by someone else. Over a period of time, the S1 screw loosened and the implant failed, and the patient was immobile because of the pain. So we supplanted another 2 rods on each side and using onlay dominoes and connected it to the pelvis, and the patient was mobile. So it's a very powerful device. So again, in lumbosacral tumors, basically as a palliative measure to optimize fixation and stability in such cases, you can see here there is significant involvement of multiple levels, and S1 vertebral body is also involved. So this is basically to bypass these involved levels so as to give stability to the spine, to manage pain, and to mobilize the patient. And again, in high-grade list, this is basically to protect the S1 pedicle screws because there's high stress on the S1 pedicle screws. For example, this particular patient with a big, the long-standing L5 S1 lytic with a big void in the front involving the lower half of L5 and upper half of S1, where we did a Lumbopelvic fixation. Again, sacral trauma, which is this is the only way one can mobilize these patients. The trauma is in different planes. This is a U-shaped fracture of the S1. The only way we can stabilize this is by doing a lumbopelvic fixation, as shown here. This kind of fixation can nowadays be done using minimal access, which is a boon in obese patients. So, spinopelvic fixation has unlimited indications. Fixation across the lumbosacral junction is a big challenge. When in doubt, go to pelvis. So, iliac screws, S2 iliac screws, multiple rod constructs provide significantly rigid biomechanical stability, enhancing fusion, minimizing pseudarthrosis, minimizing failure rate, minimizing thus the revision rates. So the latest advances are, in doing this particular procedure using MIS. So this particular technique is a necessary arrow in the spine quiver of every spine surgeon. Thank you.
Thank you, Dr. Arvind Kulkarni. Dr. Arvind is not here, I think.
Hey, he's around. He's there.
Oh, where is? Okay, Arvind. So that was nice presentation. For beginners, can you just tell the tips what to watch out for when they do these sacroiliac fixations?
Yeah, so especially someone who's used to pass pedicle screws, freehand, it's not very difficult because the opportunity is big here. The pelvis is a very big structure. As long as your direction of trajectory are there in your screws, maybe initially you get oriented towards this teardrop by obliquely pacing your C-arm. In terms of degrees, it varies from patient to patient. Basically, it is directed inferiorly in both, inferiorly in a caudal angle and inferiorly towards the floor. And you can see the teardrop, and the teardrop is big enough to accommodate 7.5 mm screws that we have on our trolley. So you just follow it. I've actually never used this teardrop as a landmark to pass these screws, because most of the time this can be done usually very easily with a free hand. So when the patient is position prone, you ask one of your assistants to put his palm on the greater trochanter of the patient on that particular side, and you direct your pedicle probe in that particular direction inferiorly and laterally.
So, Arvind, before you move ahead on that one, you would find it easier to put these screws from the opposite side.
Correct.
Like the rest of that. I just wanted you to clarify.
That is a yeah. So that is a very important point which Partha has highlighted. So you're standing on the opposite side. It is almost, I wouldn't say impossible, it would be very stupid to do it from the same side. You don't have good control over the direction, nor can you see actually the PSI, because it has to be retracted. The soft tissue on the PSI has to be retracted powerfully to get into that particular trajectory. The other point would be to see to elevate the gluteus on top of the outer surface of the ilium, so that you can actually feel the plane of the ilium. So that also guides you in putting your probe in the right place. The most challenging patients are the kids who have misshapen pelvises. This patient with neuromuscular scoliosis. That is where that should not be your first case probably, because it can be very tricky. They are misshapen, they are misangled, and they can be very thin. So that is where you can go wrong sometimes. So unless you have a good amount of experience with elderly patients, you shouldn't embark on doing it in kids.
So Arvind, I have one more question for you. Because Guru's really been doing a good job till now, I thought I'll take some pressure off him. So the question is, See, your percentage of iliac screws compared to say S1 screws will be something like 2-3% is my expectation, right? You would be 97% S1 screws, right? I hope so, at least. So can you give us some tips on how you maximize the hold you can get out of S1 screws? Because most of the time we're doing, simple single level fusions or 2-level fusions where we don't need to go to the ilium. And that's 90+% of maximize your S1 screw hold. What are the tips and tricks for that one?
So this is something which I have learned and extrapolated from my alpha S1 MIS fixations. So when you do a MIS fixation, if you put your alpha and S1 screws that the way we put in open surgery, bicortical S1 screws and alpha screws, then it is very difficult to negotiate the rod. And the extensions of the percutaneous screws, they hit each other. So in there, we make it a point to put the S1 screw parallel to the L5 screw, which makes it a tricortically angulated screw. So you are getting purchase in the tricortical area of the sacral promontory. And that purchase has to be extremely good. Most of the times it's very, very sclerotic in long-standing lytic lysis where we put these S1 screws. So, and if you get a bite, if you can get a bite in that S1 tricortical area, that sclerotic area, you won the, that is where you won the case. So that particular purchase, nothing can beat that kind of a purchase. So a tricortical purchase at S1 is a must to get a good solid fusion. If you not got a good purchase in S1 on the day of surgery, it's a day one failure. That patient is going to come back with loosening and implant failure.
Right. So the other thing is the technical trick.
Also putting a bigger, wider screw at S1. S1 can easily take a 7.5 mm screw. So I usually make it a point to put a 7.5 mm screw in S1.
Right. So the other thing is, how exactly do you pierce the other cortex? Because you said we need another cortical hold. So, the technical trick of how to do it. We all have our own ways, but we'd like to hear yours and what in your experience works.
So when it is a tricortical purchase, I don't go beyond, I don't break the cortex. A purchase in the triangle is more than enough. And also make it a point that your screws are as medially angulated as possible. So that gives a longer length of the screw inside the S1. So that also helps in terms of biomechanics. So a big diameter, medially angulated long screw in the tricortical area, that would serve the purpose.
Okay, Arvind.
Yes.
So, in your opinion, when you do a iliac screw or maybe S2 AI screw, how do you basically connect these screws with the other screws in the lumbar spine? How do you contour your rod? Any tips and tricks for that?
So as much as possible. The reason Guru is asking is because these iliac screws, especially the iliac screws, are slightly way off. They're not in the same line as the pedicles. So they are they're offset from the midline. So it becomes difficult sometimes to continue the same rod going down to the ilium. So having said that, I still would love to put the same rod. I would like to still continue with the same rod going down, angulated in such way. Even if I put 2 iliac screws, I plan it in such a way that the screws are in the same line as the rod when it comes to the rod. If that is not possible, there are these special connectors which on top of the tulips of the iliac screws, you can place these connectors, and they have a keyhole which goes into the main rod. So there's a keyhole, and there is a stick to it, and that stick goes on the ini of the ilium, on which you put the ini and tighten it, and the whole of that particular implant goes through the rod. goes to the main rod, and on top of that again you have a need to tighten it. So there are various kind of connectors actually. They are like dominoes. So basically they are offset connectors.
Okay. Any more
question from Appaji? Yeah.
Yeah, Appaji.
Hello.
Yes, Appaji.
Hi.
Hi, Arvind. Yeah. So do you use
Hi,
stacked screws in the ileum?
Sorry?
Do you use stacked screws? Some people use 2 screws, 3 screws in the ileum. Do you recommend it?
You saw my presentation. I usually tend to use 2 screws. It's shown that
like one.
Biomechanically, 2 screws are better than 1.
Okay. Okay.
Yeah. Okay. Are there any more questions?
We can move on, Guru. Yeah.
If not, thank you, Dr. Arvind. We'll move on to the next talk by Dr. Sudhir Ganeshan. He is going to talk on biology of the spinal fusion.
At the outset, I would like to thank the organizing committee of IOACON for giving me this opportunity to present this today. Let's start with the case. So this is a 57 years old male with degenerative listhesis and lumbar canal stenosis at L4-5, as you can see in the sagittal and axial views, for which the patient underwent L4-5 transforaminal lumbar interbody fusion. You can see in the CT picture at the end of 1 year, the good fusion which has happened between the segments. This is a similar case, which is a 54 years old female with degenerative listhesis, again with lumbar canal stenosis of L4 over L5, for which the patient underwent TLIF of L4-5. But at the end of 1 year, this patient had insufficient fusion and the patient came back with severe back pain. So why is this happening? What is the difference between these two patients, and what factors contributed to good fusion in the first case and what factors contributed to less fusion in the second case? To understand this, we have to understand the basic biology of spine fusion, which will be discussed by me today, Dr. Sudhir from Chennai. So, as we all know, spine fusion is one of the commonest procedures for most of the spinal pathologies. Irrespective of the technique, the fundamental aim is to achieve bony fusion in all these patients. Non-union or pseudoarthrosis can cause failure of fixation and impact quality of life. This fusion is dependent on various factors. Depending on the type of grafting material, patient comorbidities, approach, and the number of levels, the pseudoarthrosis rates in the lumbar and cervical spine can range from a few percent for a single level to greater than 40% for multi-level procedures as per literature. So to achieve a good outcome in spine fusion, biology as well as biomechanics is equally important. They should go hand in hand and they should be balanced to get a very good outcome. But however, we being surgeons, we concentrate predominantly on the biomechanics factors like screws, implants, implant positioning, contouring, etc. But we are not giving adequate importance to biology, and hence these patients may have adverse outcomes. So the fusion relies primarily on bone remodeling, and it is basically between the balance between the osteoblasts, osteoclasts, osteocytes, which is auto-regulated by metabolic, endocrine, and mechanical signaling pathways. The fusion has 3 phases. As we all know, the first phase is the inflammatory phase, which lasts about 3 weeks. It is initiated by the decortication of transverse processes in case of posterolateral fusions or end plates in case of interbody fusions. Once there is decortication, inflammatory cells get secreted and bone formation is initiated by membranous ossification. The second phase is the reparative phase. So the initial steps of fusion for mass formation and cancellous bone remodeling occurs during this phase. There will also be resorption of necrotic tissue, vascularization, and progenitor cell differentiation. The bone formation usually migrates from the peripheral zone towards the central zone. The third phase is the remodeling phase. It usually lasts for about 4 weeks, and during this stage or phase, mature bone is formed, the cartilaginous remnants, they dissipate, and the bone marrow volume increases. And the maturation of bone slows down for the outer zone and increases for the central zone during the remodeling phase. Both reach a similar level at the end of about 10 weeks. Various studies in literature have shown that in posterolateral fusion, membranous bone formation occurs primarily, and increased volume of woven bone and enchondral ossification will happen subsequently at the bone grafted site. Whereas in interbody fusion, the local environment is originally hypovascular, devoid of nutrients, which is exacerbated by degenerative changes. Hence, interbody fusion is more demanding biologically compared to posterolateral fusion. So as I said, this is the process. So decortication and end plate preparation results in osteoprogenitor cells entry into the fusion area. They differentiate into the bone forming osteoblastic cells. And because of the signaling pathways between osteoblasts, osteoclasts and osteocytes, they produce bone matrix on the transplanted graft sites. Finally, there will be remodeling and fusion mass formation. Predominant studies in this area was done by Borden et al. They have shown that membranous bone formation was found to occur early and near the transverse processes in case of posterolateral fusion. A later repair response, which is seen in the central zone between the adjacent transverse processes, demonstrated enchondral bone formation with a lag effect. That is called a central lag effect. So this is from their paper. As you can see, FM means fusion mass. The fusion mass usually starts in the outer zones, both in the coronal view as well as in the sagittal view. And then it progresses towards the central zone. Similarly, in the peripheral zones, BMP2 mRNA expression was increased during weeks 2 through 6. And BMP6 in the outer zone had a first peak on day 2 and then during a week 5. Whereas BMP6 in the central zone showed an initial peak on day 2 but did not demonstrate the later peak. Again, further animal studies showed that implanting only 50% of the normal volume of autograft actually lowered the fusion rate from 70% to about 30%. Similarly, excessive spine motion decreased the fusion success rate from about 58% to 14% in rabbits. Now, as I said, bone fusion in case of spinal arthrodisc surgeries is multifactorial. What are the factors affecting fusion? It can be divided into local factors or systemic factors. The local factors can again be divided into mechanical factors or biological factors. The mechanical factors are stability, the loading mechanisms, and the biologic factors are blood supply, site preparation, bone grafts, radiation, and the local bone disease. The systemic factors are osteoporosis, hormonal influence, nutrition, drugs, and smoking, etc. So the mechanical factors, literature is very controversial. People say that instrumentation is better than non-instrumented fusions. And fusion mass from instrumented spine is narrower with compact bone in animal studies. And uninstrumented fusion mass has less but wider trabecular bone. We'll see about this in the later slides. Coming to tissue bed, the local environment is very, very important. The main nutrition for the fusion mass is by the local blood supply and the inflammatory response and the availability of progenitor cells. And the blood supply from adjacent tissues is very, very vital. Many animal studies have shown that by blocking this blood supply from adjacent tissues actually hampered bony fusion. Fusion site preparation is one of the most important things which we have to consider when we are operating. So membranous rabbits not undergoing decortication of the posterolateral spine elements failed to fuse. And vascular injection studies also revealed that the primary blood supply to the fusion mass is from the decorticated posterolateral bony elements. That is, in case of posterolateral fusion, the transverse processes has to be decorticated thoroughly, and in case of interbody fusions, the end plates has to be decorticated thoroughly so that there is adequate blood supply and a very good environment for the fusion to occur. Coming to the type of bone grafts. Bone grafts can be bone graft extenders, which allows the use of less autologous bone graft with the same end result, or one that allows given amount of autologous bone to be stretched over a greater area. Enhancers are that when added to autogenous bone grafts increases the successful healing rate using either the usual amount of graft or smaller amount of bone graft. And bone graft substitutes may be used entirely in place of autologous bone grafts to achieve the same or a better fusion success rate. The gold standard bone grafts for use in spinal arthrodesis is autologous bone grafts like iliac graft bone grafts or the bone grafts from the decompressed spinal elements in case of posterior spinal procedures. The bone grafts can again be divided into osteoconductive, which provides mechanical stability, large and scaffold pores, which are large enough to assist neovascularization, cell migration, and bony ingrowth. Or it could be osteoinductive, which contains various growth factors that promote osteogenesis of these surrounding stem cells. Or it could be osteogenic, which provides mature osteoblasts that will drive new bone formation. So the topmost picture is autologous bone graft. The top right is BMP. The one in the syringe is demineralized bone practice, and one in the cup is allografts. This is an example of different types of bone grafts. Coming to osteoconductive bone graft, the commonly used one are the ceramic ones composed of calcium sulfate, hydroxyapatite, or tricalcium phosphate. Studies have shown that they are osteoconductive, biodegradable, non-toxic, and non-immunogenic, and they can be easily sterilized, but they are not osteoinductive. The commonly used osteoinductive bone graft is demineralized bone practice, which is prepared from allograft bone by decalcification. However, studies have shown that there are no significant differences between DBM and autograft composite when it is compared with autograft alone in posterolateral fusions. So this is another paper which states that though DBM alone can induce favorable bone bridging in interbody fusions, it is still considered inferior to autologous bone grafts. Therefore, it is recommended as a bone graft extender rather than bone void filler, especially in patients with osteoporosis. Now coming to osteoinductive substances like BMP2. The most commonly used osteoinductive substances are BMP2 and 7. The BMP2 has officially been approved by FDA only for single level anterior interbody fusion, but however it is widely used by many surgeons for other surgeries also. Despite the advantages in bone formation, it still remains a highly controversial issue because of its complications, which are like heterotrophic ossification, hematoma formation, infection, dysphagia in case of ACDF, arachnoiditis, retrograde ejaculation, and cancer. So according to this paper for BMP7, they did not recommend for fusion in case of posterolateral instrumented fusion surgeries. Coming to osteogenic components, the recently platelet-rich plasma has been utilized for fusions. And according to this paper, they state that platelet gel failed to enhance fusion rate when they are added to autografts. And the authors do not recommend platelet gel to supplement autologous bone grafts. However, contradictory to this paper, this particular paper with 20 patients showed that the bony rate was significantly superior in the PRP group than in the control group, whereas the average duration of bone union was not significantly different. We have done a study and it is about to be published which shows that there is no significant difference between the PRP group and the autologous group alone. There are a lot of studies which are going on for other growth factors like calcitonin, NEL1, P15, angiopoietin, and they have shown promising results. However, future studies with large numbers and randomized control studies are required to prove their efficacy. This is one of the paper which concentrates more on the gene therapy and stem cell therapy for spine fusions. According to them, higher rate of spinal fusion has been obtained with culture expanded bone marrow mesenchymal stem cells compared to freshly isolated cells. Similarly, osteodifferentiated MSCs were more efficient. And there are various genetic engineering strategies are effective, but further research are needed in the delivery strategy because now predominantly adenovirus is being used as the carrier, which can result in some complications. All these things, all these research are in their infancy stage and it has to be validated. To summarize the bone graft agents, autologous have osteoconductive, osteoinductive, osteogenic properties and they are considered the gold standard bone grafts. Allografts are osteoconductive and osteoinductive. Ceramic are predominantly osteoconductive. DMB is osteoconductive as well as osteoinductive. BMP is predominantly osteoinductive, and the cells, that is bone marrow cells, stem cells, they have osteogenic potential. Now coming to other factors, technique related. So as we were discussing earlier, studies have shown that instrumented fusion is better than non-instrumented fusion because it provides adequate stability for the fusion mass to heal. Similarly, 360-degree fusion is better than posterolateral fusion according to certain studies, especially in high-grade listhesis, because it creates normal biomechanics and it stabilizes the entire functional fusion. And long segment fusion is more prone for osteoporosis, so we have to be extremely careful when we are operating on these patients and other patients with other factors like neurofibromatosis and muscular dystrophies. The commonly performed procedures like A-lift, P-lift, T-lift Literature is very clear that there is no significant difference in radiological fusion rates between any one of these procedures. These pictures are the respective techniques, and there is no difference in these procedures. Coming to the implant related, the commonly used interbody cage is PEEK cage and titanium cages. This is one of the meta-analyses which has shown that titanium and titanium coated PEEK cages used for PLIFs are associated with similar rates of subsidence, but a higher rate of fusion compared to PEEK interbody cages was seen in titanium cages. The latest material which is being used is tantalum. According to this paper, promising results are seen with tantalum cages, but however, long-term results with future studies are required. Coming to the commonly used drugs and its effects, bisphosphonates, people say that zoledronic acid actually shortened the duration of time to fusion for radio and improved radiological and clinical outcomes, reduced the cage subsidence and pedicle screw loosening. Teriparatide, according to few studies, enhances fusion radiologically and histologically. Certain other studies have shown that there is no significant difference in the radiological fusion rate. But these studies are lower rate of pedicle screw loosening. With osteoporosis. According to this particular study, there is no significant improvement in the overall fusion rate surgery and outcome between the teriparatide and bisphosphonate group. There are no studies concerning denosumab and spinal fusion as of now. Theoretically, however, it enhances spinal fusion by inhibiting the rank ligand. Thus, to conclude, clear understanding of biology of spinal fusion is very important. Fusion depends on multiple factors. Meticulous preparation of the site for grafting is very, very vital. Autologous bone grafts is considered the gold standard. Osteoinductive substitutes are better than osteoconductive when we are trying to enhance the autografts. Gene therapy and stem cells may be the future, and they are showing promising results. Thank you.
Thank you, Sudhir. So, do we have any questions for Dr. Sudhir? Anybody?
So Sudhir, how often do you think it's necessary to use iliac crest bone graft, or do you find that for simple fusions in the spine, you're okay with just local bone graft?
Simple fusion, single level fusions, definitely we can go ahead with local bone grafts, which we get from decompressing the lamina and spinous processes. But however, when you are planning for long segment fixations or deformity surgeries or special conditions like neurofibromatosis where the rates of pseudoarthrosis is high, then definitely we have to think about using iliac crest bone grafts, and in infections, especially when the bone grafts are not sufficient.
So the next question I wanted to ask you is, I think our participants will be more interested in knowing how do you make sure that your bone graft is prepared well? What steps do you take in any fusion, whether it's posterior or interbody, specifically to make sure that you maximize the possibility of union?
Yeah. The first and most important thing is when we are exposing, it is better to remove the soft tissue when you are exposing itself, because when you're decompressing, it will be easier for you to get the bone grafts directly without soft tissue. And once you remove the soft tissue, I always depute one of them to prepare the bone graft specifically. So their only job will be to remove all the soft tissue thoroughly, and it has to be prepared. And as far as possible, the prepared bone grafts should be in tiny pieces. And if you have bone mill, it is better. But in our country, it is not very common. And you nibble off, and then you keep it in blood-soaked gauze piece. Don't wash the bone grafts with saline. Most of them, they tend to wash bone grafts with saline. It will wash away all the osteogenic and osteoinductive growth factors. So you're not supposed to do that. And if you're able to get some good blood-soaked gauze piece, especially from the marrow elements, it is better. You can pack it and keep it. And do not expose the bone grafts to the theater temperature. That is, again, it's very important because it may be harmful to the osteogenic cells.
Any particular points or steps in preparation?
Yeah, preparation, as I said, it is very, very important. For posterolateral fusion, most of the times we do not decorticate the transverse processes. I think it has to be stressed up again and again. You have to expose the intertransverse membrane and the transverse processes, and you have to use the burr to prepare the transverse processes. Decortication is very, very important. And in interbody preparation, again, just using shavers and sizer is not important. Use the angled curettes and the box curettes wherever possible. Make sure that you hear the scraping sound of the end plate, and you make sure that you scrape the end plates very thoroughly. But make sure you do not overdo that, because it may result in cage subsidence. And pack adequate bone grafts anteriorly. That is the key for fusion. Just packing the cage and inserting the cage is not at all important. Pack adequate bone grafts either using the syringe technique or using the bone funnel, and then pack the bone grafts adequately. That is very, very vital.
At what places, Sudhir, would you use bone substitutes instead of bone graft even in a primary situation? Are there any particular areas where you would use a bone substitute or an artificial bone graft kind of thing for your procedure without having to go for, autologous bone graft? Any specific procedures?
I rarely use bone graft substitutes without autologous grafts, including cervical spine surgeries. I always prefer using autografts, because ultimately, as of now, the only aim is fusion. So we have to give the best shot possible rather than relying on other things when we are able to get bone grafts.
All right. Kuru, you were going to say something.
Yeah, Sudhir?
Yeah,
where does the BMP stand right now in lumbar surgeries and cervical spine surgeries?
In lumbar surgeries, they use it regularly, but still, even the 2020 paper, the literature is very clear. It is associated with high rates of complications, whereas in cervical surgeries, people have stopped using it. For lumbar surgeries, they do use even now for scoliosis and other deformity surgeries, especially abroad. So they do use routinely even for single level fusions. So they say that the complications are not very severe as reported in the literature. In our country, I think we are not using it regularly mainly because of cost issues. So cervical surgeries, there is no doubt. It is almost banned. It is not being used because of various complications. Lumbar surgeries, people are using it even now, routinely.
So is there a level 1 evidence for BMP right now?
No.
There is no good level 1
and
evidence.
FDA has approved only for anterior fusion, only for anterior lumbar interbody fusion, as per the latest literature when I went through, and not for other procedures.
Thank you, Sudhir.
Yeah, thanks, Dr.
So, yeah, we'll move on.
I just wanted, if I can have 10 seconds, I just wanted to emphasize on one point regarding the use of NSAIDs and its effect on bony fusion. The literature says that you can use NSAIDs very safely if it is going to be less than 2 weeks, and it is dose dependent and duration dependent. So it can be used. Preferably, COX-2 inhibitors can be used during the post-operative period.
Okay. Thank you, Sudhir.
Yeah, thank you.
So we'll move on to the next video session by Dr. Parthasarathi. So he's going to show you how to do a posterolateral and a transforaminal lumbar interbody fusion. Over to you, Partha.
Good morning, everybody. This presentation is about the transforaminal lumbar interbody fusion as a procedure for lumbar instability and lumbar degenerative processes. This is the case of a 32-year-old lady who complained of instability, low back pain with left radicular pain for the last 6 months. On examination, she was unable to stand straight. She was stooped forward with a list, had severely restricted range of movement, but no neurological deficit. Her X-ray showed a grade 1 slip with features of dysplasia. There was no break in the pars. However, there was a rounded sacrum and a mild wedging of the L5. On the MRI, it's confirmed that the pars is intact. However, there is central canal stenosis and evidence of more compression on the left cuts, as is seen well on the axial cuts. Now we will go to the procedure. Classically, the transforaminal interbody fusion is done in a prone position, and when we position the patient, we need to really make sure that all the bony prominences are padded, the eyes are absolutely free from any pressure, and there is no pressure on the abdomen to decrease extradural bleeding. It's important also to keep the BP under control with a normotensive BP with a mean arterial pressure around 80, and tranexamic acid helps to keep the blood loss less. A central standard midline incision is made, and a standard subperiosteal dissection is carried out to expose the required levels. It's important here to note that it is better to not damage the facet capsules, especially of the normal non-fused levels while we're doing this procedure. A good exposure without blood loss with a standard intersection technique for the L5 screw is being displayed here. You can see the upper and lower parts of the transverse process and the midpoint at the lateral border of the facet taken as an entry part and marked with a sharp awl. A Steffi probe, straight Steffi probe with a blunt tip is used to probe the pedicle. It's important here to note that you must have a very good idea on how much lordosis the L5 is so that you can probe in that direction. You shouldn't force the probe. Once you've finished probing, you can plug the hole with some wax so that there is no further bleeding. The S1 screw entry point is described differently in multiple places. It can be either 3 millimeters below and lateral to the tip of the facet joint, or it can be slightly superior to that. The S1 pedicle per se is fairly large and we can probe it without danger of damaging it. These blunt KYs are used to mark the pedicles that are probed so that we can make sure of the level as well as the direction. The L5 screw looks well directed. As you can see, the S1 screw requires redirection, and that can be done before piercing the anterior cortex. So the S1 screw is now probed in the right direction, and a gentle tapping of the probe across the anterior cortex can make sure you get a bicortical hold. A bicortical hold is necessary because the sacrum is hollow. Here the L5 screw is being inserted in, and a similar procedure can be repeated on the other side. Once the screws are in, a check a C-arm is a good idea. As you can see, we've got a good position on the L5 screws and the disc space has opened up slightly with positioning. Prior to starting off our decompression, we can remove the supraspinous and interspinous ligaments. It's good practice to generally remove all the soft tissue off the bone before starting to remove the bone so that it's easier to use it as bone graft. Here you can see that the facet capsule is being removed, and as we remove the facet capsule, a small piece of bone popped off which suggested a facetal dysplasia. This was not fractured prior to the surgery, and it means that the facet was probably not fused, and this was the reason there was an instability that developed. Once the two facets are excised, laminectomy can then be performed using either rongers or an osteotome, as is shown here. The osteotome is placed just superior to the inferior articular process of L5, and a transverse osteotomy is done very gently, taking care not to cross the cortex closer to the dura, and this can be completed all the way across. One of the reasons why I prefer to do this is because there is no entry of an instrument into an already crowded canal. Here we can just lift off the entire lamina without entering the canal and use a cob to separate the ligamentum flavum from the underside. This prevents inadvertent dural injury in a very tight canal. The rest of the superior part of the lamina is being removed now using a ronger, and once that is done, you can clear up all the way up to the ligamentum flavum at the higher level. The ligamentum flavum, which was left behind, is now being excised using a 15 number blade and forceps. Once this is done, we can go ahead to free the two exiting nerve roots by using a ronger on the overhang of the facet joints. This will be seen now, and you can trace the nerve root right up to its lateral recess to make sure there is no compression of the same over there. Once that is done, the inferior articular process of L5 is completely osteotomized and removed before osteotomizing the superior articular process of S1 in line with the superior border of the pedicle. As you can see, that piece is the articular process of S1. That region, the transforaminal region, generally has a lot of blood vessels. So these are being cauterized to prevent excessive bleeding. Once this cauterization is done, all the other soft tissue can be pushed away, and a 15 number blade can be used to enter the disc space. Once the disc space is entered after the annulotomy is done, the annulus and superficial disc can be removed. The rest of the disc usually comes out by using either shavers or trial sizes like this, which go into the disc space. And as you can see, the disc space, how mobile the disc space is once the facets are removed in a case of instability. So we can keep increasing the size of the sizer that is going in till we get a position where the sizer fits well and doesn't come out easily. Once that is done, the shaver is used to remove the disc which is left behind. A rod placed on the opposite side with a little bit of distraction keeps the disc space mouth open for us to continue and do a proper preparation of the disc space. As you can see now, the shaver is removing the rest of the cartilaginous end plate. All areas where there is any epidural bleed can be packed with patties, and this will prevent further bleeding. The disc has been removed. A nice toothed curette can be used to remove all the other remnants of the disc to get a nice bed for our fusion, which is the ultimate aim of preparing the disc space. All the excess disc material is removed carefully. At this point, it's important to note that the exiting route, that is the L5 route, is in fair proximity to our disc space. So it's important to make sure that we are working under vision and not harming or damaging the nerve root while we are doing this. We can use a series of angled curettes as well as angled disc punches to remove the disc from the opposite side, thus negating the need of going into the other side. All the bone that we removed is morselized and used as local bone graft. It is pushed into the disc space so that it occupies the front as well as the opposite side of the disc space. This helps to see, to promote a good fusion, as well as to be able to see the fusion on our post-operative x-rays anterior to the cage that we are going to place. The shaver can be used again just to make sure that the disc space is packed nicely anteriorly, as well as turned around once to make sure the cage can go in. This is a regular titanium lordotic cage. There are two ways to insert this. One, as in given in the picture, where it goes in the same direction as it is supposed to be placed. If you feel that it's difficult to do this without causing a lot of retraction of the dura, it can also be pushed in at a 90-degree angle and turned inwards. So this is the final C-arm picture with the cage in situ. You can see that we have expanded the disc space almost to 12 mm. Now the roots are being checked after that to make sure that there is no compression at any point. The other rod is being placed. Once the rod is placed, we can then compress over that to restore some more lordosis and thus get a good position overall. This is pretty much the procedure. The closure is a standard closure where we suture up the paraspinal muscles and the subcutaneous tissue and the skin. Thank you.
Thank you, Dr. Partha. Do you have any questions for Dr. Partha?
Yeah.
Yes,
and Sudhir speaking. Yeah, yes. Dr. Partha, how often do you do a T-lift without doing midline decompression? And what are the tips and tricks for that? Just by removing the facet in case of some lateral recess stenosis on unilateral side.
So I would do in the rare occasion that there is a unilateral stenosis with an instability, or there is a pure instability with hardly any stenosis, I would do a unilateral T-lift. In most other cases, I have not seen too much of a difference in having to, take off the midline when I'm doing a fusion. In that case, the difference would be that I would maintain the interspinous and supraspinous ligaments over the spinous process. I would osteotomize the facet on the same side in which I'm going in, which would be the side of compression. Or if there is no side of compression and I'm doing it for instability, it would be the left side because that's the easier side for a right-handed me. Take off the facet. Once the facet is off, then you can find the plane between the flavum and take off the lamina till you make sure that you're at above the edge of the flavum. And then the process is pretty much the same as in a bilateral, but you just stick onto one side. That's the only difference.
Okay. And how often do you always see both the roots and retract? I mean, both the traversing or exiting, or do you just see the traversing alone without looking for the exiting?
I don't look for the exiting in general, unless I'm putting in a very large cage, in which case I will slide in a root probe, which can just make sure that I'm not impinging the cage on the nerve root, which usually happens in the outer lateral corner superiorly. So the nerve root kind of just protects that. But I used to see both nerve roots. Now I see the exiting nerve root only if I'm dealing with a lytic where I have to make sure that the exiting root is decompressed. For a degenerative, I don't see it at all.
Okay. Just wanted to bring up that point. And any tips and tricks to prevent or reduce epidural bleeding when you're visualizing the disc space?
So the most common thing that happens is that when we see an epidural bleed, we go ahead right away to start, cauterizing it and trying to find the bleeder, which actually seems to be a little counterproductive here. The easiest way to handle any epidural bleeding in the transforaminal space is to pack it. So what I normally do is I expose the transforaminal space where I'm supposed to do my discectomy before I finish all my decompression, and then pack it and then continue with the rest of my decompression. When you get back, usually there is very little bleeding, or you can see the the veins that you need to cauterize. The one troublesome place that you will get bleeding from is the kind of the axilla of the exiting root that is above the disc, and that is well handled if you just pack it with a patty and leave it there till you finish the entire job.
And we have to be very careful when you're inserting the cage to take care of the patties, because there have been instances where the patties can enter along with the cage. So
I take, that happens fairly common actually. So I usually take off the patty just before I'm going to put in the cage. So the other thing that which was part of my brief but I didn't show was a posterolateral fusion. The process is fairly similar, only your exposure on the wide laterally is a lot more. So it doesn't pay to be small about your incision. Your incision needs to be larger. Your facial dissection will also be larger. You need to take a lot of care not to damage the facet of the higher level when you're doing this. So no cautery over the facet. You can just swipe it with a cob and it will push the muscle away. But you have to see up to the tip of the L5 transverse process if you're doing an L5S1, or the tip of an L4 transverse process, which means that your exposure has to go up really high. There is no, you can't do a minimal invasive thing of this. You need to do a proper exposure. If you are, however, doing a Wiltshire approach where you're doing a lateral approach, then that's a lot easier. But again, promoting a good fusion always has to do with creating a good bed.
Thanks, Dr. Patel.
Thank you.
Any more questions?
Guru, we can move on. We'll go to the next session. Yeah.
Okay.
Have the other people logged in?
Yes.
I think so.
Thank you.
Next is Ajay, no?
Yes.
Sir, you are there? Yeah, I see him logged in. Yeah.
Yes, sir. Sorry, there. So thank you, Partha. And we'll move to the next video session. And I hand over the reins to Dr. Appaji Krishnan. He will take over from here. Appaji.
Yeah. So welcome all. Again, this session is on thoracic and thoracolumbar spine. We have had, this will have again the basics, diagnosis, diagnostic dilemma, and management of basic, where is the program? Yeah, sorry. So we'll have about fractures, infection, how to instrument, and then management of common problems in thoracic spine and thoracolumbar spine. So without much ado, I'll invite Dr. Ajay Shetty to speak on spinal tuberculosis, current trends in the management. Hello.
Good afternoon, respected chairpersons and my dear friends. My talk would be on the current trends in the management of spinal tuberculosis. We all know that spinal tuberculosis is one of the commonest diseases which we see in the Indian subcontinent. Unfortunately, India accounts for a quarter of the world's annual incidence of spinal tuberculosis. We do know for the fact that tuberculosis is a curable and a preventable condition, and uncomplicated spinal tuberculosis is a medical disease. Adequate treatment curtails onward transmission of the infection, but there is a rising concern in the increasing incidence of drug-resistant tuberculosis. Where are we today with respect to tuberculosis? If you look at the WHO NTB strategy, we are lagging way behind in reducing the incidence of tuberculosis, the number of TB deaths, and the percentage of the people who are affected with tuberculosis and facing a significant amount of cost. What about the investigations in concerns with patients with spinal tuberculosis? The question is what to do. If you look at the most common investigations, what we need to do is to look at the general condition of the patient, HPT, CDC, ESR. ESR is prognostic. We have to look at the HIV tuberculosis syndemic. RBS, blood sugar has to be well under control. LFT as a monitoring, because most of the anti-TB drugs have hepatotoxic side effects. What not to do is basically also important. We do know that the blood-based PCR test, the antibody tests are no longer useful. And even the TB Gold test and the MAN2 test is basically useful in diagnosing latent tuberculosis. And in an endemic country like India, it may not be of a major significant usage. By investigations, MRI still remains the gold standard. And probably we should be able to come to some degree of diagnosis in with the use of MRI to a large extent, especially when you have a well-defined paraspinal abscess, which is extending along 2 or 3 levels. The abscess wall is very thin, and then it goes in more in favor of tuberculosis. If there is a subligamentous spread of 2 or 3 multiple bodies, multiple skip lesions, a thoracic spine involvement also goes in favor of spinal tuberculosis. We have to understand that even then, a classical paradiscal in a thoracic with a thin cold abscess may be ideal, but tuberculosis is a great mimicker. Therefore, we need to do a biopsy for all these patients to confirm it's tuberculosis, because it could be a pyogenic, eosinophilic granuloma, lymphoma, any one of these disorders or many more disorders can mimic a tuberculosis. Therefore, it's important to have a diagnosis. Therefore, is it always important that we have to do a biopsy? Yes. But in the lesions which are early with no destruction, probably we can get away by doing a biopsy and treating the patients with anti-chemotherapy. However, in patients who present with neurological deficit with instability, it's safer to do the combined procedure together, the surgery and biopsy at the same time. When you do a biopsy, it's important that we send the tissue always for gene expert, TB culture, histopathology, and pyogenic bacterial culture. And in certain situations, you may have to send for fungal culture also. Traditional smear may not be of much use in patients with spinal tuberculosis. We know that the spinal TB is basically a postbacillary condition and not an ideal scenario. Where do you take the biopsy from? Ideally from the lesion, IMAGE guided and a CT guided. Transpedicular is much more easier. You can aspirate the cold abscess whenever the cold abscess is easily accessible for you. There are various terminologies that has come into place. The presumptive, that is based on the clinical features you suspect is tuberculosis. You do a biopsy or a bacteriologically confirmed it's tuberculosis is a confirmed case. Whereas when you send it for tissue diagnosis, but it comes as negative. It's clinically thought to be tuberculosis, but when you look at the negative microbiological culture, it is not very favorable. It gives a non-specific spondylodiscitis. Even then, if the MRI is very conclusive, it's okay to start on anti-tuberculosis drug, a trial of conservative treatment. If the patient is responding, then we can presume that it is tuberculosis and continue the same. And we also know, again, in drug resistance, it could be clinically diagnosed or bacterially confirmed treatment failure. But we have to understand that tuberculosis, especially at drug resistant, when you do the biopsy again, you may not get a culture positivity rate, which is as low as sometimes 30 to 60%. Therefore, most of the time, the drug resistance would be diagnosed more based on a clinical rather than on a bacteriological confirmed methods. We know the other recent change that has happened, the tuberculosis is a notifiable disease, and the chemotherapy is right now advocated for up to a period of 1 month, 1 year. And the other important change that has happened is that in the continuation phase, ethambutol has to be continued for the next 10 months' time. And it's important, the most important aspect of tuberculosis is monitoring. We have to look for ESR, LFT, and weight gain, a sense of well-being, which implies that the disease is healing. You look for various clinical signs, the weight gain, laboratory, the ESR, imaging, X-ray, MRI, and PET scan also could be used. I do not use PET scan in my practice to look at healing. Most of the time is clinical assessment and sometimes supplemented by MRI in certain group of patients. But the most important thing of drug therapy is to prevent failure. And the most important aspect, I would like to put it as counseling, 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 and counseling again. Give the body weight based drug dosage, patient to compliance, nutrition, vitamin D, and vitamin C. I would like to emphasize again that this is the most important aspect. If you look at drug-resistant tuberculosis incidence in southern part of India, it's about 5%. Whereas in India, in the northern part of India, including even Mumbai, the reported incidence could be as high as 15 to 20%, which is actually not acceptable. And probably we have to play a very important role in decreasing the incidence of drug therapy. A word about paradoxical reaction, wherein the patient who is on anti-TB drugs, who's feeling better, initially shows improvement, suddenly starts deteriorating. It's just an immune response. You continue the same line of therapy. This is as against drug resistance where there is no improvement at all. Therefore, we know now that the uncompleted spinal tuberculosis is a medical disease, whereas the presence of complications like deformity, instability, or significant neurological deficit is a different ball game. And you need to, this is what is called as complicated tuberculosis. Therefore, in complicated spinal tuberculosis, whenever there is a neurological deficit, severe vertebral infection like pan-vertebral disease, the presence of spinal stress signs, a kyphotic deformity greater than 30 degrees, instability, they are all indications for surgery. One of the new recent developments that is likely to come within this year is probably the defining what is tuberculosis, what is instability in spinal tuberculosis. There is work going on by 2 different authors group, and probably within the next 6 months to 1 year, we will have a definitive idea. What do you mean by instability in spinal tuberculosis? What about the elderly? Elderly, even though there are patients with high comorbidities, we have found that the results are good, and if indicated, you operate them early, make them ambulatory, the outcome is much, much better. We do know that the risk factor for severe progression is age less than 10 years, vertebral body loss, pre-treatment deformity of greater than 30 degrees, junctional levels, and the presence of spinal stress signs. Now we know which surgery to do, when do you have to do surgery, but which surgery to do, whether to go from anterior, posterior, or a combined approach. These are the goals of surgical treatment: decompression, deformity correction, and stability. The question comes whether it's necessary to do all the 3 components. Most of the time, it could be adequate to do 1 or 2 of these components. And in some scenarios where you may have to look at deformity correction, because deformity in active spinal tuberculosis is largely flexible and it can be corrected by your positioning and minor degree of compression during the procedure per se. Therefore, when you choose approach, the Hong Kong procedure and the modified Hong Kong are the one which have been traditionally very popular, still popular in case of anterior disease, in case of cervical spine. Whereas in Hong Kong, you remove the whole of the involved vertebra, whereas in modified Hong Kong, you just remove the part of the diseased vertebra so that your segment of fusion becomes significantly lesser. Chances of graft failure also becomes lesser. It is still the mainstay of treatment in cervical tuberculosis. Rarely you do nowadays due to a combined antero-posterior approach, because the posterior surgery has advanced to a large degree. It has obviated the need of this approach. Therefore, now the current trend is for mainly all posterior approaches, especially in thoracic and the lumbar spine, where you can achieve all of this. We can achieve decompression, debridement, reconstruction, instrumentation, correction of deformity, all by a posterior approach, what is called as the global fusion. Therefore, posterior surgery could be just an instrumentation. You can instrument with decompression. You can transpedicularly debride, and you can do a global reconstructions. So these are examples of a posterior-only surgery wherein it is instrumented with a good degree of correction. And basically what happens, as I mentioned earlier, it's a flexible disease. Tuberculosis of active spine is a flexible disease. Moment you position the patient prone, you instrument, compress it, usually it heals with a good consolidation. And even at 6 months, it could be adequate, especially more so in the early tubercular lesions. And it is ideal in patients with a posterior-segment disease, that is tuberculosis involving two adjacent vertebral segment is basically what is called as a posterior-segment disease. You can go much shorter alone. Therefore, most of the scenarios in thoracic and thoracolumbar tuberculosis are lumbar tuberculosis when the vertebral body involvement is less than 2 or 3 vertebral bodies, because when it becomes more, it becomes difficult to reconstruction from behind. When the overall vertebral body loss is less than 1, elderly patients with severe pain, multi-level involvement, a posterior surgery alone is adequate. When the vertebral body loss is more, when the defect is there, you've got two options. One is to do a posterior laminectomy and just shorten the posterior column or to reconstruct. This is an example of a transpedicular debridement and posterior closing wedge osteotomy, a good correction of the deformity, a good healing of the lesion. And this is what we do because the anterior lesion is soft, you need not reconstruct. But if there is a deformity, you can reconstruct the anterior column like a TIL, if a transforaminal excision, facetal, resect it, put a cage and come out. And we have moved to do that same in the thoracic spine. I mean, the introduction of a TILIF cage is easier. We can have different custom-made cages up to 20 millimeters. Thoracic vertebral bodies are lesser. You may have to remove the rib and you can achieve a good degree of correction. But when the defect is more, you may have to use a cage to reconstruct, and you may have to remove what is called as a costotransversectomy or an anterolateral approach, which helps in the reconstruction. A pictorial representation of an operative procedure where a transfacetal reconstruction with the cage. And it could become more difficult as you come down to the thoracic spine, but in the lumbar segment, it's important to save the motion segment. Use the part of the pedicle which is not affected, use it as a part of your fixation anchor points so that you can reduce your fixation to monosegmental or sometimes involving one more vertebra. But in this scenario, save the joints and you can remove the implant at the unfused segment once the disease tends to heal. We know that now the disease cure is not everything in spinal tuberculosis, because in children the disease tend to progress. As a classical example of one of the MRC study patients, disease progress over 6 years to a horrendous 128-degree curve. Therefore, it's important in spinal tuberculosis, identify which is uncomplicated or complicated. Uncomplicated, treat it medically, do a biopsy in most of this scenario. Most important thing, ensure compliance, adequate drug dosage based on the body weight. Surgery is indicated only in patients with neurological deficit and instability. If surgery is indicated, we can go for a simple procedures like posterior-only instrumentation to reconstructions. Anterior surgery is definitely the treatment of choice when you indicate surgery in cervical tuberculosis. Thank you very much.
Yeah, thank you, Dr. Ajay. Such a wonderful description of tuberculosis, one of the commonest.
Hi, Firoz. How are you?
Hello, sir.
You are muted, Firoz. You are muted. Yeah.
Okay. How are you, Ajay?
How are you?
I'm good. You're doing well?
I'm not able to hear anybody.
Unmute yourself.
Apaji, can you hear me?
I can hear you, but I'm not able to hear you, sir.
I think there is some problem in my audio. I'm not able to hear both of you.
Oh.
Can you hear me?
Yeah, I can hear you.
Apaji, can you hear me?
Yeah, I can hear you, Feroz, sir.
Yeah, I think I had muted it. Sorry. How are you guys?
I'm fine, sir.
Yeah, Ajay, how are you?
I'm fine, thank you. You see, I'm operating.
So how are
yeah.
You're operating? Yeah, I've just come for this talk. I have to get back.
Yeah. Except for Apaji has to stay back the whole day.
Yeah.
Any questions?
Yeah, sir. A nice description of TB. How much, I will ask you, if you in a OPD practice, if you see, say, 20 or 30 TB patients, how many undergo surgery in your hands?
Maybe around 10 out of 30, because most of the patients who come to us would be in advanced stage, either with deficits or things like that, or sometimes they come to us with symptoms with chronic pain, which we get an MRI done and you diagnose spondylodiscitis. If that is the patient, you end up doing a biopsy, treated with medicine. But most of them who come to you would have been on medicines or advised medicines, not taken medicine for 2 to 3 months, then come to you with deformity or neurological deficit.
Okay. How many patients advise surgery elsewhere you have treated conservatively? And what type of patients? Mainly, not how many. What type of patients?
Unfortunately, it's not a situation in tuberculosis. Actually, tuberculosis, when patient is advised surgery, when they come to us, most of them need surgery. It's not like a disc. You find that in cervical disc, lumbar disc, usually people would advise surgery within a week's time. And you may treat them with a nerve root block or conservatively they become better. But in tuberculosis, most of the time when they come to you, when it's advised surgery elsewhere, they need surgery.
Okay. So, drainage of abscesses. Do you still do? No drainage of abscesses.
I sometimes do, in the sense, if somebody has got a huge abscess in the dorsal region and patients feel uncomfortable about it, we just do an ultrasound guided aspiration.
Okay. The next question is, if the patient has completed ATT and you still see some collection around the old TB, but the MRI is showing the bone has healed, but there is some collection.
See, the thing is that the first question is whether it's necessary to get an MRI done in all patients. Number one, usually around 9 months' time, you see there is a significant weight gain. Patient has got complete sense of well-being, is able to do all activities, and you see in X-ray there is no further destruction. I mean, I would not do an MRI in that group of patients, but if the patient is affordable, I always get an MRI done. Therefore, in my practice, about 50% of the patient will not get an MRI because for them, again, a cost is a concern. The moment you tell him, we need to get an MRI to see, he'll say, doctor, I'll come next time, I have not bought the money. Therefore, 50% of them end up getting the treatment stopped based on clinical judgment and ESR, X-ray. Another 50% we get an MRI done. A presence of an abscess without any changes, I mean, the bone has healed, there is a good fatty replacement, we usually stop it.
So, what is the end point to say that this TB has healed? So, what is your end point? Like, we know that we have book description, but what in a conservatively managed TB spine?
See, my end point is a sense of well-being, number one. No further destruction of bone in the X-ray. Okay, that is the end point. Because if you want to see sclerosis in an X-ray, you will have to wait for a long duration of time.
Yeah. So yeah, exactly. So TB heals by fibrosis. It doesn't, unlike pyogenic discitis where it heals by osteogenesis, TB heals by fibrosis. So we should not expect sclerotic bone in TB.
No, you do get it, but you have to wait for some more time.
Yeah, 2 to 3 years. Like it, yeah, it makes 2 to 3 years it takes. But the healing is by fibrosis initially. Yes, sir. So, any other point you want to tell, sir, for the general orthopedic crowd who treat primarily the...
If you look at drug resistant in southern India, I asked extensively, it's only about 5%, that to the upper end of it. Whereas in northern India, they reported up to 20-25%. And I feel one of the most important factors which have been contributed is compliance. People here are very compliant. And the moment you tell them you have to take for 1 year, the chances that they will take is very high. Second important thing is that people tend to prescribe drugs on a standard AKT4, 1 tablet per day, 1 sachet per day, which is 4 tablets. But it's meant for a 45 kg. Therefore, most of the patients will be above that. Therefore, it's important to give the dosage based on body weight and compliance.
So yeah, exactly. So the take-home message is the drug usage should be compliant and it should be adequate to the weight of the patient and not by the composition. So we should use correct weight dosages. Thank you, sir. Any other questions from other panel?
Okay, guys. Thank you.
I think
you all.
Everybody knows TB well, sir, better than most of us. So thank you, sir.
Thank
We'll
you.
go to the next. We'll go to the next talk. It'll be by Dr. Feroz. It is on rationale behind management of thoracolumbar fractures. When to operate, when to treat them conservatively, and what type of fixation and surgery indications. Dr. Feroz, please.
Good afternoon, everyone. Thoracolumbar fractures are probably the most common fractures that we see in the lumbar spine. And I'm going to talk of management of thoracolumbar fractures. The objective of this talk is to study the personality of the fractures, classify them, operate versus conserve, approach to surgery, decides on the signals for fixations, and decide to fuse or not to fuse. The reason why we have fractures more at the thoracolumbar junction is due to the transition zone that is seen between the kyphosis and the lorosis. The lumbar spine is less stiff in flexion. And this transition zone predisposes to failure. There is a central loading force that acts at the thoracolumbar junction, leading to fractures. Classifications are too many and one gets confused by it. You have the Dennis classification, the AO classification, the TLICS classification. So what is, how do we identify instability? How do we define instability? Clinical instability is the loss in the ability of the spine under physiologic loads to maintain relationship between vertebrae in such a way that there is neither damage nor subsequent irritation to the spinal cord or nerve roots. Spine Trauma Study Group has defined three categories: mechanical stability, suggested by morphology of the injury; long-term stability, indicated by the integrity of the PLC, or the neurological stability, indicated by the presence or absence of deficit. Clinical examination is divided into epiconus when the fracture is above D12, conus metatarsus when the fracture is D12, L1, L2, coraquina when the fracture is below L2. Treatment: medical is mainly with steroids, augmented with bracing. Surgical is instrumentation and decompression. The medical management, the primary insult is the insult that, or the damage that happens to the core at the time of the injury, and this is non-modifiable. Secondary is something that can be treated or can be modified rather. Is due to vascular dysfunctions, edema, ischemia, electrolyte shifts, free radical production, inflammation, delayed cell deaths. A lot of drugs are used, including steroids, gangliosides, naloxones, calcium channel blockers, free radical scavengers, and neurotropic agents. A word about methylprednisolone, a drug that's so widely used. And there are some studies to show that if it is used within the first 3 to 8 hours for about of injury, then there is some neurological recovery, but it remains a big controversy. Some centers use it regularly and some do not at all. If it is used in 30 milligrams per kg body weight, a bolus dose followed by 5.4 milligrams per kg per hour for 24 hours if the injury is presented by 3 hours, and for 48 hours if it is presented by 8 hours. Bracing is mainly used in fractures that are stable without any neurologic deficit. There are many types of brace available: TLSO brace, Jevons brace, anti-reaction brace. It's normally worn for about 3 to 6 months depending on the fractures, and it's only initiated when there is clinical and radiographic evidence of fracture healing. But the big question still remains: does bracing really help? One really doesn't know. Coming to the morphological algorithm, surgery or no surgery is very individualized depending on the fracture. But if it's an A0, A1, A2, then normally you don't need surgery. But if it's an A3, A4 unstable burst fracture or a type B or a type C fracture, then surgery is indicated. The goals of this surgery is to achieve and maintain anatomical reduction stability, have a neural element decompression, immediate mobilization, and early rehabilitation. Timing of surgery is very important. If it was below 24 hours, 24 to 72 hours, more than 72 hours. And there was a study that was published in the AO Spine where they concluded that the earlier the decompression, the better it is. Timing of surgery also decides the surgical procedure. If it's less than 2 weeks, then posterior surgery works well with low risk of implant failure. But if it's more than 2 weeks, then additional implant support to prevent kyphosis or for kyphosis correction and late implant failure. Anterior approach gives you direct visualization and decompression of neural elements, restores anterior column, and corrects the kyphosis. Contraindicated in PLC insufficiency, osteoporosis, in patients who are obese with severe pulmonary disease or low lumbar fractures. Posterior approach is the most commonly used approach. It's easy, reliable, safe, gives indirect canal clearance, can correct the kyphosis. But you can also have a late kyphosis if you fail to reconstruct the anterior column. There are many ways you can reduce a fracture. Postural, you have the pre-pin rods, cantilever ligament of Texas. Reverse cortical sign is when the rectus fragment is rotated more than 180 degrees. Severe ligamentous disruptions, and it's a contraindication to ligament of Texas. There are some instances where you have to clean the canal posteriorly. When there's a fracture of the conus with the posterior failure and neural deficit, you get canal intrusion, where you don't have to or should not retract the durac cord, and the fragments just tempered back into the body. Short, long, or intermediate depends on the type of the fracture and the patient. But when there is a type B injury, then it has to be a long level stabilization because it's 3-column fracture, mainly seen neckline spondylitis or dish. Anterior posterior approach, so fractures thoracic or the thoracolumbar region, L-chair with failure of the posterior tension band and significant anterior column injury with or without retrobulbous ventral fragment and right deficit with a severe canal stenosis with more than 75. Fusion has its advantages because you can restore the stability of the spine. It supports the implant rather than the implants above the bone. In young patients, you can have a short signal stabilization, prevents implant failure. Implants can be removed after fusion, especially in young patients. So the whole idea is to reconstruct the anterior column, because if you do not reconstruct the column, then this is what you get. Type C injuries, main cause of neural deficit is the initial impact. Prognosis is poor, role of decompression is doubtful. Many surgeons only stabilize. Percutaneous fixations, in patients who have no neurological deficits, intact PLCs, type A3, A4 fractures. But where there is a PLC deficiency or where there were fractures where you need to decompress, and there are such patients where one should not try percutaneous. The downside is it's not very cost effective and a lot of radiations involved. You have a balloon assisted reduction in cement augmentations. It can be utilized with open surgery or percutaneous fixations. Can avoid an actual or a combined approach. The take-home message is detailed clinical and radiology examinations must identify fracture morphology and PLC status and classify individualized treatment. If surgery, always reconstruct and get a good height of the entry column. Thank you.
Thank you, Dr. Feroz. Yeah, question from my side first. Hello? Hello?
Okay. Appaji, can you hear me now?
Yeah, I can hear you.
Okay. I can't see you, but.
Yeah, I have not switched on my video.
Okay. Okay.
Yeah, I can switch it on now. Yeah.
I did not recognize my voice.
It looked like a European or a British speaking.
Yeah, someone. I thought it's someone from Europe. Anyway, yeah.
So the question from my side will be on the steroid usage. There's now enough controversy and now enough evidence against the use of steroids. So do you still recommend to the general crowd?
I personally do not use steroids. Hello.
So do you recommend to the general crowd to start steroid or not to start steroid?
No, the problem is, I'll tell you what, suppose the patient comes to me, I don't use them. I had a few instances where, the patient goes to some other hospital and they tell the patient, oh, the steroid has not been used. If the steroid had been used, the patient would have improved.
But you do explain to the patient that steroid can be used, but you prefer not to use it, right?
I not to use. I never use.
Yeah. Okay. Vikas, are you there? Can you ask some questions? You are from the Spinal Injury Center. Vikas? Because it's not there, is it? Oh, we are 10 minutes ahead, Dr. Feroz. So how much can we talk on trauma now?
So do you use steroids?
No, I generally in traumatic situations now I do not use at all. But I tend to err if they come with an incomplete neurology.
Okay.
So I tend to use it but not at that dose, not at the NASIS-2 dose. It's the pulse steroid which the neurologists give in like my transverse myelitis and other things. I use just 500 milligram BD dose, like a pulse steroid dose. Yeah.
Do you think 500 milligrams BD is okay?
No, there is no scientific basis on what I do. Yeah. I also feel I've moved out of using steroids in most of the other traumatic situations, except for the cervical incomplete, where there is some evidence still that it can be of help. So otherwise, I do not use at all. Yeah, we have had enough complications. In fact, one of our patients developed a huge bleed. He had a duodenal ulcer, acute duodenal ulcer, which eroded into the gastroduodenal artery. And then he had a bleed and we had to take him, embolize him immediately, and all those things happened. Instead of managing his spinal trauma, we were managing the gastric bleed, in fact. Yeah.
Actually.
Please go ahead. Yeah.
I was actually talking to one of the neurosurgeons who is a regular user of steroids. And he says that, no, if I use them, I have seen that they are getting results. So I personally don't use it.
Yeah, I mean, most of us have stopped using it. Yeah, but the neurologists use it for cord edema and other transverse myelitis and demyelination. They have something like pulse steroid. Even for GBS, they give pulse steroid. So I tend to use it for that, but there is no scientific evidence, as I told you. Next question I wanted to ask is about the timing of surgery. Do you rush in to do these spine fractures now, or you wait? Do it as an elective?
Yes, it's if it is really, someone who's having neurological, which is progressive deficit, then probably yes, I would go in and do it. Otherwise, I don't do something in the late night. I will always do it at whenever it is available. The OT is available. So yes, I have years that it's the timing of surgery actually is not a very big issue. It's actually the impact during the injury that actually determines the prognosis. How bad is the impact at the time of the injury?
Okay. So do you still, if it is an incomplete neurology, like you see a patient has some preserved motor function below the level of injury, do you do it urgently, or you still do it as a semi-emergency, like work up the patient properly and do it?
I would say if it's late in the night, I will not do it. I'll wait for the next day.
Okay, so that's the main point. Yeah. The next question was about the levels of fixation. So in a patient without neurodeficit, how do you convince the patient for surgery? So what are the points you will require? Like if you have to teach a PG, what are the points you have to tell that this patient requires?
Yeah, no, I'll tell you, if there is, if I see there is significant retropulsion and the patient does not have any neurological deficit, there is a high chance that the posterior elements are fractured. And, there'll be auto decompression. So that is that. Yes, if a CT will confirm this regarding the posterior elements. If I see that, yes, there are posterior elements that are ruptured, then probably, yes, I will go in and operate.
Okay. So the third point is, if there is we already had a talk on radio diagnosis, radiology for fractures. So do you depend on the MRI for every case to make sure the PLC is not injured, and then decide on the approach, like anterior, posterior reconstruction, how many screws, like that?
See, normally nowadays I do everything posteriorly. I used to do a lot of anterior posterior, which I thought is not really required. But now I have shifted to most 90% is all posterior. Yes.
Yeah, and levels of fixation. The olden school thought used to be that you fix longer in fractures. But now with the newer rehabilitative papers, they say fix shorter so that the patient will have at least adequate movement in the spine.
Exactly. Yes. Nowadays, yes, it has to be adequate fix levels. I don't say that you fix too long, but it should be just adequate. That's all.
So most often in the lumbar or thoracic, you'll fix shorter, and if it's a junction like thoracolumbar, like D12 or L1, you'll fix slightly longer.
Yes. Okay. Junction. So I know. Yes.
Yeah. So the next question will be in stiff spine. So the problem is when these stiff spines come with a fracture, which is very painful and no neurodeficit, but during anesthesia, there are lots of mishaps. I've had one, and I've heard of so many mishaps. Yeah.
I also had one. Because they are very, very unstable. They are highly unstable. And I had one in the cervical spine. I didn't have a mishap in the lumbar spine, but yes, I did have a mishap in the cervical spine. But in these situations, you have to fix long because they are very, very unstable.
Yeah. So in a stiff spine, you will fix long, and you'll be very careful not to alter their position during induction of anesthesia, right?
No, I just fix it in situ. I just don't try to do a lot of correction. Yes.
Yeah, that's a point I want to bring out, because I've heard some of the, I've heard from hearsay, this is not correct. Correct me if I'm, some people have tried manipulating spine and then landed up in big soup, and so this is for general orthopedic crowd. Do not, in a stiff spine, if the patient comes with a fracture and severe pain, never ever try to manipulate under anesthesia. Yeah.
That is the last thing you should do.
Yeah. So I think we are okay with this, Dr. Feroz. Thanks for such a wonderful talk. I think conclusion points will be steroids. As of now, most of us do not use it. Fixation should be, timing should be semi-emergency. It need not be like rush into the place. In complete neurology, you should operate, and in stable situations, you should operate. There are criteria for conservative treatment. You can read through the Marcy papers where they treat most of the fractures conservatively. And the third point will be fixation should be adequate, not long or short. Enough, I think. Dr. Feroz, anything you wanted to add?
Yeah, I had met a Bangladeshi surgeon in a meeting, and he told me that he treats all fractures conservatively, and he gets good results.
Yeah, see, there is a good paper from that Marcy et al. So people can go through that paper where their main thing is conservative management and rehabilitation. So most of the deficit or neurodeficit patients require good rehabilitation rather than surgery. Thank you, Dr. Feroz.
Thank you. Thank you.
So next talk will be by Dr. Vikas. Vikas, are you there? Vikas?
Hi, how are you?
Yeah, hi Vikas. So next talk will be by Vikas. It will be decision making in the management of osteoporotic vertebral compression fractures. So Vikas, go ahead, please.
Thank you. Talk for this forum is decision making in management of osteoporotic vertebral compression fractures. And so we all know that osteoporosis is a skeletal disorder which is characterized by compromised bone strength, predisposing a person to an increased risk of fractures. Bone strength primarily reflects the integration of bone quality and bone density. So once your T-score on an DEXA scan is less than -2.5, we label these patients as osteoporotic patients. And before I start this particular talk, I just want to highlight with this particular table that no treatment, whether conservative or surgical, whenever we decide for a particular fracture, is complete without knowing or starting the medical treatment of osteoporosis. I'm not going to the details of this, but medical treatment form is an integral part of any form of management for osteoporotic vertebral compression fractures. So when we talk about decision making in osteoporotic vertebral spine fractures, basically the first decision has to be made is whether you really need to operate the patient or you can conserve the patient. So to answer this question, it is very important for you to understand the morphology of the fracture which is there, and you look at the X-rays. This was initially propagated by Sugita et al. In 1995, which was an X-ray based classification, and he classified the fractures into 5 types. You can see on the left hand is normal type, then you have swelled front type, you have a bow shaped type, and you have a projecting type, and then you have a concave type and a dented type. So all these morphologies can be seen on an X-ray and can be identified. And according to their observations, patients who had a swelled front type or a bow-shaped type or a projecting type, these are malignant forms of vertebral compression fractures of osteoporosis, which probably would lead to a complication like further collapse or kyphotic deformity, which may lead to a neurological involvement. So such cases or such fractures, when seen on X-ray, they just cannot be just conserved. They need to, you need to deal with them aggressively, maybe with a surgery, right? Whereas when you see a pattern like a concave type or a dented type, these are benign types of osteoporotic collapses, and patients who have this kind of a picture, they can be conserved. By conservation, I mean they can be treated with a brace, with medical management of osteoporosis and with analgesics, and we can expect good healing in these kind of fracture patterns. Whereas the lower 3 ones, that is swelled front type, the bow-shaped type, and projecting type, they are known to be notorious and can cause delayed complications. Now, this was an X-ray based, and this was in 1995, which was given by Sugita et al., which was further upgraded in 2018 by the classification of osteoporotic thoracolumbar spine fractures recommendations of the spine section of the German Society of Orthopaedics and Trauma. And they came up with a classification which was based on all the modalities of radiology which are available, that is the X-ray, the CT scan, and the MRIs. And they came up with, again, 5 types of OF or the osteoporotic fractures. And the first 2 types, wherein you see the edema in OF1, the whole body edema, and the OF2, which just has little bit involvement of the posterior wall, less than 1/5 of the posterior wall, and only involving the upper or the lower end plate. They were supposed to be the nascent ones, and they can be treated conservatively. According to them, they prognosticated that. And if you have any picture wherein there is OF3 or OF4, that is involvement of both the end plates, or there is disintegration of the shape of the vertebra, or there is a rotational component to it, like in OF5, then I think they propagated that surgery could be a better option to prevent late complications in osteoporotic spine fractures. So this is how you basically make a decision whether you need to operate this patient or you can conserve the patient. So that is the first decision that you always make when you see a patient with osteoporotic spine vertebral compression fracture. So once you have decided that you have to operate this patient based on the pattern of the patient, morphology of the fracture, then the other thing starts as to what are the strategies to implement as to how to improve your fixation, or what exactly you need to do. So surgically, we either take care of the pain of the patient, or we need to stabilize and decompress the spine. So basically, the problem with osteoporosis is that osteoporotic spine, however, causes problems in management, particularly where instrumentation is involved, resulting in screw loosening, pull-out, pseudoarthrosis, or adjacent segment kyphosis. Osteoporosis alters the biomechanics of the bone implant interface, resulting in various degrees of fixation failures. So basically, since the bone is soft and we are going to put a hard implant into the bone, there could be all these problems that have been labeled just now. So it is very important for you to strategize your fixation, and there are multiple ways to improve your fixation when you are dealing with osteoporotic spine fractures and you have to do a fixation. So this, when we come to fixation part, let me divide the things into 2 very broad categories. One is that how do you improve your surgical technique? That is one. And what are the implants or novel things that are there in the industry or with you, which you can use to improve your pull-out strength. So when we come to basic surgical technique, there can be things like you can increase the diameter of the screw so as to get a better purchase in the pedicle. You can increase the length of the screw. You can use a small pilot hole and then put in a larger diameter screw there. You can do under tapping of screw track. You can have a longer construct. So you can take multiple points of fixation so as to reduce the stress on the implants there. You can do a supplemental anterior fixation or an anterior reconstruction. You can use laminar hooks or wires, because that is what is only laminar hooks and wires are basically holding the cortical part of the vertebral column. So the fixation is better. You can use transverse connectors to again disseminate the stresses on the implant. Then there are novel surgical techniques which are there by using a double screw technique, or you can use a bicortical screw technique. So what you do is you put a longer screw engaging the pedicle, and you put such a long screw that you engage the anterior cortex of the vertebral body so as to improve your pull-out strength there. Or there's another trajectory which is known as cortical bone trajectory, which has been utilized in midlifts. So you put your screw only in the cortical part, so there is no cancellus. So the pull-out is better as compared to a routine pedicle screw. Now the other concept is novel screw or a construct. So you can use expandable screws. You can use injectable pedicle screws through which you can inject cement to augment your screws. You can use coated screws, which could be hydroxyapatite coated. And obviously you can do cement augmentation. You can do prophylactic vertebroplasties. And there are multiple other things by which you can improve your construct and by which you can improve your pull-out strength of your screws. So let me impart this with the help of a few cases so that I should be able to give you the right message. So this is a simple case. She's a 65-year-old lady. She has severe pain in the back for 4 weeks with multiple comorbidities like SLE, diabetes, colitis, hypertension, CAD, Parkinsonism, and she has severe osteoporosis with a DEXA scan of -4 in the spine with a neurologically normal patient. So the main complaint is back pain. So, when we deal with such patients, and you don't want to keep these patients on bed for a long time, and you don't want them to suffer also because of the pain. So the best thing to do for such patients is, these are the X-rays of the patient. There is hardly any instability, but the patient has very severe pain, which is making her life very difficult to live. So these are the MRIs, and what we did was a simple procedure in the two vertebrae which were fractured, which were showing edema. We did kyphoplasties for that. Now, when do you opt for? Another question could be, decision making could be, what do you do? Whether you do a vertebroplasty or what do you do a kyphoplasty? So basically, the difference is that in kyphoplasty, you are inflating a balloon prior to injecting the cement. When you inflate a balloon inside the bone, you create a void there. So the advantage of this is you can inject cement, which is more viscous. So the chances of leakage are much less in a kyphoplasty. Whereas in vertebroplasty, since you are not using any balloon and you have to push cement, you are likely to use cement which is less viscous, and the chances of leakage are a little higher in vertebroplasty as compared to the kyphoplasties. So, basically, kyphoplasties and vertebroplasties are pain management modalities which are done only to take care of the pain of the patient. Another case, 98-year-old male, otherwise healthy, neurology normal, severe pain in the back, and you can see it is a pincer type of fracture, that is OVF4, if you remember your classification. Now, this is a situation wherein you need to you stabilize. A simple pain relief cannot be there because this is likely to go into kyphosis and cause him more further complications. So we decided to do a good job for this guy, and we did a hurried job with cement augmentation, and we did a percutaneous fixation, and we also did some vertebroplasty just to augment the anterior vertebra, and he did quite well. So that's also because the fracture opened up. Now, another case, 76-year-old male, severe back pain and radicular pain. It's a long-standing old fracture, and pain was so bad that he could not even sit. Neurology was normal. There were no comorbidities, and DEXA lumbar was -4.3. So in the X-ray, you can see there's a fracture of L4, which is an old fracture, and probably because of the instability, which you can see on the flexion and extension views, it is opening up on extension. This is a closer view of that, and it's an old fracture. The patient had back pain, and he could not even sit, and he had very severe radicular pain on both the legs because of this. You can see the central part is not that badly stenosed, but if you look at the foramens on either side, on the MRI, they are very badly stenosed, probably because of the chronic instability which he had, because this patient was initially treated conservatively. Now we had to do something. The principles of surgery for this particular patient would be to stabilize because there is instability, to decompress because there is foraminal compromise, and to stabilize in such a way, because this is an osteoporotic patient, you need to stabilize in such a way that your pull-out strength becomes is not compromised. So what we did was, we did this. We did augmentation of our screws at L5 and L3. We also inserted 2 screws in L4, which was the fractured vertebra, to improve the overall strength of the construct. We did an interbody, and we did a good decompression. We also added a prophylactic vertebroplasty at the upper level so as to prevent any adjacent segment fracture prophylactically, just to make sure that our construct lives longer. So this patient was very happy with the surgery, and he did very well. And it's been almost 3-4 years down the line since this patient has been operated, and this patient is doing very well. There has been no signs of any loosening. Cement and the screws are holding very well, and the patient is doing very well. Another case through which I want to give my message is, this is a 61-year-old female patient with a history of trivial fall, and she had complaints of weakness of the lower limbs with Frankel grade C and with involvement of bowel and bladder. You can see there's a fracture there, and there is kyphotic deformity which is there, and patient looks very severely osteoporotic. This is the X-ray and the MRI. You see there is retrobulgation of the fragment there. Probably it's an old fracture, and there is no anterior structure which is there, and that's causing instability and causing compression of the cord. So now the problem, this has to be very nicely dealt with, because when you treat such patients, the idea should be to stabilize, because there's a fracture and there's instability, and you want to, since you are dealing with an osteoporotic patient, you would probably like to augment your screws so as to have a better pull-out strength. At the same time, there is no anterior thing that is going to, so if you do not do any anterior reconstruction in this patient, it is likely that there will be too much of stress on your posterior implants. So probably, I think you anyway have to decompress. So I thought of doing a corpectomy for this particular patient because I wanted to recreate anterior structure or reconstruct the anterior structure so as to produce, put less stress on my posterior implants so that my implant or my construct lives longer than than it would be if I do not do an anterior reconstruction. So probably in this particular case, I would think of an anterior reconstruction definitely and do a decompression and stabilization with formation. And this is what we did. So we went 2 levels up and 2 levels down. We augmented our screws with cement and we did a corpectomy, decompressed the cord nicely, and we had put in a cage. Retrospectively thinking, this case looks, the X-ray looks very good. But only thing that if I critically analyze my own X-rays, I would probably put in a bigger cage because the larger the cage, it would, surround the end plate nicely on the more stronger parts of the end plate, and the chances of sinking of the cage would be even further reduced. Otherwise, this is a very well performed case, very nicely done, and the patient did very well. She improved drastically and she started walking, and it's been almost again 4-5 years down the line, and she's doing well. So these are the cases through which I wanted to give you my message. And just to add on to whatever cases I have shown and whatever I do whenever I treat these osteoporotic patients is medical treatment is essential. I do start them with denosumab, or I start them with teriparatide based on multiple things. So medically, I have to see what is right for the patient. So medical treatment always forms an integral part of any of these patients which are being treated. So to conclude, basically you need to decide whether you have to operate or conserve based on the morphology patterns which I have told you. You could follow Sugita et al. You could follow the other classification which I showed. Then you need to have various strategies that in case you have decided to operate, how would you improve your fixation, whether it will be a longer screw, the bicortical screw, a bicortical pache, or segment augmentation, or various other strategies which we discussed just now. And again, I want to highlight that medical management is an integral part of the treatment, whether you do a conservative treatment or a surgical treatment. Thank you so much, and I would be willing to answer any of your questions. Thank you so much.
Thank you, Vikas. So, Vikas, are you there? Yeah, I can see.
Yes, hi.
Yeah, hi. So that was a good elucidation of osteoporotic fractures. But if you have to instruct the general orthopedic surgeon on a vertebral osteoporotic fracture management, like what will be the primary? See, I see most of the people come with a huge brace. They are like rested on bed. And what do you tell to them? I mean, these patients, or if you have to instruct a general orthopedic surgeon, okay, you have to do these things for a, say, less than 30-degree collapse, say L1. And it's 100% osteoporotic.
Absolutely. So very apt question actually for this particular forum. I think it's very important, first of all, to decide whether the fracture the patient has got is a nascent looking fracture or a malignant looking fracture. So that is something that is very important to decide at day 0. So if you think that it's a nascent looking fracture, especially based on what I spoke initially about the Sugita et al. Classification and the other classification which I spoke about. So if you think it is a nascent looking fracture, which 90% of the fractures would fall into category, these patients can very well be managed with a brace, with analgesics, and with appropriate osteoporotic treatment. By osteoporotic treatment, I mean all those drugs that we have for osteoporosis, including the biphosphonates, teriparatides, and the denosumabs. All that we have, the gamut of it is there with us, which can be used to improve the. Now, the bracing has to be bed rest or bracing. Basically, in the acute phase, you can start off the patient with the bed rest. As the pain becomes more bearable, I would encourage my patient to wear a brace and start mobilizing as soon as possible. It's only if it is a nascent kind of a fracture. If the fracture to me, the morphology of the fracture to me looks like that this patient may actually go into kyphosis, or this may land up in a problem with neurological deficits later on, I may counsel the patient at day 0 also that this is one fracture which may go into problems and you may need a surgical intervention for it. So I would prime the patient initially. At the first go, they may not understand the importance of it, but yes, you need to prime them based on whatever knowledge that you have, got all these years. So you need to prime them based on the morphology of the patient, of the fracture, and that's how I go about it.
Okay. So second thing is, when do you mobilize these patients?
All depends about the pain, pain of the patient. I will do them the next day only with the help of a brace. If they're comfortable to walk, I would do that. I mean, the bed rest part is only to take care of the acute pain phase. If pain is bearable to the patient and patient feels comfortable with the brace, I would mobilize them day 1.
Yeah, and do you start them on any extension exercises or something like that?
Not immediately. Not immediately. I would wait for the fracture to heal, which would take about 8 to 12 weeks for any fracture to unite or to heal up. So maybe after that, I would recommend the exercises.
So exercises you'll start after 6 weeks. Bracing from day 1. If the pain is not there, make them walk. So absolute bed rest is only for the acute pain, and not if the pain is less. You should, the earlier you mobilize them out of bed, better it is for them, right?
Better, yes.
Okay.
I think you would do the same thing.
Yeah, as you rightly said, medical management of osteoporosis is the most important. So what type of medical management is bisphosphonates or teriparatide? Which one do you use?
Usually I am a little bit more aggressive when I deal with patients who come to me with a fracture. Even if you go by the FRAX criteria and other criteria which are laid down in literature, any patient, osteoporotic patient who comes to you for management, medical management, if there is a fracture, you need to start them with a hormonal treatment, that is either a teriparatide, or you start them with denosumab. So I would not give them biphosphonates. Maybe along with what I'm giving as a teriparatide or denosumab, I may add biphosphonates, but not only on biphosphonates.
So denosumab now as a newer molecule, they work more like bisphosphonate, right? They are like osteoclast inhibiting RANK DL inhibitors. So do they also cause fractures or jaw necrosis like bisphosphonates do?
Not many of the, actually some of the, if you look at the complication part of denosumab, it's a very, very safe drug. That's what we know, except for even you can give it for patients who have, nephro involvement. I mean, there is involvement of the kidneys. It is found to be still safe to be given to these patients. So only contraindication is if the serum calcium is high, then you are not supposed to give denosumab. Otherwise, they were very safe drugs. It's a very safe drug which has a safety profile for almost 10 years has been recommended to us. And other than that, denosumab, there have been reports, though they function more like biphosphonates, but the bone formation is bone formed after giving denosumab is much better, is of much better quality. They act both on the cortical as well as the cancellous part of the bone, and so they function very well. And even sometimes in some of the reports of denosumab, they have said that the speed of breaking bone is also quite good. In fact, even immediately after fractures, you can either give teriparatide or denosumab based on what you're comfortable with.
So because it's a newer thing, I wanted you to elaborate on that. Thank you, Vikas. I think we are done with this thing. Okay. Be around because next is this thing, so somebody has to be there to ask me questions. Right?
Sure.
So yeah, can you play my talk now?
I welcome you.
Good afternoon, everyone. I'm Dr. Appaji Krishnan, spine surgeon from Chennai. Welcome to this IOACON Basic Sciences workshop on spine surgery. I'm going to talk on thoracic pedicle screw insertion. I'll be initially talking on the regular thoracic pedicle screw, and also touch upon a deformed spine and give some salvage options. So basic anatomy of thoracic pedicle. So pedicle screw insertion, we should know about 4 dimensions of a pedicle. One is the transverse pedicle angle, that is the angle which is caused by these two lines. The transverse width of the pedicle, that is the maximum width of the pedicle in the transverse angle. The cord length, or it's the screw length, which is from the starting point till the anterior cortex of the vertebra. The starting point and the insertion techniques also should be spoken about. So the transverse pedicle angle, as we were discussing, actually it's around 30% convergent at T1, as you can see here, and it starts decreasing or almost to neutral at T12. So you may have to have just a 5-degree convergence or a 5-degree divergent screw at T12, wherein T1 it will be convergent at 30 degrees. The minimum, most of the other angles will be around 13 to 15 degrees of all the other pedicles. The transverse pedicle angle is calculated in two ways. One is, as we can see, number 2, that is a convergent angle that is calculated between the transverse line along the spinous process and the pedicle. So these are all already available, and one need not do a CT scan to learn about this. So pedicle screw insertion, the next one is we should also know how thick a screw we can use. So the thinnest pedicle in thoracic spine is at T4, which is around 4.7 millimeters. The widest is at T12, which is around 7.8 millimeters. So the commonest screws which are used in the thoracic spine up to T10 will be a 6.5. Above T10, it will be 5.5, and T4 you have to be careful, but you can still use a 5.5 mm screw. The Asian population, the pedicle width is slightly smaller than the Caucasian. The cord length is the shortest at T6, which is around 40 millimeters, and the longest is at T12, which is 47 millimeters. So the longest screw in thoracic spine will be a 45 millimeter at T12, and you can use 40 millimeter almost till T1, sometimes T1, T2 because of the angulation. If you're not getting a 30-degree angulation of T1, T2 screws, you may end up using only 30 to 35 mm screws. The screw length has to be calculated accordingly. So dorsal cortex to the pedicle isthmus usually is around 12.2 millimeters. It varies between 11 to 13 millimeters in the thoracic spine. So the point of entry to the isthmus in the pedicle is usually around 12 to 13 millimeters. The pedicle screw insertion, we should know the starting points. So there are 3 starting points. One is a direct starting point, as you can see here. It sits on the pedicle. The second one is a funnel where the TP meets the lamina. It's a funnel technique. And the third one is a transverse process technique wherein the starting point is on the middle of the transverse process. The insertion technique is 2 types. One is a straightforward technique, which is now popularized by Lawrence Lenke. So it is a insertion wherein you start in the middle of the pedicle and then goes directly inward. And Harms and Foley described an anatomical wherein you start at the superior end of the superior facet and then go downward. So there are 2 insertion technique and angles which are followed. One is an anatomical, one is straightforward. The pedicle screw insertion in the sagittal plane, usually it's around 10 to 15 degrees according to the Indian study from the AIMS from Professor Jaiswal's unit. The Caucasian population is around 12 to 18 degrees. So the sagittal plane angle increases as you go upward towards the T1 and then decreases as you come down towards T12. Techniques of insertion of a pedicle screw commonly used is a freehand technique. I will show you a video plus how to do it. Image guidance, lateral radiography and fluoroscopy, which is very important. You can also use navigation and robotic guidance. Most of us do not have access to these. Techniques of screw insertion, the freehand technique, you should know the starting point for each and every level. There is a chart available in the Lenke's technique. So the freehand technique starts with meticulous exposure. You should have cortical burst to expose the pedicular blush and the pedicle palpation through seekers. You can also use image guidance, which can be a lateral radiography, which can be X-ray taken during insertion, or a live C-arm fluoroscopy. So the insertion starts at the junction of the bisected transverse process, as you can see here. Most of the transverse processes are bisected, and the lamina at the lateral parts. You should not go. It's almost similar to the lumbar spine, except that the facet joint here is in a horizontal plane, and then the superior facet is hidden beneath the inferior facet here. So you will be at the parts at that point where the transection of transverse process meets the lateral parts. That will be the insertion point. Most of it tends towards, in the lower dorsal spine, it is towards the caudal end, and towards the upper thoracic spine from T8 onwards, it will go to the cranial end of the transverse process, and again from T2 and T1, it will be at the middle of the transverse process. So this is a paper from Lenke describing the thoracic freehand pedicle screw placement in thoracic spine and how safe it is. So the incision should be good, adequate, and exposure should be till the tip of transverse process. So the entire spinous process, lamina, the joints, and the tip of transverse process should be exposed. We can use a burr, a cortical burr, to start. So once we determine the starting point, just burr so that you remove the cortical bone and expose the cortical blush. Then using a gear shift probe like this, you can actually, this is, Lenke calls it the gear shift, but we all call it as Lenke's probe. So we usually insert with the convex side facing the medial end. Initially, search for a soft spot and let the pedicle finder fall into the pedicle. Do not force it inside. After inserting around 15 millimeters, which I told you is the isthmus of the pedicle, you have to remove the probe and then reinsert it with the concave side facing medially, so that you can have a medial angulation of the screw. So this is called the gear shift maneuver described by Lenke, but we call it Lenke's maneuver. So these are the points. You can see here clearly how you will insert convex side facing the medial end, and then once you cross the isthmus, turn it to go medially. So the Lenke probe has actually a small angulation which goes in. So a cortical burr, and you can see the blush there. So the insertion with the convex side facing medially, and then gear shifting to face medially. Then you will use a flexible ball tip pedicle probe or a pedicle sound to make sure you're not breached any of the walls. So you have to palpate 5 distinct bony borders: superior, inferior, medial, lateral, and anterior also. Most of the time you might not have palpated anterior. Anterior will give you the depth of the screw. Some people do tapping. So I do tapping. So I use a tap and then repalpate again using the probe, so that I will know that I have not breached any of the walls, and then the screw is placed. So screw length, you should we usually under tap 1 millimeter less. Then again I will palpate and then place the screw very slowly, so that we can use a viscoelastic expansion of the pedicle to our benefit. So measurement of the screw length, and then insertion of the screw, as you can see here. An ideal screw in the thoracic spine should be in the center of the pedicle. There should be no violation of the pedicle walls in proper trajectory, and you should have a very good proper chord length and also the diameter of the screw. A short video here. So I instead of using a burr, I've used a nibbler to decorticate the bone there. This is a T12 screw. So I'm using the Lenke probe of the gear shift, going the convex side in first. I reached up to 15 to 20 millimeters, removed the probe, turned the concave side inward, inserted till 20 millimeters, and then getting into the probe there. So now I use this ball tip probe to palpate the walls and also see how much depth I have to reach. That's the anterior end plate. So again I check So all 4 walls and the anterior walls, so 5 walls. This I've used a tap which is 4.5 millimeter. So I always tap till around 35 to 40 millimeters, since I've measured 45 millimeter as my screw length. And then usually I will palpate after tapping. I think I missed in this video. So that's a screw in. So this is in a real-time speed. I've not speeded up this video, so you can know that it can be done at this speed also. So I've also showed the next D11 also, wherein I have used the same maneuver. I used the nibbler to decorticate the outer cortex. Now I see the pedicle blush there. That's a cancellous bone. I've used the gear shift with the convex side medially. Insert till about that'll be the 20 mark. So I insert till the 20, take it out, turn the probe with the concave side facing medially, then go in again. Do not push the probe with too much of force, just try to get the soft spot in. Again palpate with the ball tip probe. You can feel the anterior stop there. I've palpated all the other walls and insert the screw directly. This is without tapping. So how to confirm that the screw is in good position? So you can either do a fluoroscopy in AP and lateral, or a radiograph in AP and lateral. And sometimes you can use an intraoperative screw EMG or post-insertion 3D imaging if you have the facility, like the O-arm or intraoperative CT scan. In the deformed spine, the thoracic pedicle screw is really challenging, because there is a huge change in the anatomy and morphometry of the scoliotic pedicles. You should have very sound knowledge before attempting in a deformed spine. But the first papers came from Suk et al. In 1995, where he described that the thoracic pedicle screw is possible in deformed scoliotic spine, but it became quite useful, or people started using it more after 2000s only, from 2002, 2003, after the Lenkes paper. So it's a huge learning curve, less complications with experience. The 3D anatomical orientation of the deformed spine, you should have a 3D orientation. If you either do a CT scan, read the orientation, and you should plan meticulously before embarking on inserting a thoracic pedicle screw in a deformed spine. So in the scoliotic spine, you should be aware that the dural sac is shifted towards the concavity. The pedicles at the concave side are very thin and short, and the pedicle width on the concave side is maybe even absent. So you may not even have, you may have a very thin sliver of bone, and you may not have a width of pedicle that is known. And the cord length will vary between the two sides, from the convex and the concave sides. So when you do a CT scan, you should not get a section like this. You should ask for a pedicle oriented section where you can learn the pedicles or see the pedicles properly. And in the scoliotic spine, as I said, the pedicle is thinner and shorter on the concave side than on the convex side. The spinal canal diameter is also smaller on the concave side, and spinal cord is shifted to the concave side. So you should be very, very careful not to insert a screw into the canal in the concave side. And you should have a 3D orientation before inserting the pedicle screw in the thoracic. So concave side will be more horizontal, and the convex side will be a more vertical screw placement. So convex will be a more vertical, and the concave side will be a horizontal screw placement. Actually, Professor Jaiswal has described this wind swipe deformity of pedicles, wherein both the pedicle will be like in a wind swipe deformity. As you can see here, the convex side is also bent, and the concave side is also bent towards the same side. So we can use various other options of screw insertion technique. So you cannot, usually it's very difficult to go through a thin pedicle, so you'll use either an open lamina laminotomy technique or an in-out technique, wherein you'll use the pedicle rib as a single unit to insert the screw. So these are, mind you, these are for highly challenging, these are for highly experienced surgeons, as these are highly challenging procedures in a deformed spine. So the newer techniques are either to use a navigation in 2-dimension or in 3-dimension, where you can actually live navigate the screw and the screw length. The third and the most important is the latest is the techniques of screw insertion using a robot. So robotic guidance, I mean, only few centers in India have it, 3 or 4 centers. So this is one of the planning for a thoracic screw. You can see how they have planned the screw between the rib and the pedicle here in both the sides. And that's how robot helps. This is the first generation robot, and this is from Dr. Sajanik Dey's unit. And most of the time, the pedicle, actually, there is an expansion. So there is a viscoelastic property of the young bone in this deformed spine, wherein you can have an expansion of the pedicle to 111% from their normal width. So you can safely use 4.5, 5.5 millimeter screws. And the pedicle fracture of the lateral wall is seen in these patients in 72%. When you fail to do these, then you have to go for a salvage options, changing the trajectory, anatomical. If you have used an anatomical, go to in and out, or an in and out technique, go to an anatomical technique. You can use hook construct, you can use sublaminar wires or sublaminar bands. The complication thoracic spine pedicle screw is direct injury to the cord, a hematoma because you have fractured the medial wall, or a late screw pull out. Vascular injuries, direct injury to major vessels, because on the side of thoracic vertebra is aorta and the IVC. Some of these screws can injure the great vessels, and some of these patients even have died on table. Visceral injury is quite rare. Pleural injury and lung injury. Injury to thoracic duct in deformed spine and in tubercular spine is also known. So in conclusion, thoracic pedicle screw insertion is safe. It's difficult but feasible in deformed spine, but though it has a big learning curve. Image guidance, navigation, and robotics have helped increase the accuracy of thoracic pedicle screw. The complications, though rare in thoracic pedicle screw insertion, can be severe, leading to paraplegia. Thank you, one and all.
Thank you, Paji. It was a very nice presentation. Very apt. And okay, I have a few questions for you.
Yeah.
If you allow.
Yeah, I think we have 2 minutes. Yeah.
Okay. So quick questions. So how do you make sure about the angulations as they are described in the textbooks while you're performing the surgery? You have to go 10 degrees. You have to go 15 degrees.
No, that's what. So there are 2 ways of maintaining the angulation. One is following the angle of the transverse process. So I showed in one of the slides how those angles change from T1 to T12. So in the T12 itself, if you follow those transverse processes itself, you will be able to have the angle. Normally it's to the vertical, you just eyeball it. So when you're at a 30 degree with your Lenke probe, most often with the concave side facing, you'll be around 15 to 20 degree inward. So that itself is more than enough. But following the transverse process anatomy is the best. Yeah.
Right. Which is your choice of approach? Straightforward approach or anatomical technique?
It depends on. Most often, I'll try for a straightforward approach. But straightforward approach, the inferior breach is very common. Inferior pedicular breach is very common. So sometimes I have to go for an anatomical, but anatomical approach has a better screw length because it is longer, it's in an angle. So you get a longer screw, and the purchase of the screw is also better in anatomical approach.
Right.
I've used both. In fractures, mostly I use straightforward. In deformities, I use anatomical approach.
Right. And just a word for since we have orthopedic surgeons with us, what diameter of screws would you use from T1 to T12? Like what would you go? 4.5, 5.5, 6.5? How would you go?
So that's what T12, 11, 10, most often 6.5. 9876 will be 5.5. 5, 4, and 3 will be 4.5. Again, T1 and T2 will be again 5.5.
Okay. So 1, 2, 5.5, 3, 4, 5, 4.5, downwards 5.5 and 6.5.
6.5s, yeah.
Perfect, perfect. You spoke about in-out in technique. Is there a difference between the pull-out strength of an in-out technique and a normal pedicle screw?
Yeah, the pull-out strength is almost like in an in-out in technique, because you're passing through 3 cortices. Actually, their pull-out strength is slightly better. They say 110% of a normal pedicle screw in the straightforward technique. Yeah.
Right. And just last question: what would you use? What was your preference for? When would you use a monoaxial screw, a polyaxial screw, and a uniaxial screw?
Hello, Vikas. Yeah, I've stopped using monoaxial screws long time ago. So I've not used monoaxial for last 10-12 years now. Uniaxials, if I'm looking for a rod derotation maneuver correction in deformity. Otherwise, I've used only polyaxial screws in trauma and other situations. In fact, in kyphosis corrections, I use slightly the extended screws, the reduction screws in the lower end.
Yeah. Basically, polyaxials make your life very easy.
Much easier
to work with. Monoaxials are very difficult. You have to be very specific in your entry points in having all of them in one go, in one line. So it's very difficult to deal with monoaxial screws.
Yeah.
So thank you so much, Appaji. Back to you.
I think only 4 of us are sitting and listening to 4 of us talking. So I do not know. Vikas tells us that there are 1,000 people watching on OrthoTV. I do not know, but I'll call upon next Premik to give us lecture on the heart shield rectangle, the old and time-tested spine stabilization technique. Premik, all yours.
Yeah. Good afternoon, everyone. Today I'm going to talk about sublaminar wiring. Over several thousand wires under the lamina. It was first described by Luque in 1976 in Mexico. What are the modes of usage? It can be used as a standalone wire in C1, C2. It can be used with the H rods, the Luque rods. It can be used with heart shell rectangle, closed loops, frames, rectangles, and nowadays as a hybrid system between the pedicle screws and the wires. The advantages are it has versatile indications, wide applicability, technically not demanding, excellent corrective potential in all planes, sagittal, translation and derotational, obviates need for post-operative bracing, climate compliance, and simplistic, inexpensive, time-tested. It has an extracortical hold on bone. It is advantageous in osteoporosis. Extraosseous implant. It has a good pull-out property. More forgiving, technically less demanding, less gadgetry. Being a semi-rigid type of fixation, it allows for some collapse or settling of anterior column, which may be beneficial for fusion. Used as a salvage in failed pedicle screw fixation. Sublaminar wires were used widely with great effect for many years until the mid-1980s, until the development of third generation spinal instrumentation system backed by the great metal lobby, the marketing team of them. So, the safety of sublaminar wire was put under cloud. Many papers came out with saying that the sublaminar wire caused lots of neurological complications in all the places where it was used, and multiple papers were come and it came into disrepute. But then came this paper from Boachi in 2000 in Spine, safety of sublaminar wires with the Isola instrumentation for the treatment of idiopathic scoliosis. Well, there were 1366 wires put by him, and there were no patient with adolescent idiopathic scoliosis having any neurological complication. What he concluded was, despite the increased complexity of spinal instrumentation system, sublaminar wires placement is a safe and useful adjunct in surgical treatment of neurologically intact patients with idiopathic scoliosis. We stand here in the defense of sublaminar wires which has been charged with being a neurologically dangerous tool for instrumenting the spine? Well, we have proofs. We have put 3,317 wires which stand testimony to this trial. Coming to the technique and the safety tips, well, putting sublaminar wire, though is simple, but there are very specific steps. You go through them and then, well, you will do a very good job of putting them. The steps are, first, you need to have a very good interlaminar exposure, followed by good wire contouring, the passage of the wire through the exposure, and securing and locking the wires, and then the final tightening the wires to the leuke rods or the heart shield. So as we come, the interlaminar exposure, in the thoracolumbar spine, the spinous processes, they actually overlap the underlying lamina. So you need to have a proper exposure of the interlaminar space. As you can see, you may have to remove a lot of spinous processes to go and see the yellow ligament. So this is where you need to go all the way up to here and then get that cleared to see the dura. You have to do this at all the levels and from one end to the other, so you can pass the wires very easily and safely. As you can see in this video, we are trying to remove the ligamentum flavum from in between the spinous lamina and the spinous processes. Here care has to be taken that you don't bite on the bone. Only the ligament has to be taken out and has to be taken out at all levels. As you can see, nice clearance of the interlaminar space is your first step and the most important step of putting the wires. So once the once the interlaminar spaces are done, then you come to putting the wires. So before putting the wires, you need to know what type of wires. These are the stainless steel wires. These we call wires which are 18 gauge wires, which are double looped and on one side and shouldered on the other side. And as we say, bend it like Bhojraj. These wires, it has been pre-made wires. Initially, we used to have a spindle of wires and tried to make these wires on table, which used to be very messy and very dangerous. So what we did, not we, but Dr. Bhojraj, that he made these pre-bent wires and he shaped it in a inverted question mark shaped wires, where there are two wires of 18 gauge which are bent in front and are shouldered on the other side. So these give a very smooth entry point for the wires, so they don't pierce the dura and they are very safe. And because of these bends, it gives you a very easy and simple, like a needle thread going through a needle. So it just you can pass the wires very safely and quickly. So here you can see from the prepared interlaminar space, you put the wire on one end and it just scrapes under the lamina and pops out from the other side. As you can see, you just pick it up with the needle holder and you pull it up. When you're doing this, you have to remember that you pull both sides of the wire. So you're not here. And this you see is the locking of the wire. So you pull the wire and lock the wires. So when you lock these wires, they have to be in this manner so that it doesn't go on hitting the spinous, what we say, the cord, when you are putting multiple wires. Now this is another wire we are putting under the lumbar spine, scraping under the lamina, and it pops out from the other side, on the superior side. Always go from below upwards. Pull it up. When you're pulling this wire, you pull both the wires up and then lock it. Lock it with your thumb over the lamina. So now you put multiple wires. After putting multiple wires over all the segments, you bend the heart shield. The heart shield has to be bent and contoured as per your requirement. Whether you want to put a kyphotic curve, you want to put a lordotic curve, depending upon where you are putting the heart shield. Once the heart shield is contoured, the wire are put and put under the heart shield, and the heart shield is locked to the spine. There are three types of tightening. The first tightening of the wire is on itself, so that you don't mix yourself, because there are so many multiple wires, you don't mix one on the other. The second tightening is the tightening what you are seeing here, where the entire wire is tightened till you touch the heart shield. And the final tightening is happening when you do it with your plier and the wire turns on itself. That's when your final tightening occurs. So once all the final tightening has happened, you need to cut the extra wires. You have to be careful while doing this because the wires can fly off. So you need to catch hold of the end of the wire which can fly off. And once everything is done, the heart shield sits very much snugly to the spine, and the spine contours to the shape of the heart shield. The interspinal space can be filled by gel foam, and then you can put as much graft as you want. So we have done 3,317 wires under this lamina in a total of 227 patients. Multiple cases of deformity, fractures, infection, and tumors. I'll be showing you a few cases one after another. But in all this, we had no cord-related problems. We had less than 1% of radiculopathy, or what we would say root problems. So neurological complications were minimal in all these patients. So it has been used in with H-rod, with sublaminar wire in scoliosis. It has been used with a heart shield sublaminar and sublaminar wire for correcting scoliosis. We have very good results, long-term results, and this is like very much cost effective. Even in kyphosis, this can be used to correct the kyphosis. With multiple, you have segmental corrections, as you can see, a very good correction of this kyphosis. Even clinically, they look absolutely straight. In fractures, well, you have fractures where there is a thoracolumbar spine fracture with complete paraplegia. You can use this as a very quick and quick surgery, and you can reduce the fracture in no time. This is a implant of choice in osteoporotic compression fractures, because the hold here is not the body but the lamina, which is a cortical bone. As you can see, we can do a lot of good hold on the spine with sublaminar wire and the heart shield, and along with this, do a good decompression job by doing a transpedicular decompression. It can be used in tumors also. This is an example of an aneurysmal bone cyst, which was excised, and it was fused using, it was stabilized using a sublaminar wire. It has this is a good long-term result of this patient. It can be used in infection like COX, where you can have a heart shield sublaminar wire to stabilize the spine. Thoracolumbar instability also can be treated by using the wires and the heart shield. They help tremendously. The cost, the ease, and the safety is really good. It can also be used. This is one thing which I would like to bring to everyone's attention as a salvage procedure for failed pedicle screw. Here you can see a T-lift done at a thoracolumbar region which has failed miserably with cage coming out because of the bone being osteoporotic. We removed the cage, we removed the implant and salvaged the patient with heart shield sublaminar wiring, and the patient is doing absolutely fine. So the carry home message here is sublaminar wiring is still a versatile, cost-effective time-tested, and a simple modality of spinal instrumentation. With basic safety tips, it is an extremely safe implant with no extra risk of neurological deficit. Simplicity, versatility, and cost effectiveness makes it an ideal implant for the third world countries, as shown in this presentation. Thank you.
Yeah, Premik.
Yeah, tell me, sir.
Yeah, that's a good talk.
Thank
Good
you.
description on usage of sublaminar wires. You've not yeah, I know you are the champion of sublaminar wires and other things. About the levels of fixation, like in pedicle screw, we talk about 2 level above, 2 level below. Is there a
Okay.
specific levels which we have to fix?
So it depends upon what type of pathology you are dealing with. If it is a fracture, we ideally say 3 level above and 3 level below. Or if it's a cox spine osteoporotic fracture, 3 to 4 levels above and 3 levels below. Nowadays, we are doing even 2 levels above and 2 levels below in a stable spine. And if it is a scoliosis, every segment we can put a wire. It ranges from putting it from T1 to L5.
Scoliosis, we are all aware. Yeah, we have to put at every level. That's a Luque description of sublaminar wiring and segmental. That's the first segmental scoliosis correction. Yes. And I know of the paper where you had described about how even rotation is corrected using sublaminar wires.
Yes.
Yeah. So as a technical issue, as you said, it's one of the safest techniques, provided people are aware that you should be at the lamina scratching it and not going deeper anteriorly. So that's when
the
people
interlaminar preparation is a very important part of putting what we say sublaminar wire. Once that is prepared well, you can put any amount and any type of wire below it. It's a very simple and putting 14 wires or 16 wires, what we say, it hardly takes any time. You don't require Siam, you don't require anything other than getting the levels. Otherwise, this is a very simple technique. I would say a person who does a microlumbar decompression, who does a good decompression doing a laminar, interlaminar plevomectomy. So these are the same technique used to actually pass the wire, because you need clearance as you do in a microlumbar decompression. So it's not a technique which newer people won't be able to catch up very soon. It just removes the phlebum without hurting the bone, and you are done.
In fact, like the way I've trained using hooks, wires, bands, everything. So the newer fellows do not train in any of these days. Straight away graduate into using pedicle screws. Yeah.
So these are
thanks,
things
Premik.
which
We'll go to the next talk on. Yeah, thanks, Premik. Thanks for a wonderful talk.
Thank you.
We'll go to the next talk by Pankaj. Pankaj Kandwal, your talk on pedicular decompression and biopsy options.
1-year-old male patient, tailor by occupation, came to us with severe back pain. A 51-year-old male patient, tailor by occupation, came to us with severe back pain. VAS was 9 on 10 and ODI was 91%. And here on X-rays and images, you can see it is a paradiscal lesion involving D12 and L1. Patient was debilitated, and thus and failed conservative treatment, and thus we opted for surgical management, and the patient agreed. A shot in posterior midline incision, as you can see, the routine exposure. Here we take care of preserving the posterior midline structures, especially the supraspinous and interspinous ligaments. Once you have taken care of that and good hemostasis, you go ahead and with a deeper dissection, you reach this part, and then it's followed by the routine pedicle screw insertion. This is going at L2. The starter all is going at L2. Here you can also observe that facet has been preserved while instrumenting. Now goes the pedicle finder or the linkage all, and the usual gear shift which is taken care of. You also ensure that all the walls are intact. This is followed by a polyaxial pedicle screw insertion at L2. The same thing is repeated, and if you can see on the other side, all the vertebrae have been instrumented right away from D, 11, 12, L1 and L2, and there's a distraction we are doing at the area of interest of the interbody area. This is followed by the facetectomy, inferior facetectomy, which is a routine part of doing a interbody fusion. The inferior facet of D12 is resected. I usually use the osteotome, and then you can remove the bone with the help of nibbler. This is the part of superior facet of L1 which is being nibbled, and part of the transverse process also. Now the inferior lamina of D12 is resected with help of Kerrison rongers. Gradually we go step by step, and then that is followed by removing the superior facet of L1 along with the pedicle. So part of pedicle is resected here. I am using a burr here. A lot of people use osteotome or can use Kerrison ronger. For the final few bites I am using a Kerrison ronger and removing the remnants of superior facet of L1 with part of L1 pedicle. Here you can also appreciate the flavum which is exposed after doing the facetectomy. You repeat this procedure till the entire facet and part of the pedicle is removed. Have to be patient at this stage. This was a dry lesion, but usually with wet lesions you can come across abscess. And now with the blunt instruments, fine instruments, you're trying to take away the flavum and part of the granulation tissue. You're dissecting a plane between the dura underlying and the flavum along with some part of the granulation tissue. At this moment you can take and bring in your microscope. People who are comfortable with microscope can use microscope. However, I've done here under naked eyes. Gently with blunt dissection you have to remove the flavum, and now you can see the cord and the nerve root. So the exiting nerve root is there in front of you, and underneath the cord you can see some epidural collection and part of maybe sequestrated disc. Now once you have ensured that your nerve root is in place, and you put a dura protector medially, and then you can go into the disc. While making an entry point I usually take after the knife cutting the annulus. Here the annulus wasn't there, but I've taken an osteotome, and then you go in. At this step I also tilt the table so that I get a better view and I can go all the way to the other side. So with osteotome I make a plane in the disc, and that is followed by shavers, end plate shavers. Sequential shavers are in, which are used for preparing the disc space, apart from ensuring that the loose sequestrated disc and other granulation tissue or necrotic tissue can be removed easily. And you take it gently with help of pituitary ronger, controlled. So basically you are in front of the dura now, and then comes the curettes. There are various curettes for end plate preparation. A good healthy bed is important for having a good fusion, interbody fusion. Now comes the trial cage insertion. So again, sequential sizer can be inserted, and the one which has a better or snug fit would be the size. You can check it at the C-arm with the C-arm, and the size looks good, and if you look at the AP view, it's almost crossing the midline. So with that, you have goes in the cage. So you take this appropriate size of cage. Here I've used a peak interbody cage, which is filled with a autograft, taking care of the dura as well as the nerve root. You gently hammer in the cage. At every step you have to be careful, ensuring that the dura is free. Plus you have to have this surgery under neuromonitoring, especially if you have an intact patient. So this is the final position of the cage after interbody fusion. That's a cage there, and if you can see in the entire process, we have not disturbed the midline structure. This is followed by the rod insertion. The rod goes in carefully. This is followed by compression at the in-wall level, which is D12 and L1. So compression, as we all know, would make sure that the cage is placed well and tight in the interbody area. Same thing is repeated on the other side. And as you can see, there is a good bed on the opposite side. The lamina is intact, which can be burred and can be used for interbody fusion. So for posterior fusion, posterior and posterolateral fusion. So you can see the autograft which was used on the opposite side. Final tightening, and that is followed by closure. And then you can see a short instrumentation involving the diseased vertebra and with interbody fusion. Thank you.
Thanks, Pankaj, for such a wonderful demonstration of transpedicular fixation. Pankaj, are you there?
Hey, Appaji, how are you? I'm good. I'm very much here.
Yeah. So you have shown actually sort of a posterolateral approach for the disc in thoracic spine or thoracolumbar spine. If you have to do a transpedicular approach, like for a biopsy, where all you will use a transpedicular approach?
You mean is a transpedicular biopsy? Then that is going to be different.
For transpedicular decompression.
Appaji, you're not audible. Have you lost your connection, Appaji?
Pankaj, can you hear me?
Yeah, now it's better.
Can you hear me now? Yeah.
Yes.
So, Pankaj, no, if you have to do not about transpedicular biopsy, I'm talking about transpedicular decompression, like in trauma and other situations.
Okay. So you want to ask me if the technique is using? Appaji, again, we have lost you.
Can you hear me now?
Yes.
Hello. Yeah.
Yes.
Hello. Can you hear me now?
Yes, Appaji,
Sorry.
go ahead.
You know, the question was if you have to do a transpedicular decompression, like in fractures. So will you use the same approach?
Well, again, for I think trauma is less forgiving when compared to tuberculosis. I would not restrict myself unless the patient has got only unilateral symptoms. I would go for a good laminectomy, but for going into the disc, I would definitely go for the same procedure.
Yeah. And for a corrective maneuver for like osteotomies, you'll do a better laminectomy posteriorly, right?
Yes. Yes.
Yeah. So, yeah. And if you have to do a transpedicular biopsy, so you'll use the same like the screw entry approach, or you'll have some other technique?
Again, I think in more or less it's going to be the same, but again, depending on where the lesion is, you may go cranial or caudal.
Okay, so Anyone else is a guru or somebody who want to ask questions? Do we have any questions?
It was a short presentation.
Yeah, we have 10 minutes.
I know. My
now.
presentation was for 10 minutes and that's how I kept it short and simple.
Yeah. So you want to add something on that? You want to talk on
No,
any other?
I think that's just fine. It's just that I wanted to show how we are doing short segment fixation along with transpedicular decompression. We achieved good decompression, and yet we save a lot of mobile segments. We preserve the lamina on the opposite side. So it's a kind of a hybrid kind of a technique which we are following right now.
Yeah. So thanks, Pankaj. We'll have a 5-minute recess. Sanjay, you're there?
Yes, sir.
Nobody is there.
Yes, sir.
Hello.
Hello.
Yeah. We'll have a 5-minute recess and we'll start at 3 o'clock with the next session, right?
Okay.
We'll have a coffee break for 5 minutes.
Okay, sir.
Thank you, Apaji. Thank you for having me. Thank you.
Yeah. Thanks.
Good day.
Hello. Hello. Hello.
Yes, sir.
Yeah, is the next group of speakers already logged in? I see only Janathan.
Not yet, sir.
Yeah, Nikhil, KD, VTI sir is going to give a direct lecture, right?
Yes, sir.
Sailesh, Tarush will log in later, but we should at least call Nikhil and KD to log in now. Sanjay, who's going to send it?
Yes, sir. I'm Sanjay.
Yeah, please call up Nikhil and KD to log in. We'll start in 2 minutes, right?
Okay, sir.
Yeah, we'll start in 2 minutes with Janathan. Janathan, I see Janathan in there already. Hi,
Yes,
Janathan. Hi.
Good afternoon to all. Dr. Appaji, can you hear me? Hello.
Yeah. Very well, Janathan. How are you?
Thank you. Are we starting now?
Okay, we'll start in a minute's time. We'll start in a minute.
Yeah, no problem. So only thing is I have a small problem with the video, so my video is not coming.
Okay, that's okay. So we'll ask you questions. So be prepared at the end.
Yeah, no problem.
Yeah. No. This is Palmyra stem. Yeah, good evening, everyone. We'll move on to the next session. So this will be on the interventions of spine. The first one will be transpedicular biopsy. Dr. Janathan will be talking to us on transpedicular biopsy. This is one of the commonest procedures which will be done on a daycare basis in spine, other than the pain procedures. So over to Janathan.
Yeah, thank you. I think I have a recorded presentation.
Good afternoon to all. First of all, I would like to thank the organizers of this Mini-IOACON for giving me this opportunity to demonstrate the surgical cells for percutaneous biopsy of vertebral body lesions. Biopsy is an important investigation tool. It is essential to establish tissue diagnosis, mainly to differentiate benign and malignant lesions, to differentiate between malignancy and infections, and even in infections to differentiate between pyogenes and tubercular infections, as well as to differentiate between rifampicin sensitive and resistant strains. So my objective of my today's session is to demonstrate the surgical techniques of percutaneous biopsy. Generally, biopsy can be a closed biopsy, which is done percutaneously, or an open biopsy. Percutaneous biopsy can be a fine needle aspiration cytology or wide bore needle biopsy. But fine needle aspiration cytology is easy, least traumatic, but then it gives a poor yield and it is difficult to penetrate the bone. Deeper tissues, it is very difficult to get adequate quantity of material, and aspiration of the pus is difficult. Whereas core needle biopsy is the preferred one for vertebral lesions. Large bore needles, trifine cut and two cut needles or the biopsy or some of the variants. Large bore needles provide good yield, aspiration of pus, is possible, but they can be more traumatic. Generally, I use 11 or 13 gauge needles, 4.5 inches long. And you can see here the pus also. When in infective conditions, we can aspirate the pus. We need some imaging backup. These are some of the methods. Ultrasound is fast, cheap, there's no risk of radiation, but then it is limited by the fact that we cannot use large bore needles. It is difficult to use. Bony lesions, it is difficult. Deeper tissues, visualization is poor, and we need interdepartmental coordination. Usually, the small lesion, soft tissue lesions in the superficial compartment, lesions can be biopsy using ultrasound. Fluoroscopy is the preferred method. We get a real-time picture, and it is dependent on surgeon, inexpensive. Most of the operation theaters are equipped with image intensifier, and we can use large needles. And since we are doing it in OT environment, resuscitation of the patient becomes easier if there is an untoward incident. However, there is a risk of radiation hazard, and sometimes the soft tissue lesions and smaller lesions, we may not be able to visualize clearly. And CT-guided biopsy is another important option or commonly practiced method. We can have a multiplanar visualization of the complex areas, even the smaller lesions and soft tissue lesions we can identify clearly, and we can have an accurate trajectory of the needle. However, there are certain disadvantages. Again, CT scan also has some radiation risks. In real time, in case of real time need for fluoroscopy is there, and if the patient is uncooperative in a radiology department to proceed with the sedation and other things may be a little bit tricky issue, and you need to have coordination with the radiology department. MRI gives better soft tissue contrast and multiplanar imaging, and there's no risk of radiation, but then it is limited by the fact that it can be costly investigation, as well as we need to have MR compatible equipments. Coming to the approach, we can do biopsy either through transpedicular approach or extrapedicular approach. Most of the spine surgeons are familiar with the transpedicular approach. Before any procedure, it is also essential to do a detailed patient evaluation. We need to look at the bleeding disorders, allergy history, local infections, and if the patient is taking some anticoagulant, they need to be stopped well in advance. These are some of the contraindications, like bleeding disorders, local infections, uncooperative patients, pregnant patients, systemic infection over skin puncture site. And then if the patient has a significant spinal cord compromise at the level to be studied, it is better to avoid. So once we have decided to do a biopsy, accurate planning is required. Study the images carefully, site of the pathology and presence of collection. So decide the approach and trajectory. Patient cooperation is important. And I would prefer to do these procedures under local anesthesia, because even if by mistake we pass the needle towards a nerve root, patient will be able to experience radicular symptoms and can pinpoint so that we can change the direction of the needle. However, additional sedation can be considered in uncooperative patients. Bleeding parameters should be evaluated. The sites, favorable sites for needle trajectory, usually if there is a pus or any collection or a displaced collection, they need to be biopsied. Similarly, soft necrotic bone or lytic areas, they need to be biopsied. Soft tissue mass gives better results, maybe from multiple sites. So the next important issue is image. Here now I would like to discuss the technique of transpedicular biopsy. It is important to have proper AP and lateral view. If you look at here, there are oval shadows. The end plates look oval. And if you draw lines on the lateral margin, you can see the pedicle shadow is outside the lateral margin. So it's not a true AP view. We need to ensure that the superior and inferior border of the vertebral body is straight line and the pedicle shadows are within the boundaries of the lateral wall. Similarly, in the lateral view also, here you can see that the pedicle shadows are not overlapping correctly, and it is essential to have a straight line. Superior end plate should look straight line and pedicle shadow should overlap. So this is an important concept when you use a SIAM. If you look at like this, the vertebral body, in the AP view, you see the pedicle shadow as a oval shadow. The lateral margin of this is the outer of the lateral border of the pedicle, and your entry point should be superior lateral corner of the oval shadow. And as we advance at an angle and somewhere in the middle of the pedicle, now you can see that it is somewhere in the middle of the oval shadow, or it should still be within the boundaries of the oval shadow in the AP production. And as we go in, once you breach the posterior cortex of the vertebral body, we can see that the oval shadow, it corresponds with the medial border of the vertebral shadow, and we must ensure that this screw tip remains within this boundary again, or within the middle one. And after that, maybe we can go at an angle and cross the oval shadow. So this is how it is: the station 1, station 2, station 3. So this is a clinical example where you can see that the entry point is at the superolateral corner of the pedicle shadow on the AP view, and it is at the station 1. As you enter station 2, middle of the pedicle, and then you can see that it is still within the oval shadow. And once it crosses the posterior border, now you can see the AP view is just touching the middle border of the oval shadow. So sometimes we can use extrapedicular approach. It gives a better trajectory to the lesion. Mainly the transpedicular approach is limited by the fact that our direction is limited by the boundaries of the pedicle shadow, while here it is not the case. And also there is less chance of injury to the spinal cord. So if the lesion is on the opposite side of the vertebral body or center of the vertebral body, we can easily approach it through this trajectory. However, there is a risk of visceral and vascular injury difficult in thoracic spine due to ribs. So this is a case where you can see that the entry is far lateral compared to the transpedicular approach, and the needle is coming at an angle so that we can reach almost to the midline. The complications are there can be bleeding, neurological injury, visceral injuries like pneumothorax, then allergic reactions and vasovagal reactions. And what about the success rate? With a large bore needle, we can get favorable results in 80 to 100%. Failure to get report means the patient may be on antibiotics or sample is not from the appropriate area. Errors in the transport and processing of the samples also can contribute to the failure of results report, and failure to get appropriate culture tests. Sometimes we may have to do a fungal culture. So I will demonstrate the techniques using a video here. So this is a case of multiple metastasis, the pathological L3 and L5 vertebral bodies. So L3, there is a pathological fracture of L3 and signal intensity changes in L5. So we have decided to do a percutaneous biopsy. Patient is on monitor. Local anesthesia is infiltrated using the spinal needle. Again, the position is confirmed with the image intensifier. And you can see that we are targeting the superolateral corner of the oval shadow on the AP view, and it should just touch the entry point in the lateral view. Local anesthesia is infiltrated. And it's 2% lignocaine. So then an incision is made, and then the needle, Jamshidi needle is introduced. So we can see that this is a station 1 confirmed with the image. It's slightly on the superior aspect, so it is redirected. Now you can see it is correct. And now we have to confirm the same with the AP view also. Yeah, so it's in the superolateral corner of the oval shadow. So that means it is station 1. Now it is with the gyrating movement, we advance into the vertebral body in the direction of the pedicle. And you can see that this is now station 2, which is still within the oval shadow. Still in the oval shadow. And you can see the station 2. This is almost touching the postal border of the vertebral body. So now we advance again a little bit. Now we are in the station 3, and I remove the stillet at this stage. Confirm with the image, it has crossed the vertebral body. We need to confirm the AP view also to ensure that it is still within the pedicle shadow. So now we have advanced it. Yes. I am checking for the movements of the leg on the toes so that there is no neurological injury. And now with the gyrating movement, slowly advance into the vertebral body. Remember that the stillet should be removed at this stage, so that a part of bone is trapped within the substance of the within the needle. So now we have breached the oval shadow here, but it is already in the vertebral body. So with the rotating movement, we advance slowly At this stage, you can do a little bit of twisting movement so that the bone is caught there and remove it. And then remove the, you can aspirate also to see if there is any pus. So the needle is removed now, and you can see a large chunk of bone is caught in the junction. So now because we need to do for multiple sites, and for the demonstration purposes, I'm doing the extrapedicular approach. Again, you can see the needle is directed to the junction of pedicle and vertebral body just above the transverse process. On the entry point is a little bit more lateral compared to the transpedicular approach. So the needle is introduced at an angle now to hit the junction between the pedicle and the body. So now you can see it here that I'm trying to know this is a little bit superior, so I will try to angle it a little bit more. I can see with the little bit angulation now I can target the lower part of the vertebral body. So this is the advantage of transpedicular approach, where with a little bit angulation we can either target the superior part of the vertebral body or even the disc space. So now it is at the junction. Now we introduce and confirm that it is in the vertebral body, and then we try. So it is still, so it's entered the vertebral body, but on the AP view it was still within the oval shadow. So that is the most important thing. So now we advance after removing the stellate. Then with the retrobit rotating movement, we try to capture a piece of bone. Then we pull out, and we can see that a large chunk of bone is again caught. So that's about that is how we do a transpedicular, extrapedicular approach. I think with this I would like to end my talk. Thank you.
Yeah, thanks, Jonathan.
Any questions?
Nice demonstration of transpedicular biopsies. I think you've touched upon all the points, transpedicular, extrapedicular, and all the three fluoroscopy guided. And what is the yield rate, Jonathan? If you are doing a biopsy and sending for a culture, what is the yield rate in fluoroscopy guided versus CT guided biopsy?
Okay, so I think I can answer about the fluoroscopic guided biopsy authoritatively because I have done it myself. In tubercular infections, combined AFB smear, gene expert, and histopathological evidence, if I take into account, I think it is near 100%. I mean, including the histopathological evidence. Some cases I will not get AFB, but histopathological evidence will be there. Whereas in bacterial infections, my yield is, I mean, I could grow organisms only in about 30 to 32%, 35%. Rest of the things, it is we will get biopsy report of inflammatory pathology or something like that, no, but we will not grow the organisms. In metastatic lesions, many times we were able to identify that it is metastasis almost 100%, but very rarely, I think once or twice, they were unable to tell the type of malignancy. On the contrary, for the CT guided biopsy, in our hospital, some of the patients undergo CT guided biopsy. It happens when a patient is admitted in some other unit, or even my cases when I have the tight schedule, so we refer it to CT guided biopsy, and sometimes junctional areas. They find it difficult to use a large bore needle, and many times the biopsy is reported as insufficient material. Whereas at least when I do it with these large bore bottles, I think none of the times that the pathologist at least can they can make a some diagnosis, which is not the case with CT guided biopsy.
Point well taken, Jonathan. But if you have a good radiologist who can do it, will you prefer to do it yourself, or will you prefer a CT guided? How much is the dose difference
fluoroscopy to CT scan? Do you have any idea which is better for the patient radiologically?
From the radiation point of view, I think CT guided biopsy is slightly better. That's what they say, unless you use a fluoro even in CT. And there are a couple of advantages with CT guided biopsy. Number one, probably junctional areas. I will not do a fluoroscopic guided biopsy. It's a little bit tricky. Then third thing is, if the lesion is very small or very small lesions, then probably I think I may not be able to clearly target by a fluoroscopic guided biopsy. CT is a better option. So there is definitely a role for CT guided biopsy.
Yeah. So yeah, that's what. But most often, what you hear from the radiologist is that it is so close to the aorta, it's so close to the this thing, because CT gives you so many details rather than in
exactly soft tissue.
Fluoroscopy, you tend to
soft tissue
much more aggressive while doing fluoroscopic.
Your voice is breaking.
No, what I wanted to say is, Janardhan, let me make my point. What I wanted to say is you are much more aggressive doing a fluoroscopic biopsy, because you're not seeing those big structures as you will see in a CT scan. Most of they are more defensive in doing a biopsy than what you and I will do in the with fluoroscopy in the theater.
Appaji.
Yes, sir.
This confidence or diffidence comes out of three-dimensional acquaintance with the spine.
Yes, sir.
See, you will always do biopsy. Even when you do CT scan biopsy, probably you will do it more confidently than a radiologist will do. I am not trying to demean the radiologist. What I'm saying is it's a sheer three-dimensional understanding. How much is that aorta really away from me? At what angle? That I would know only by three-dimensional, my absorbing those facts over years.
Yes, sir. Point well taken, sir. That's
no,
the
one
truth.
More thing I also want to. I want to add here. Like, we are also now used to doing percutaneous pedicle screws. So I think even if we can do that, I am sure we can do this, especially vertebral body lesions. Maybe if the lesion has got a soft tissue component which is extending beyond the boundaries of vertebral body, then yes, it may be tricky.
Yeah, that's true, sir. With the knowledge as a surgeon, you are much better even to help an anesthetist put a spinal during difficult spinal anesthesia than they can do it, because we have the first-hand experience of seeing the spine live. Yeah, thanks, Janardhan, for a nice lecture on transpedicular or biopsies. The next talk will be by Nikhil Arbati. Nikhil Arbati will talk on vertebroplasty or kyphoplasty, whichever is better. Nikhil, over to you.
Yeah, so I hope the screen is visible. Hello, everybody. I'm Dr. Nikhil Arbati from Mumbai, and I'm thankful to the ASSICON committee for giving me an opportunity to speak today. Today's topic is about percutaneous vertebroplasty. So what does percutaneous vertebroplasty mean? It's basically the injection of a PMMA cement into an osteoporotic fractured vertebra, which is not showing any signs of healing, even after a period of conservative trial, leading to pain and affection in active daily life. So what are the benefits of doing vertebroplasty? Apart from the fact that it gives an adequate pain relief, it helps in early mobilization of patients who have this osteoporotic fracture. Majority of these patients are geriatric patients, so these require early mobilization. Thus, it prevents the comorbidities worsening directly. Also, it prevents, if it's a junction level fracture, it prevents the collapse from worsening. As in this case, if the patient had been treated adequately before, the collapse would have been prevented from worsening. There are certain indications of doing a vertebroplasty. First of all, our osteoporotic fracture, which has got a conservative trial of 3 to 4 weeks and is not showing any signs of having a pain relief. Patients who have comorbidities and are totally non-ambulatory because of the pain, they need to consider vertebroplasty. If an MRI picture shows a Camel sign, that is a non-avascular necrosis or non-union, that is another condition where vertebroplasty needs to be considered. Also, if it's a pathological fracture because of a tumor where a palliative surgery such as injecting cement is to be considered, as in multiple myeloma, then there are other indications. Definitely, vertebroplasty comes with its complications. There are some immediate complications, like an extravasation of cement into the epidural space, which can lead to neurological complications, an extravasation of cement anteriorly into the paraspinal veins, which can lead to other serious complications. There is also the chances of extravasation of cement into the superior inferior disc space. This, apart from the fact that there are sudden hypertension which can happen while injecting the cement because of an embolus which can be thrown up. There are some delayed complications, that is an adjacent level fracture which can happen. Also, the vertebroplasty injected bone, if there is a fall in the future and if that bone gets affected, the cement does not get integrated into the bone. So the chances are that the cement block can sometimes hit the pulse. You should definitely not consider a vertebroplasty when there is a severe osteoporotic fracture which can lead to stenosis and there are neurological symptoms because of it. If there is a burst type of fracture pattern where the cement can get pushed out or can get extravasate very easily, you should not consider a vertebroplasty. More than 60-70% collapse where it will be very difficult to negotiate needle into it and put cement, definitely you should not consider doing a vertebroplasty. Apart from the routine things that you should not do a vertebroplasty in a traumatic fractures. There are some cases where it depends upon whether the vertebroplasty needs to be done or not, depending upon the surgeon's preference. If the fracture is less than 3 weeks, but if the patient is severely non-ambulatory because of the pain, is not able to walk, and is having comorbidities, then you can consider doing a vertebroplasty in such cases. If the collapse is more than 50% and in X-ray and MRI it appears difficult to negotiate a needle, but if the surgeon has an adequate, experience of negotiating it, then it can be considered. More than 2-level fractures, depending upon what is the extent of collapse. If the collapse is not severe and you feel that you can inject 3 to 4 cc of cement into every vertebral level, you can consider it. 3 levels is maximum that I've done at one time. A junctional level where there is a compression and there is minor cord compression without any severe stenosis and no deficits, you can consider doing a vertebroplasty. At the higher level, about D6 or D7, if you feel that the pedicles are adequate and where there is no severe compression of vertical compression of the osteoporotic fracture and you will be able to inject an adequate amount of cement into it, you can consider doing it. So these are the cases which depends upon the surgeon's preference and his experience. So how does this vertebroplasty help? So actually there is no confirmed theory in how it works, but one of the theory postulated is that the heat generated by injecting the cement causes neuroablation of the nerves leading to pain reduction. What would be the ideal case to start if you're doing a vertebroplasty? The fracture, if it's between D11 to L3, the vertical compression fracture should not be more than 40 to 50%. You should have an intact pedicle so that you can easily cross the needle lits and with an intact morphology of the vertebra. Definitely not any burst fracture, so that there should not be an extravasation of the cement. And if possible, at least 2 to 3 weeks of period of conservative trial post this fracture should have been done. Some investigations which are necessary before going through the vertebroplasty procedure is, apart from the supine X-ray, see if you can get a standing X-ray. This is necessary so that you can determine the amount of collapse. After doing a standing X-ray, you can also, if possible, get a prone X-ray, because if in the standing X-ray you find that the collapse is significant and you're not sure whether you'll be able to pass the needle or not, then in the prone X-ray, if it's possible, you will be able to see whether the fracture is opening up. An MRI scan is mandatory because this will show the fracture pattern and the morphology, also to say whether the edema is present or not, because if it's an old fracture, definitely it will not accept any cement in it. And if you're not sure whether the fracture is a burst or not, get a CT scan done. Apart from that, the other investigations are, if it's a multiple level fracture seen at the same time, get a serum electrophoresis done to rule out multiple myeloma. You can do a bone densitometry to see what is the bone density, DEXA scan to see what is the bone density, and post-treatment, post-vertebroplasty, any medical management is required. Also, if the routine investigation, serum creatinine and all, which is required, because procedures are usually done under local and sedation. You require a proper sterile OT and a C-arm where you can easily see an AP laterally properly. If you have 2 C-arms, then it is also reduces your operating time significantly. Make sure that the temperature of the OT is properly controlled. It should be between 18 to 20 degrees. These procedures are done under local and sedation. You should have a proper, good anesthetist who can give a proper sedation without making the patient too sleepy. You may require a deep sedation only when you're injecting the cement, because that is when the patient may experience some amount of elevated pain. If you're doing more than 2 levels at a single sitting, you can use 2% xylocaine mixed with adrenaline, or 2% xylocaine is enough if you're doing at a single level. If you want to use a dye after putting the cement in, after putting the needle into place before injecting the cement, you can use an Omnipack or a Eurocapsule dye. So the technique basically involves advancing a J needle or a Cook's needle through the pedicle, through the 3 o'clock or 9 o'clock position, depending upon the pedicle. And under CM guidance, you advance the needle up to the anterior 1/3 part of the body. Once the needle is confirmed in that position, in APN lateral view, you can use a dye to inject into that space first through the needle to make sure that there is no extravasation. Once everything is confirmed, you can just pass the cement into that needle. About 3 to 5 cc cement can be easily passed. So, an illustration of it, this is where we start at the 9 o'clock position. You usually inject a little bit of local around the lateral part of the pedicle, and this is where we make a stab incision in the skin adjoining to that lateral part of the pedicle. You can advance the Jamshedi needle up to the lateral part of the pedicle in the AP and the lateral view so that you get a good hold. Further advancement of the Jamshedi needle in the AP and lateral view should be done under proper CM guidance. Make sure that the Jamshedi needle travels through the pedicle as it travels through a small cylinder. So always make sure that the Jamshedi needle is positioned into the AP and lateral views. In the final position, before advancing further, it should be in the medial part of the pedicle and should have crossed the posterior vertebral line in the lateral view. As in this, yeah. The final placement is it should be in the anterior 1/3 part of the vertebra, and once it's confirmed there, you can just inject it and check the spread. To illustrate, you should have the CM and a technician who can show a proper AP view where the pedicles are both seen properly. You can always orient the CM in such a way that the pedicles are seen properly and you see a dead AP and a dead lateral view. Then in the AP view, inject the local around the lateral part of the pedicle, 2% xylocaine. If you're doing more than 2 levels, you can use 2% xylocaine mixed with adrenaline. After injecting the local, give it sufficient amount of time for that local to act. So maybe after a minute or a minute and a half, you can just with a stab knife, an 11 gauge or a 15 gauge, make a stab incision on the lateral part of the pedicle adjoining the skin. Then with the Jamshedi needle in the AP, you can start advancing it up to the lateral part of the pedicle in the 9 o'clock position. Checking the AP. Usually sometimes this osteoporotic vertebra have a very weak bone and the needle can suddenly give way. So in the lateral part of the pedicle in the 9 o'clock position, make sure that the needle gets a proper good hold. Once you're satisfied with the hold, then you can ask the CM technician to rotate the CM and make it lateral view to make sure that the needle is advancing properly in the lateral view. It's not too superior or inferior. So once it's confirmed in lateral view that the position is proper, you can advance the needle further. So you can keep on doing twisting movements and rotating movements to advance the needle in osteoporotic this thing. Need not always hammer it unless there is some amount of sclerosis present. If it's a little bit old fracture and you need to push the needle a little bit with force. Otherwise, majority of the times with a twisting movement, you can advance the needle further. So always keep on checking the AP and lateral views to make sure this, once it is positioned properly where the needle is placed, yeah, in the lateral view in the anterior 1/3 part of the vertebral body. You can just do a final arrangement so that the needle is placed there, and once it's confirmed that it is there, you can just check it. That does not give it this thing. I usually do it with this thing. So this is where the final placement of the needle should be, in the anterior 1/3 part of the body. And I usually don't inject any dye into it, but if you want, you can inject a dye to make sure there is no extraversion of cement going to be. Then you can start mixing the cement and inject the cement in a semi-solid state. Usually 3 to 5 cc of PMM cement can be injected at one level through one pedicle. Do it under continuous fluoro and don't all push the cement in so that it does not extravase it out. This is how the final picture appears after doing a single level vertebroplasty. Once the procedure is done, remove the jumpsury needle, allow at least total setting time of the cement should be around 15 minutes, so give that much amount of time till the patient remains prone. Once that time has elapsed, the cement has hardened exteriorly, then you can just put a small dressing, a cell strip over it, and then make the patient supine again. Thank you.
Thanks, Nikhil. I don't see Nikhil around. Is he logged in? Sailesh?
Yes.
You had a comment to give.
No, I think he has explained it very, very well. Most of the points he has very nicely covered. One thing I just want to tell to all the colleagues and orthopedic surgeons is that we have to be careful for this procedure, which looks very simple, but sometimes there can be devastating complications also. We have seen pulmonary embolism, we have seen the cement leaking into the canal, cement leaking into the basivertebral vein. I mean, it is going through the basivertebral vein into various parts of different organs. So we have to be very careful when we are doing the vertebroplasty procedure. But I think Nikhil has done a great job. What do you think, Appaji?
Yeah. He's shown. He started with showing the complications. So
yes,
people should not think that it is a straightforward procedure. Even I've been called by my orthopedic friends in the middle of the night. Hey, I started doing one vertebroplasty and the patient is not moving legs. What is the reason? I said, bloody do a CT scan. You'll see all cement in the canal. So you have to be very, very careful. I see Kalidatta there. So he's going to speak on kyphoplasty. What is your take, Dr. KD?
Appaji, before we finish, can I add something to this?
Yes, sir. Yes, sir. Please.
Yeah. Basically, if the fracture is more than 3 weeks old or so, one has to really find out whether it's opening or not opening. The second thing is it truly non-union? Because if the bone has not shown any potential for osteoblastic activity, even after putting in a cement, sometimes it doesn't. So what we do is, like he has said, to an AP view, a lateral view sitting position, but the sitting has to be a slumped. Patient has to really slump down without resting the arms on the table. Only then he can slump truly. Then we make the patient lie down supine, put a large Gamgee pad behind the gibbus, strap it there and make them lie down supine. So spine truly opens up rather than putting them prone, truly opens up and you know how much it is opening or not opening. And if it's significantly opening, sometimes cement may not be a good idea. You may have to do something more than that.
Yeah, true, sir. There are instances where there is not like an osteoporotic collapse fracture, but like a transverse section into the lateral body or towards the posterior.
Yeah. These are osteoporotic bones, but they go for non-union more frequently than imagine.
अभी जो इन्फेक्शन का जो भी आएगा पहले
Guru, can you mute yourself? Guru.
कोविड रिपोर्ट का वेट कर रहे थे कोविड रिपोर्ट आ गया अभी
Sorry. Yes, sir. Sir, please go ahead.
Appaji, you said something to me?
To mute yourself. You are interfering in the discussion.
Sorry.
Yes, sir. Please go ahead, sir.
Yeah, so the non-union is not as uncommon as we thought. It's far more common than that. And therefore, till you do something more, something towards osteosynthesis, rather than only mechanical scaffolding, patient may not get. I've seen enough number of patients whose the cement blob has moved out of its place anteriorly, migrated wherever you like. So one has to be cautious everywhere, at every stage of the procedure, every stage in planning, every stage post-op. But one thing is for sure, the pain relief after vertebroplasty is a super pain relief. Patient always blesses you till he finds something new is happening.
Yes, sir. That is the truth. Point well taken, sir. So we'll move on to the next talk. I think KD is there. Yes, sir. Yeah. Kalidata Das. KD, sir.
Yes, sir. Appaji,
Yeah.
Vanakkam, I am there.
Yeah, so we'll move to the next talk. This is on the the advanced version of vertebroplasty, which the kypho fellows call it. Let's see how Dr. KD manages kyphoplasty.
A very good afternoon. I thank the organizers for giving me this opportunity. Gautam and Rupinder have been instrumental in me being with you this afternoon. Welcome to this session of kyphoplasty. Initially, it's a few minutes of a small presentation to get acquainted with the procedure, following which there is a video which is self-explanatory with a voiceover. I am Dr. Kalidata Das from the Indian Spinal Injury Center, New Delhi. I will be speaking to you on kyphoplasty, which is a minimal invasive spinal procedure to treat progressive vertebral compression fracture. We'll use the term VCF or OCF. It involves injecting of high viscosity bone cement in a freshly created vertebral body cavity under low pressure. Now, when there is an increasing amount of geriatric people, they will but often have a fall, which leads to an osteoporotic fracture. It is the change in biomechanics and the fear of falling which creates this fracture, because of which there is increasing progression of kyphosis, leading to a change in the quality of activities of daily living and leading to depression in these patients. The indications of kyphoplasty varies from stabilization of a progressive osteoporotic fracture to metastasis or multiple myeloma in Kummel's disease and painful hemangiomas. We need to also understand the contraindications where it should not be done. In case we are not sure of the pain indicator, which is the primary source of pain, if there is osteomyelitis or systemic infection, if the posterior wall of the canal is breached, or there are retropus fragments in the canal, or if there is an epidural extension of tumor, these are not the ideal cases where a kyphoplasty or injection of cement is considered. Following a change or following 6 weeks of failed conservative treatment, a unipedicular or a bipedicular process of kyphoplasty or cementing can be thought of. There are other less known and less used options are there in an osteoporotic spine. They are posterior stabilization with surface coated screws, with segment augmented screws, expandable screws, and screws with sublaminar hooks and lamina. We shall get familiar with the instruments that are used. We have a working cannula, we have a BFT, we have a drill, and these are the guide wires for understanding the positioning. On the other hand, we have a syringe on which there is the cement which is loaded, and there are max to tell you how much of cement has been injected. We have a pressure gauge, a long tube, and a connector to which the balloon is connected. Now, this is a type of kyphoplasty and a picturization of how to start, what the inflated balloon looks like, and a schematic diagram of the kyphoplasty and balloon in situ. To see the balloon, an oil dye is used so that it is radio-opaque. The anesthesia that is preferred in these patients is a local sedation, local anesthesia. The complications of general anesthesia is avoided if we do not use general anesthesia. These patients are coupled with comorbidities. For in these patients, it is best not to use general anesthesia. To start the preparation or the process of kyphoplasty, the patient is supposed to be able to sleep on his stomach or in a prone position for around 20-25 minutes, which is approximately the duration of the procedure that takes place. Once the patient is positioned, some amount of local anesthesia and sedation is given, and the C-arm is put in place. The patient is positioned on bolters. The position itself reduces the fracture, which is the ultimate goal of filling the cleft or the cavity that has been created by the balloon. Once the position of the patient is prone, we need to take a AP in which the pedicle is visualized to us in form of two circles wherein we obliterate or compensate if there is any rotation in the vertebral body. The lateral image is taken such that the upper end plate and the lower end plate are in one synchronous line, and this is a true lateral where the whole length of the pedicle is visible. The points to remember in AP lateral is 1, which corresponds to the lateral border of the pedicle, in the AP view, which corresponds to the beginning of the pedicle in the lateral view. The second point corresponds to the middle of the pedicle, both in the AP and lateral view. The medial border of the pedicle in the AP view corresponds with the medial entry of the joining of the posterior border of the body and the pedicle. This is the most tricky part. If these points do not correspond, most probably you are not in the right trajectory. The guide wires supplied to us are marked on the skin in form of 1 centimeter lateral to the pedicle and bisecting the pedicle in the horizontal view. The Jamshedi is used as a starter to check at every point. The center point of the pedicle is the point number 2, which corresponds to the center and the beginning of the posterior body. This is a right position. Once we have the working cannula in place, we put the drill. This acts in 2 processes, makes a smooth passage for the balloon to go in, and also the bone that is there can be removed for biopsy or for histopathology. This is how the balloon looks like. These 2 markers correspond to the position of the balloon. It should be placed in the middle of the body of the vertebrae or below the fracture so as to lift the fracture to an extent, creating a trabecular mesh. In the AP, once the radio-opaque filled balloons are inflated, they look like goggles meeting each other so as to understand the passage of cement from each vacuum area, creating a bridge. This is how it laterally looks. It should be 3 to 5 millimeters from the subchondral bone above and below, thus not breaching the end plates. Once it is full, we have a spectacle-like image with the bone filling the center of the fracture. The consistency of the cement when injected is like a toothpaste. When small amount of pressure is put into the plunger, the cement rises up rather than falling down. What are the end points of the inflation of the balloon? The reduction of fracture, which is visualized in the lateral, is visualized. The maximum balloon pressure, which goes up to 300 plus in the vertebral body, should not be crossed. The cortical walls should be in contact, and the cement volume should be approximately 2 to 5 ml as per requirement, and it should be in the vertebral cavity. The ideal amount of cement has not been substantiated, and it is anywhere between 2 to 10 ml, and the patient is not moved until the cement is cured or hard. Things to keep in mind: the streak of cement, if not set, and the plunger or the BFT or the cement tube is removed, can leave a tail which is called a rack tail. There are some special techniques that experienced people use. It is an eggshell ballooning cementoplasty, in which liquid cement is initially inserted, after which the balloon is inflated, creating a space. Once this space hardens or forms an artificial wall of cement, the second set of cement is now infiltrated. The right-hand side picture B shows us a process of kyphoplasty with ballooning technique, wherein cement has spread around and now the solid cement is to be put. The mechanism of pain relief is not well understood, but there is substantial amount of relief of pain after the cementing procedure. The complications: there could be spinal cord or nerve root injury, pulmonary embolism, transverse process or the pedicle fracture. There could be hematoma, epidural abscess, and sedation-related complications. We will go through this small presentation, which is self-explanatory. The patient has been positioned. The guide wires have been checked. Now the cannula or the working cannula has been put. The surgeon is now drilling the drill, which is checked on AP and lateral. Both the films are now substantiated and correlated with the C-arm, which is positioned in lateral. Care needs to be taken that the anterior cortex is not breached. We see here the passing of a biopsy instrument, and this also has a nozzle which on clicking changes from 30 to 90 degrees to create a space. This is the balloon which is passed through the working cannula. The beads of the balloon were visualized on the lateral view of the body of the vertebrae, wherein you can see both the balloons identically corresponded. Now, under strict observation of the pressure gauge that we have, the balloons are inflated and repeatedly checked. The pressure that we see here is 85. If it is a osteoporotic bone, there will be sudden increase in pressure, but once you keep the balloon in place, the pressure starts falling because the osteoporotic trabeculae gives way. The cement that has been prepared takes approximately 6 to 8 minutes, depending upon the handling and the room temperature of the operating theater. Care is taken while the cement is put in. The anesthetist is given an instruction to start an F-choline or a steroid when the cement goes in, along with which repeated lateral views are taken to see that the cement does not extravagate onto the disc spaces or posteriorly to the canal. Once satisfactory amount of cement has been injected, we wait and use an empty BFT plunger to tap on the cement to see if it is hard. Once the cement is set, both the needles are removed, and that is the end of the procedure. Patient is generally kept on the table for a little time, sent back to the room, and can be immediately mobilized after 1 and 1.5 hours. It was lovely presenting to you this afternoon. I thank people involved in making this presentation, and a special note of thanks goes to my team members and Rupinder Chahal, from whom this video that I presented was borrowed. Thank you so much. Have a good day.
I can't hear
Hello,
anybody.
Dr. Das.
Yes, sir.
No, I just want to know from you the advantages of kyphoplasty over vertebroplasty, and why should I consider kyphoplasty in patient who can get better with vertebroplasty? Any advantages from your experience?
There is, technically speaking, this is a much safer and a simpler procedure than vertebroplasty, because the vertebroplasty cement is in much liquid form and depends upon the expertise of the patient.
Okay.
Whereas the outcome of the patient, there is no difference at all. In fact, the economy or the pricing of the kyphoplasty is a big disadvantage compared to what can be achieved as an end result by vertebroplasty.
But nowadays, some Indian companies also are in market for kyphoplasty, which are reducing the cost, I believe.
Yes, but unfortunately, Silesh, we have had experience of the balloon not deflating in some of the Indian companies, and it is a real big mess.
Okay.
Because it has happened. I will not name certain conditions where it has happened. For this small procedure of a kyphoplasty, when the balloon did not deflate, they had to do an anterior approach and a vertebrectomy to remove the balloon from the front.
Okay, okay, okay.
So if there is no issues, you can choose whatever you're comfortable with.
But the quality,
I've been comfortable with kyphoplasty, and I choose if the patient needs a kyphoplasty or a vertebroplasty. It also depends upon how we look at the case individually. But the same results are achieved by both of them.
Reduction in cost should not reduce the quality.
Very true.
Yeah. Okay. Can we move on? I think. Appaji?
Appaji सो गए क्या? Afternoon.
नहीं sir.
Sir, our 2 minutes, you can ask some questions, sir, if you have.
No. It was a very beautiful, it was an excellent presentation by Dr. Das, and he's covered most of the points. A lot of learning for all of us. I must compliment Dr. Das for doing it.
Thank you. Thank you, Silesh. Thank you, Dr. Ingalkar.
So we move ahead.
Yes.
Yeah, we go ahead, and I would like to invite Dr. V.T. Ingalkar sir for his presentation. So sir will be doing live, I think.
Can I?
Yes, sir. Yes, sir.
Oh.
We can see your screen.
Yeah. Thank you very much for inviting me to speak here. I'm extremely happy that in this basic course, the injection techniques are being discussed. I think that itself is a big thing as far as I look at it. Okay. We always tell the people that go and take an injection, but very often in our own mind, there is no clarity about what is going to be done. We say, okay, chalo isko injection dete hai. But beyond that, probably often we don't have clarity in our mind about what is to be done, why it needs to be done, etc. So let me begin with this. Okay. Number one, injection is used for two purposes. One is diagnostic tool, and one is therapeutic tool. As far as orthopods are concerned, we always only look at the therapeutic part of it. Even I'm sure all those who are logged in now for this are looking at some therapeutic tips rather than diagnostic tips. But please remember that diagnostic use of injections is as much important as that, because any speculated pain source on the X-ray, MRI, clinically, etc., is still a probable source. And I and many would not consider that as a confirmed source until the patient gets a pain relief after blocking it. I go and block it with local anesthetic and the patient's pain goes away, then it is confirmed that this is the source of pain production. Now, this is something very important, and if we don't pay attention to that, we are not going to really help. But given a small given time, I can't cover everything. So I'm going to talk about the therapeutic part of it. Another important thing is most of these patients have pain, either local pain, facet pain, root pain, They have some difficulty in doing certain actions, the flexion, extension, rotations, combination of movements, etc. And that their pain is reproduced. We always insist on doing just pre-injection. Just before patient is taken on the table, we make them go through all kinds of contraction, local movements, contortions, and find out which are the positions in which they get pain. We note them down, we inject them, and post-injection, within first half an hour or so, we repeat that clinical examination, even before the patient is taken out. If we are going to do multiple facet blocks for diagnostic purposes, we after every block we will wait for a few minutes and do examination and again continue with further block. So that is something which is very important. Well, all of you are aware of the setups. Surgeon must be good in his work, must be understanding exactly what he needs to do. A good C-arm, a good camera in that, a good monitor, and the C of the arm must be so large that you have enough place between the C arm and the patient's body. This distance must be sufficient for you to do all kinds of work. That's important. Now, another important thing is many people advise that if you want to give facet block, put the patient in 45 degrees oblique. No, we always put the patient prone and in a very, very stable position. Most patients move when they are unstably positioned. We always position them stable, prone, and then we manipulate the C arm to do what we want. We do movement, tilt, rotation, whatever you want to do, whatever angle you want to have, you move the C arm and don't move the patient, don't change the patient's position. Okay, now in this way, patient's compliance is excellent. The pain patient will not give you trouble, will not move, and complication rates will be definitely lesser. Three-dimensional understanding of anatomy is an absolute must. If you don't have that clarity in your mind, probably you're not going to do as well as you. So how does a particular area look in AP? In oblique, in lateral, in flexion, in extension, in 20-degree rotation, in 10-degree flexion, in 10-degree cephalad tilt, 10-degree caudal keep. All these things you must be able to understand as to what exactly is happening there. And then you should be able to speculate in your own mind, where are the soft tissues in this particular thing. So I should be able to speculate, where is the root exiting, how is the root going out, where is it extraforaminal, where is it intraforaminal, where is it proximally. I should be able to three-dimensionally project it in my mind, and then I'll be able to inject it far more successfully, far more safely. So that's another important point. You must have a good C-arm images, of course. For the root injections, we need to have you to understand one thing, that this is an oblique view of the thing. There's an end-on pedicle here. This is end-on of the pedicle here. And the root skirts just underneath that. The distance between the pedicle's under surface and the medial surface and the root is very small. The distance between this is much, much smaller. So you also have to remember, when you position the patient, this particular distance between the tip of superior process here and the inferior margin of the pedicle, this distance must be maximum for you to see on the X-ray. So position your C-arm accordingly. Now these are the 2 points I have marked. These are the points where I would go and touch if required. This is another point I would go and touch. This is how the root will go. I can go here, touch the bone. In our method, we first go and touch the bone. Why? Because we don't touch soft tissues. Once you touch the bone, you know which part of the bone you have touched, you know how to manipulate your needle further, get into foramen, go parallel to the root, what you like. Now this area is much smaller area, but this area is larger area. This particular area is much larger area. And when we do inject, what we do is we use long-handled instruments. We use a long sponge holder to localize this. We use a very long needle holder to hold, so that our hands are off the beam of the X-ray beam. We generally shoot a pilot image using auto exposure. Then we reduce the exposure. reduce the exposure of 1 notch, 2 notch required, and then make the adjustments in the brightness and contrast of the monitor so that your exposure per se is much smaller. We use pulse and intermittent, and if possible, we try to avoid a daily radiation exposure. If it is properly done, the annual exposure for a injection person may not be too bad. Somebody who is using it horrendously every day, day in and out, but has to take breaks in between. Okay. We usually use some radiographic contrast, urographin, pentopic, whatever it is, to confirm the location of our needle and to prevent intravascular injection. Why do we want to confirm it? We want to know that the other chemicals that we're going to introduce, say steroid or bupivacaine or tramadol, anything else that we are going to introduce, we are introducing it in the correct location. Otherwise, it will not work and I might get a false negative result, even when I have absolutely accurately been injecting it nearby. So therefore, we always ensure that I've gone to the correct place. Over a period of time, you may not use it. So let's begin with this first part of the story. This is the simplest block one can give, a very commonly given block and pretty useful as a general purpose. Not useful as a diagnostic, but therapeutically, yes. This is your sacral for hiatus. It can be very long hiatus or it can be very short hiatus. On either side, this is actually the lamina, and this is a lamina genetically. And this is your lateral mass. This is equivalent to facet joint. So these are two buttons on either side. You can see here, these two buttons. And the sacrum in female is generally more curved compared to male, which is a straight line. So how do you localize that? This is what you will find the hiatus. These are two cornu, and these two are palpable. What we do is we put our thumb here. Even in a fairly obese patient, not excessively obese, you are able to palpate this part with your thumb. And once you do that, you can palpate this cornu more clearly. See this, I have put my thumb here in that ditch, in that khadda. Then I have palpated with other hands, 2 fingers, this area. I have palpated to cornu, and the tip of my surface here is the point of entry for me to go. So this is how I would localize the whole thing clinically. We will use needle which has a rounded shoulder called as a 2-His needle. Generally prefer 18 or 20 gauge, not too thin, because if it's a too thin a needle, you may not be able to see it on C-arm, especially in the lateral view. When you have a large exposure, large voltage given, you may not be able to see your needle clearly. So that is where you will go. This is how you enter at about 45 degree, go and touch the posterior surface of S4, S5, then tilt the needle downwards, like you can see here. This is the needle which has gone touched. I have taken down the needle, and then you push the needle further inside. After you reach a particular area, this might get stuck up here. This might get stuck up here. So you rotate the needle axially 180 degree so that the rounded bevel, which was down here, the rounded bevel now faces up, and you can still go comfortably inside. This is how your needle will be placed, and then you start injecting. Please remember that all these foramina will leak out. This epidural space is connected to the outside, and therefore it will always leak out. It's a very simple to perform thing, and it's commonly given. I want you to note one thing here. Very often it is given thinking that it produces adhesiolysis or a neurolysis. Well, it's a myth. The epidural space freely communicates, and all the fluid that you give always leaks out everywhere through the whole spine. So you cannot truly raise epidural pressure good enough to do anything. All of you, all those who have done surgery will realize that the root adhesions need a physical detachment, physical cutting, physical separation by using dissectors. It cannot happen by fluid pressure. All that it does is opens the available separation, which is between two elements and periphery. Well, talking about transforaminal clamp, I want you to first understand what is the purpose of foraminal block. It's basically to abort the neural inflammation. Rather than mechanical deformation and compression, is the neural inflammation, which is far more important when it comes to radiculopathy. And when the neural nerve root is inflamed due to either mechanical irritation or chemical irritation, there is intraneural inflammation, which over a period of time leads to ischemia, edema, fibrosis, and even demyelination. It leads to the functional changes. We are commonly hooked on to the loss of neurofunction, which is sensory deficit and muscle weakness. What we don't pay attention to it is hyperexcitability of the DRG thereafter. And this DRG keeps on sending ectopic impulses out of nothing. When these impulses go to the brain perceives that the pain is being produced, radicular pain is going on in the absence of any pathology in a true sense. Now, this is something we want to abort. This is something we want to avoid. And that is the purpose of radicular injection. Like we said, below the root is a safer area, and this is called as a Cambin strangle. Go and touch this area and inject now further. We usually use a needle which is a 21, 22 gauge, thinner one, more comfortable, but you can't see it to the on X-ray. Its hub is plastic, therefore it's radiolucent. Bevel is 45 degree. Normal length is 89 millimeter. But for obese people, you may need 4-inch or even longer needle. You may have to ask for it specially. So this is, you go and touch this margin here, then you angulate your needle inside. In AP view, again you check it that is just past medial to this, and then you come here and start injecting. You can see the dye spreading up and down. It will go along the root sleeves. It will go underneath the pedicle. Watch this now. It's going around the medial side of the pedicle, along the lower root out. And if you can see that, it's called as the radiculogram. Well, the 3 drugs generally are used, some local anesthetic, some corticosteroid, and some pure analgesics. This may be needed for immediate pain relief when the root is inflamed. What they do is, these both drugs, they desensitize the nociceptor. They suppress the inflammation, especially steroids, and of course they give pain relief. Now, steroids are important because they prevent adhesions and scarring of an inflamed root with the periphery. They would facilitate conductions. They stabilize the membrane potential. All these are neurophysiologically confirmed scientific facts, and they suppress the ectopic discharges I talked about. All that put together, pain, paresthesia, function are improved, and the epidural steroids will accelerate pain relief, allow for return to the function quickly. We generally use 2 ml, that's 80 milligram of methylprednisolone. For acute severe pain, we might add some tramadol to it. We have sometimes given Sublaminar also, and volume is generally as per the need is required. Generally excellent short-term pain relief over a period of 6 to 12 weeks. Long-term benefits, we have patients who have gone for over 2 years, 5 years, 10 years, just after 1 or 2 injections. Efficacy of root blocks is far more pronounced if the nerve root pain is discogenic compared to the foraminal pain. And all these pain-free period must be used for very aggressive rehabilitation. Contraindications, the usual, uncontrolled diabetes, etc., blood thinners. But beware of a progressive neurodeficit and cauda equina. In these cases, we would be cautious to inject because we would like to watch these people for any development and intervene surgically as soon as it's required. There are some people, this is the last slide, there are some people who would get exacerbation of local as well as radicular pain after injections. About 4% patients have in the first 24 hours increases pain, and that pain will generally subside in about 48 hours time. The mechanism exactly is not known, but injecting under the tight structures is probably the source of trouble. Well, thank you very much.
Thank you, sir. So, do we have any questions for Dr. VDI, sir?
Sir, Dr. Apaji here, sir.
Yeah,
Can I ask
go
a
on.
question? Sir, there is lots of this literature about the powdered form of steroid, either depametol or ketocot, causing due reaction and patient developing adhesions infection. What is your take on that, sir?
You see, the adhesions and those things are inherently related to the inflammatory process within the nerve root, including inflammation of neurulema. If the neurulema gets involved, become hyperemic, etc., fibroblastic activities comes there. They're not related to the reaction produced by the thing. There's one objection taken that a particular brand, Depomedrol, has some small preservative in it. But if you look at the whole thing put together, everything put together, taking into consideration the local steroids, the dilutants and other, etc., the total concentration of that preservative in the drugs is very, 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 very small. And again, that preservative does not last long. It's the crystals which last long and eventually keep working. We have been using this modality for last over 35 years, and we haven't had patients who have got suffering related directly to the injectables or injections. So I don't think, one thing is there, because it is a kind of possibility, the drug manufacturers have to mention it in their literature. And therefore, the literature which comes with the vial will always mention that. Now, looking at that, people get hyper. And somebody even fought with me. He wanted to sue me in the court, but he didn't.
Oh.
Just because the literature said, you know, that वो चिट्ठी आता है ना बक्से में, बॉक्स में, vial box.
Yeah, yes, sir. Yeah.
So, but it doesn't. I think the basic root inflammation and inflammation of the periphery
is the root cause for the additions.
Yeah.
Okay, sir.
They are the cause for that.
Yes, sir. Yeah, actually, that's what I used to tell all the people who talk about additions, that steroid actually causes atrophy. It will not cause fibrosis, and it is anti-inflammatory. It will not cause additions. In fact, for scar additions, they give steroids to reduce the additions in the abdominal also, like abdominal surgery in laparoscopy.
Yeah.
Once they release the additions, they inject steroids to reduce additions.
Yeah. In fact, I'll tell you, I have operated upon patients who have received epidural steroids, including Depomedrol, because they had no relief after, say, week or 10 days or 20 days or 1 month or 2 months. And I have seen those crystals are very quietly sitting there. Many have disappeared. Few are sitting there, but root is not particularly differently involved. I've explored these patients, some my own and many others who have had no relief, increased pain, therefore gone down, and have seen this inside. They are not related to the Sublaminar.
Thank you, sir. Guru had some questions, sir. Guru.
Yeah. So, sir, what complications do you explain to your patients?
I explain everything to them. I tell them that this is an injection which is being given. Even if there is a C-arm, still it's a blind procedure. And we are going to inject something near the nerve root, near your spinal cord. And therefore, there is a possibility that if we puncture the dura, you might get CSF. It might flow for a while. Generally, nothing happens, but we'll have to keep watch on that. Generally, a small little pricking of the nerve root by the needle may produce some pain. If it causes hemorrhage within the nerve sheath, following the patient will have very intense radiculopathy. But all these radiculopathies generally settle down by intravenous Sublaminar, which we can give to these people. There are no major deficit except one patient in all these years who was also a known diabetic. One of my juniors happened to inject directly within the root. The root got totally expanded and inflamed. She developed foot drop. But fortunately, after about 4.5 months, that foot drop started recovering. But for 4 months, she had that difficult situation. And of course, she gave us difficult time.
Sir, in some cases,
what is your take?
Beg your pardon?
Yeah, Guru, can I ask one question? Yes, sir. So, what is your take on radio frequency ablation, which these pain physicians keep doing along the facet, sir?
Okay. Now, pain ablation is killing of those nerve roots. The facet supply doesn't come from the articular surface primarily. It comes around the facet joint and comes posteriorly and supplies that area. All that you have to do is to go and cauterize those. What we do is we often during surgery, if we find that the facet joint is too bad, then what we do is we go and cauterize the lateral part of the capsule of the facet joint. We as a routine don't damage the capsule unless we have done something to the facet joint, like facet fusion or put a screw through the facet per se. But other we try not to damage the facet capsule. And in those cases, at the end of the surgery, if the facet is badly arthrotic, we go and cauterize with a bipolar the whole lateral margin of the capsule, which is nothing else but radio frequency ablation, which is done blindly through a machine. But some people develop neuroma after that.
Yeah. Guru, you can ask one last question.
Yeah,
you have one more minute. Yes.
Sir, some patients after root block, they develop severe pain. So what is your take on that?
That is what I said. My last slide showed only that. Sometimes probably it's a mechanical irritation, poking, pricking. And this you will generally know. At the time of giving, we do not give steroids except in the skin and subcutaneous tissue. Local anesthetics, we don't give in the beginning. When we are introducing needle, it's only the skin and subcutaneous tissue. Near the epidural area, we don't inject local anesthetic. Therefore, if the needle tip has touched the nerve, patient immediately tells us. Such a patient developing radicular pain afterwards is understandable, that probably have mechanically irritated the nerve. But if that hasn't happened, and if the patient has not complained of any pain, and if the patient develops something, probably I may have injected something else which has got edematous, has got swollen, and probably started compressing physically the root from outside. Like say, for example, if there is a disc which is lying underneath the area, if I inject and the disc becomes sort of swollen up with a fluid in it, it might produce compression to the root more than what was existing prior to the injection. But majority of these will settle down.
Okay, so sir, for the want of the time, I think I would like to thank Dr. Vittingarikar sir for an excellent presentation, and every time it's very glad to hear you, sir. Thank you.
My only advice is don't only learn the technique, learn the theory behind it. And please remember, don't brush off things and it's a theoretical. We all practice practicality out of basic sciences whose work people have done in the past. We are standing on their shoulder and doing it. Why are you putting pedicular screws now and depending on them to make the patient walk in the same evening? Because somebody did basic science study for it. Respect that.
Thank you, sir.
So don't only learn, learn how to inject. Don't only learn that.
Thank you, sir. So I would like to call the next speaker, good friend of mine, Dr. Shailesh Adgaonkar. So he is going to show a video on facet blocks and RFA. Shailesh, over to you.
Yeah, thank you, Dr. Gururaj. I think I've sent the video to the committee.
Yeah.
Can you
play the video of Dr. Shailesh?
Hello. I welcome you all for this next topic, which is on lumbar facet block and radiofrequency ablation. These things are very, very common in everyone's practice. We all are aware of the facet joint, what gives the strong back to everyone, the strong neck, and the facet joints are paired diarthrodial articulations between the posterior elements of adjacent vertebrae, also known as the zygo-apophyseal joints. They are formed by the articulation of inferior articular process of the superior vertebra with the superior articular process of the inferior vertebra, and they are typical synovial joints, and there is a synovial membrane, a tough fibrous capsule, as well as the areolar tissue. Whenever we talk about the facet joints, the pain originating from the facet joint, normally when there is a disc which is prolapsed, there is a reduction in disc height, there is a lot of frictional wear occurring at the facetal junction, and that contributes to the hypertrophy, what we call as a facetal arthropathy, which is because of the friction occurring and the buckling of ligamentum, friction of facet, all these things contributing to the pain in the lower back. And we always talk about the facetal wear and facetal pain control. Today's topic, we will be going through the basic understanding about the facet and the diagnostic as well as the therapeutic blocks. In here, we can see the wet facets, and that's the contributory factor of the instability in facet joint, in the synovial joint, and that it itself is characteristic of a lot of movement occurring at the facetal junction. Main reasons facetal joints are covered by the cartilage, surrounded by the ligaments, and lubricated by the synovial fluid. Just like joints, they also become arthritic and painful. The facet joints are richly supplied by the nerve fibers from the medial branch of dorsal ramus or spinal nerve. Also, they have dual supply from the dorsal ramus of the same level as well as the level above. We need to understand this. This is very, very important. The only levels which are supplied by C1, C2, and C3 nerve are the atlantoaxial and C1, C2 joints, basically, which are supplied by the C1, C2, and C3 nerves, respectively. The main mechanism of pain is the irritation of the nerve ending, the medial branch, which contributes to a lot of pain. And when there is the friction occurring at different disc levels, this is where the distribution of facet pain, which is shown in this diagram, the paraspinal, the gluteal region, the trochanteric region, the inner thigh, and the groin. These are the areas of distribution, and the commonest modalities for treating are always conservative options first, then the diagnostic and therapeutic pain blocks, and maybe radiofrequency ablation in cases which are not getting better. Surgery is always the last option in cases where there is not much of a neurological deficit, there is not much of instability, the patient is not significantly disabled. And these are the cases where we have to have a very good understanding about indications of our cases.
That is the most important thing. Pathophysiology, I will say this is all theory, but we should understand that basic degeneration, inflammation, and injury to the facet joints leads to the pain in the joint motion. This pain leads to restriction of movement, and the facetal joint innervation also can result in muscle spasm leading to the back pain. Joint inflammation may cause localized hyperemia, and all these things we have seen in our practice. Mainly diagnostic indications such as back pain, multi-level involvement, also patients who are not getting better with medications, post-laminectomy syndromes, a patient with persistent back pain after a fusion, also the patients with adjacent segment disease leading to back pain. And these are the diagnostic as well as the therapeutic indications for considering the facetal block. Contraindications, infection is the most important, coagulopathy, and the local skin infection as well. Skin inflammation or infection is one of the important things.
Yeah, hello. We are talking about a 55-year-old lady who complains of significant back pain and left-sided leg pain. Her back pain is not settling with a lot of conservative measures, and local orthopods have tried the traction and anti-inflammatory for 2-3 months. She's got significant sitting pain. If you see that this is the lumbar spine X-ray, and we can see some amount of jogger movement, and in the dynamic X-ray we can see the reduction in the foraminal region. That means there is some movement occurring at 4 and 5. When I'm seeing the MRI scan, the MRI scan is showing the disc at L4 and L5, which is probably the contributory factor for this. And definitely this is not a surgical case for us. And a conservative approach has been already done. If you see the axials here, and there is a wet facet sign, also the foraminal disc we can see. This is not a surgical case to us, and what we can do is a facetal block and a transforaminal lumbar block we can do, left-sided foraminal as well as bilateral L. Yeah, this is the basic lumbar spine CM image, and we are doing a L4-5 facet block. We need to identify the L4 and L5 pedicle, and we need to identify the transverse process. Once we realize the area of pedicle, we need to go slightly superior on the lower one where there is a facet joint, and this is the area which we need to mark, and this is what we are marking in this. Yeah, should please just So we are at L5 pedicle, and this is the area of facet. Should please. We need to just mark it, and then we can proceed for doing the facet block. We need to tap the lower third of the facet joint where there is a branch of median nerve.
Yeah, as rightly said.
For L5 pedicle, and this is the marking for 4 pedicle, which we checked it in the CM, and this is the area which we need to consider for the L4-5 facet joint. This is the S1 pedicle which was seen on the CM, and this is the L5-S1 facetal region which we need to confirm before we do the facet block. So we need to tap the lower third of the facet joint for.
Most important is identify the pedicle, and above the pedicle around 2 centimeter is your lower part of the facet joint.
In the exact pain relief, and we need to identify the joint as well. This is a local which we always prefer to put, and
24 gauge needle.
Always aspirate before you do, and it's bilateral. Thank you. Yeah, this is the facet joint which we are seeing in AP and left and right both sides. We will confirm it in lateral. We can always use the dye to extract delineate the margins. Thank you.
We use the 18 gauge needles.
For L5. Please move.
And now we will be using the dye here, the IOA ASSI.
And we are happy so far. Shoot, please. Thank you. AP, please. Yeah, we have confirmed it in AP that these are the two facets, right and left, and the dye is looking exactly where we wanted at the lower third of the facet joint of 4-5. And we'll be putting the medicines now. Yeah, this is the IOA ASSI 300, the dye which we use. We prefer to use the triamcinolone as steroid, and we use 20 mg for one level. And this is the lignocaine. This is 2% what we always prefer mentioned, and we always keep it ready before we inject the medicine. And always we prefer to keep the patient under local sedation with anesthetic backup. Always aspirate before you inject, and most important thing is when you go inside the facet capsule, always play around the area, in and around the capsule area of the facet. That's the key.
She's doing fine, sir.
Dr. Sadre is an anesthetic consultant, and we always prefer to do it under sedation, under anesthesia guidance. Thank you.
And this is the important diagram where we need to understand the medial branch nerve transmits pain from the facet joint, and each facet is connected to medial branch nerves. And this is also called as medial nerve branch block, MBB. We need to understand the SAP and TP junction where we normally prefer to inject. And when we are putting the medicines, we are going inside the capsule as well as we are over the joint as well. So we are splaying it all around. That's how it is done. The therapeutic block. And we are going to the next topic is the radiofrequency ablation, which is next to the facet block. When we already tried the facet block, the patient has got relief for shorter period, and again the patient comes back to you with the similar lower back pain. Normally this is done by the pain specialist in our setup. And this is a procedure where we do it for stopping the nerve conduction with a heat lesion, encouraging the nerves to grow back in a pain-free configuration. It's a minimal invasive procedure performed under fluoroscopy, and the outcomes are temporary to long-lasting relief in pain. The facet, the Z joint with RFA, denervates the medial branch, also to block the sensory input from the facet joint. And this procedure was first done in 1975. The molecular moment in the soft tissue near the tip, the heat is generated and nerve is ablated. This is the important procedure in selective cases, and normally it is done in at least one problem with this is that sometimes the multifidus can have some weakness. We have to be very, very careful about the doses. The sensory stimulation is done at 50 Hertz, and the motor stimulation is done at 2 Hertz. Once the target nerve is confirmed, always prefer to use a local anesthetic splay around this facet joint, and then the heat lesion is created on the nerve for around 80 to 90 seconds. This procedure, this process may be repeated for additional nerves. And most important is exact accurate placement. In AP, you should always confirm the angulation
so that we are hitting the exact transverse plane of the vertebra. In lateral, the needle tip of the electrode is placed across the middle 2/4 of the neck of superior articular process, and this is how it is seen here in the C-arm, and then the current is passed. We have done few cases, and so far we are lucky with short to medium term pain relief with this mainly we have done it in lumbar spine, and these are the different studies. They have tried it in thoracic as well as the cervical spine, and they are the different systematic reviews. Only 3 they are sham control RCTs, 5 out of 6 studies, statistically significant reduction in pain in RFA group. The Dutch RCT, which shows RFA is no better than exercise alone. All these things are going to be there, and this is the literature which is always will talk on both the sides. And sometimes we have had complications like dysesthesias and hyposthesia on lower back. Also some issues with the multifidus, as I spoke. In conclusion, the pain originates from the facet joint, and it's a recognized problem of the facetal gear or instability. There is the procedure of choice is always the conservative approach, then the pain blocks. Facet blocks are normally done for identifying the exact diagnosis. In selective cases, we do for therapeutic purposes, and radio frequencies, additional adjunct in patients who are not suitable for surgery, who are not getting better with medications and facetal block, and it's always kept as the last option in most of the cases. Thank you very much for patient hearing. Thank you.
Thank you, Shailesh, for excellent presentation. So, Appaji, do we have any questions for Shailesh?
Shailesh?
Yes, sir.
Why don't you get into the joint? You are injecting outside the capsule.
No, we inject inside the joint as well as we splay around the capsule, both. We go inside the joint.
The so-called facetogram you showed was a picture of a leaked out, that an extra facetal spread of the dye.
Yeah, correct, sir. But
that's
we
the extra facetal spread of the dye.
Yeah,
because it's a very typical look, which is much different than this one.
Yeah, no, I agree. But we always prefer to go inside the joint as well as above. Basically.
But you don't seem to be doing oblique views. How would you know you're inside the joint?
So the now basically, sir, I think the feel is very important. Now we are doing it for a good some time, around 15-16 years. I'm doing this. So I think the feel when you check it in AP and you are going basically the cervical and lumbar facet, we need to understand we are doing slightly different in lumbar. When you are doing in AP and you are putting the needle little oblique, I think you are going on the joint. And I always prefer that SAP and transverse process, that angulation where we go on the lower surface of that joint.
After you have finalized to put the needle, turn the camera to see whether you are intra-articular. Anyhow, you are using C-arm anyhow.
Yeah.
So after you have finalized that this is the spot of injection, rotate the C-arm 45 degrees and check on it.
Yes. That can be done, sir, surely.
So, I think there are no more questions. Thank you, Shailesh.
Thank you, everyone. Thank you.
Thank you, Shailesh. Yeah. So now I would like to invite Dr. Tarush Rustagi for his video lecture on sacroiliac joint block and biopsy. Tarush, over to you.
Good afternoon. I'll be speaking on the topic of sacroiliac joint block or biopsy. My name is Tarush Rustagi. I'm a practicing spine surgeon in New Delhi. And I would really like to thank the organizers for giving me this opportunity. Joint as a source of pain can broadly be divided into two categories: traumatic and non-traumatic. While most of the patients with sacroiliac joint in our country are non-traumatic, it's often by a fall on a buttock, road traffic accident, or prolonged continuous heavy lift. Non-traumatic causes constitute idiopathic causes where no reason is found, which forms an significant amount of these patients. Osteoporotic fractures, inflammatory arthropathy, prior lumbar fusion is something that we are seeing more often after spine surgeries. Scoliosis, postpartum vaginal delivery is one of the common causes because of the relaxation of the sacroiliac joint ligaments, and of course infections and tumors. Sacroiliac joint influenced by mechanical stress is something which is being recognized more commonly after the fusion of the last lumbar L5 and L5, and various studies by Ha and Ivanov have highlighted this important concept. The prevalence of sacroiliac joint pain has been studied by numerous studies, and it has been found to be a significant component causing low back pain in up to 20 to 25% of the patients. Why we need to look at the SI joint? It is something that one must be concerned about. Low back pain examination often excludes looking at sacroiliac joint. Sacroiliac joint is often misdiagnosed and not even considered, and we will see certain situations where it can mimic a lumbar disc herniation, and often the surgery is done wrong. And spine surgeons and orthopedic surgeons are not trained enough to look at sacroiliac joint, considering that this joint does not move and cannot cause pain, unlike a knee joint. The patterns of sacroiliac joint pain is very, very intriguing, and it can be anywhere. It can cause low back pain below the level of L5. It can cause buttock pain, pelvic pain, groin pain. It can also be associated with poor sleep habits, unilateral leg instability, which is often the patient complains of difficulty in climbing stairs, sitting issues, and occasionally lower extremity pain. And these are some of the aggravating and relieving factors which are often used to test these. We will look at it in the further slide, where the provocation test can be used to diagnose the sacroiliac joint. So certain transitional movements, unilateral leg wearing, and pain when stationary are typical examples causing sacroiliac joint dysfunction. And some of the key pointers one must keep in mind while diagnosing sacroiliac joint are the pain is never midline. It is always below L5. It is at or caudal to the PSIS. It is occasionally can be associated with posterior and lateral thigh pain. And 14 finger sign is something which is pathognomic of sacroiliac joint, which we'll see ahead. And this is a very interesting diagram. If we look at the first figure and the third figure, we can see that the pattern of pain is almost similar. It is almost like a radiating pain of a disc herniation, which starts from the back and goes down all the way into the leg. The only thing that is different is the origin of the pain. So if you look at the first figure, the origin of the pain in disc herniation is higher up. While in sacroiliac joint pain, the referred pain is actually starts below near the dimple of Venus, so as to say. And this is the 14 finger sign, which was described by Fortin in 1997. It was quite pathognomic in clinical practice, where the patient is able to localize with one finger where exactly is the pain. It is within 1 centimeter of the PSIS, and it is consistent over 2 exams. And these are some of the tests which are very, very useful in diagnostic sacroiliac joint. These are provocation tests, and they are based on either distraction or compression across the sacroiliac joint. And to diagnose a sacroiliac joint dysfunction, one must be able to demonstrate a positive 3 out of 5 thigh thrust compression Ganslin-Faber distraction test, and one of the 3 positive tests must be thigh thrust or compression test. So when do you consider doing a sacroiliac joint injection? So if you have a positive history, if you have a positive examination, and if you have a positive provocation test, these are good enough scenarios for you to consider a sacroiliac joint injection. And in fact, the American Academy of Pain also shows that if you are able to demonstrate a sacroiliac issue on your history and physical examination with a positive provocation test, you can take the patient to the OR to do a diagnostic sacroiliac joint injection. It is also important to understand a little bit about the anatomy of the sacroiliac joint. Not only it is the largest joint, axial joint of the body, it is a weight-bearing joint and transmits the weight from the spine onto the pelvis. It has an irregular joint surface with a lot of ligaments and muscles connected, and has a complex nerve innervation, which we'll also see in brief ahead. Here I would like to differentiate between the two scenarios which we can consider. One is a sacroiliac joint injection, as you can see on the left side of the screen, where you inject inside the sacroiliac joint, much like a facet joint injection. On the right side, there is something called a sacroiliac joint block, where you block the pain that is coming from the sacroiliac joint without directly injecting into the sacroiliac joint, but rather denervating or injecting of the nerves that supply the pain from the sacroiliac joint, which we'll see ahead also. So if we look at this diagram carefully, the sacroiliac joint is a huge joint. And as we can see in the blue circle, the top almost 2/3 or almost 60 to 70% of the joint is covered from the dorsal spine by the overhang of the ilium. So in order to put a needle into the sacroiliac joint in the above 2/3 region, it is difficult. While the area which is accessible is the lower 1/3 or 1/4 of the sacroiliac joint, which can be accessible by placing a needle inside the joint. So in order to do a sacroiliac joint injection, there are certain things which are critical. One is patience, because every patient is different and no two sacroiliac joints are similar. So it is very difficult to pinpoint of placing the C-arm in a fixed angle for all the patients, since the anatomy is variable. And typically the tilt of the C-arm for a regular sacroiliac joint injection involves 20 to 25 degrees of cephalic tilt. So you tilt the C-arm around 20 to 25 degrees, and you have to contralateral tilt the C-arm to around 15 to 20 degrees. And the idea is, as we can see in the bottom right figure, as marked by the red circle, you should be able to differentiate between the lateral and the medial sacroiliac joint line in the inferior aspect. That is where exactly you place the needle. So this is followed by a placement of the needle within the joint and injection of the dye, which should spread along the sacroiliac joint. There are certain more techniques which have been described. One is the posterior-anterior view and the classical oblique view. Posterior-anterior view basically does not involve rainbowing the C-arm. And as we can see in the bottom part of the image, you will be able to see two images of the sacroiliac joint. So injection typically involves using a 25 gauge or a 22 gauge needle, injecting a little bit of contrast because the volume is not very high, using a little bit of local anesthetic and steroid of your choice, which is usually triamcinolone or decompression. It is also important to understand that the positive sacroiliac joint injection is when the patient responds more than 75% of relief. Anything less than 50%, the test is considered to be negative. And importantly, it should also be able to restore the function of the patient. For example, they should be able to bend, lift, use steps. And often a second injection can be done to rule out any false positive, especially if you are considering a radiofrequency ablation. The second part of the scenario is a sacroiliac joint block, where instead of injecting into the joint, you denervate or inject on the branches of the sensory nerves that supply the sacroiliac joint. These are typically the L5 dorsal rami and the S1 to S3 lateral branches. Now these branches originate from the spinal nerve. They exit the sacral foramen and travel laterally towards the sacroiliac joint. So if you block these nerves by either injection or using a radiofrequency probe at least 9 to 10 positions, you can effectively denervate the sacroiliac joint. As can also be seen in this anatomical diagram, you can see these fine metallic wires which have been placed across the dorsal rami nerves which exit the sacral foramen at S1 on the top left figure, S2 in the bottom figure, and S3 on the top right figure. And the red spots indicate the areas where you can put a radiofrequency probe in order to denervate them. And once you have identified sacroiliac joint as a source of pain, radiofrequency probe is a very effective tool to reduce the pain coming from the sacroiliac joint. There are numerous articles that it is effective in up to say 50 to 90% of the patients, 50 to 90% relief in over 70% of the patients. The key is to identify these patients critically before subjecting them to radiofrequency ablation. So a rough diagnostic algorithm can be you do a history and physical examination, do a provocation test, do a diagnostic injection in order to identify sacroiliac joint as a source of pain. And if the result is positive, that is the patient have more than 75% of the relief, then you can treat them with medications, physical therapy, further injections, radiofrequency denervation, and at times fusion surgery. Sacroiliac joint biopsy is something which we see pretty frequently in clinical practice, and any suspected lesion, whether it's infection, tumor, or inflammatory issues, needs to be biopsied. It can be done either under fluoroscopy or can be done under CT-guided biopsy. For example, this lesion on the right side, as we can see, destruction of the sacroiliac joint was biopsied and came out to be tuberculosis followed by fusion. It is also important to understand the anatomy. If the lesion lies in the top 2/3 of the sacroiliac joint, then the ilium will be overhanging it and the biopsy needle needs to be placed accordingly. And just a small topic on sacroplasty, it is something that is being done more frequently at few centers. I have not done them myself, but it can be an important cause of pain of the sacroiliac joint and the sacrum where there are insufficiency fractures. And on the similar lines to vertebroplasty, cement can be injecting into the sacrum with good pain relief. So in conclusion, sacroiliac joint dysfunction is not rare. One needs to look at it and be cognizant in finding it. Diagnosis is based on clinical examination and doing provocation test. Sacroiliac joint injection is a very useful diagnostic tool. One needs to pay a close attention to the anatomy, and the radiology or the placement of the movement of the C-arm is important. Medial bundle branch block or radiofrequency denervation can be therapeutic once you have identified these patients. And of course, suspected lesions should be biopsied in a very standard fashion. Thank you.
Thank you, Tarun.
Thank you.
Yeah. Tarun, can you hear me?
Yes, I can hear you, Guru.
Okay. So somebody's pulse oximeter I can hear.
Yes.
Okay. Typically, how successful is the SI joint block? Like if a patient you diagnose with a SI joint basically dysfunction and you do a SI joint block, how successful is it? In how many patients you have seen that they do improve?
So you're talking about the radiofrequency ablation?
No, SI joint block per se.
You mean the medial bundle branch block using local anesthetic?
Yeah.
So it works very well. Usually when I am doing an SI joint block, I intend to do a medial bundle branch block rather than injecting into the joint most often than not.
Yes.
And to be honest, I've not done many radiofrequency ablation, except I've done a few in Apollo, where the results are very good after radiofrequency ablation of the SI joints and can last up to 1.5 to 2 years. But again, these nerves have a tendency to recover after radiofrequency ablation only, also. So the pain can come back.
Can I say something here?
Yes, sir.
Sacroiliac joint is the extremely mechanically stressed joint of the body. And it is so strong, the ligaments are so strong, the muscles which cover it are so good, glutea and everything, that if the pain arises, exceptionally 5-10% cases, it is either a collagen disorder or a tuberculosis or infection, but 90% of the time it's a mechanical dysfunction of the joint. And sacroiliac instabilities or sacroiliac hypermobilities are not uncommon. We have seen a large number of cases who have unstable sacroiliac joints, especially after after multiple pregnancies and traumas, etc. Now, these are the ones where after injecting, your pain has gone away, but the mechanical stability doesn't get established, and it does come into picture again after a few days. And therefore, recurrence of pain after sacroiliac joint, whether you give intraarticular or whether you block the medial branch, it's always there. Radio frequency ablation probably may have slightly longer relief because till such time as new nerve fibers are innervating that joint. But I would consider blocking that long-term sensory feedback as something off the track. We are not treating the main cause in the joint. We are treating the result of that. So
Very well put, sir.
yeah, like that. Even when we do facet ablation, we are not treating the facet arthrosis. We are not treating the biomechanical derangements. We are probably just taking away pain transmission. That's about all. It's like in place of a short-acting anesthetic, you have given long-acting anesthetic procedure. That's all. But pain would come back. And all these sensors, nociceptors, plus the local sensors are important for controlling the joint by the muscles. If we remove that feedback, especially proprioception through them by radio frequency, I have a feeling the derangement can get accelerated in the future. I may be wrong, but that's exactly what one would expect.
Sir, what is your take if we remove the sensory feedback? Will we develop a neuropathic joint like a Charcot joint?
Exactly. So that's what I'm saying. So remember one thing, another thing. Facet joint or even sacroiliac joint has multiple supply, not one nerve. Therefore, ablating one nerve may not matter. Even when you do a facet joint ablation, you have supply coming from the upper one. You have supply coming from the lower one. So you have three neural segments supplying that facet joint. And if you just go on the lateral side and do one thing, the supply coming from the top is still there, intact. Supply coming from below is still there. So if you want to do any radiofrequency ablation, you must do what is called 3/4 circle ablation around the facet joint, superiorly, laterally, and inferiorly. Only then it can be really truly get denervated. Same thing about sacroiliac. You've got to take care of superior gluteal branches which will come down and the branches from the posterior MI of 1, 2, 3, 4.
Thank you, sir. I think with this,
very well put, sir.
We come to the end of the session. Tarush very well demonstrated video and talk.
Tarush, very well said.
Guru, you want to
very well presented.
Yeah.
Thank you very
Guru,
much.
you
Thank you.
Want to conclude the session?
Yes. So this brings the end to today's basic spine workshop of Association of Spine Surgeons of India in association with Indian Orthopaedic Association. So I would like to thank Dr. R.C. Meena sir and the ASSI for giving us this opportunity to hold this. And I would like to thank all the faculty who spared their time and took efforts to record all these videos and presentations and send it to us so that we can be on time. And I actually extend my thanks to all the faculty who participated in discussion, especially Dr. V.T. Ingadalekar sir. It's always pleasure to listen to you, sir. Thank you. And this was a huge success today. I came to know that because we had sent invitation to basically Asia Pacific Spine Society also. So we had attendees attending from all over Asia today in this workshop. So this workshop has been a great success. So I would like to again invite you all tomorrow at same time for an advanced spine workshop. and see you there.
Guru,
thank you.
Guru, any idea how many members have registered today for the workshop?
Sir, actually, it was in OrthoTV. At one point in time, we had 1,600 visits.
That's a good number. Good number.
Yes, sir. Yes, sir. So we had 1,600 visits. Almost like 230 international delegates were there from African countries, from Asia Pacific countries. So it was a good attendance, sir.
Thank you. It's a matter of happiness for ASSI that ASSI has that reputation all over the world.
Thank you, sir. And at the last, I would like to thank Sai Jot. He was there from morning till now. I think he's still there. And he did all the hard work behind the scenes. So thank you, Sai. And good evening to one and all. Thank you. Appaji, you want to say something?
Thank you all. Thanks for the thank you all. Thanks for the opportunity. Especially thanks to Dr. Gautam Zaveri, Rupinder, and Guru. You've been running the show since morning, and also Sanjay and other people who called everybody, got all the recordings on time, and I think we have finished on time for a change, and we have done a good job. Thanks, Guru. See you all, and tomorrow is the advanced spine workshop starting at 8:30. Again, 4 sessions of 2 hours each till 5 o'clock. See you all tomorrow.
Thank you.
Bye-bye.
Thank you. Thank you. Thank you.